So hi everyone, a very good evening to all of you. I hope your preparation is going good. So just let me know in the chat box if I'm audible and visible to all. A very good evening everyone. So welcome to the LRR session of psychiatry today, and in this session we'll discuss some of the important points, important topics of psychiatry. We'll also talk about important PYQs, and we'll also discuss very importantly which I call the FQs, that is future questions. So we'll discuss some questions which can come as new questions in the exam as well. Also I'll talk about some updates in the end that may also come as new questions. And don't worry about the PDF will be available in the PrepLadder app, so you can also see the PDF after the session as well. So again, very good evening. So let's start today's session, and before starting the session, this is a very important slide which I want to show you all. Nothing is impossible. So we have roughly 30 days, a month for the exam. In fact, the word impossible itself says I am possible. So everything is about attitude. How you pursue these 30 days. What is your attitude? You may say, some may say, sir, we have only 30 days, and some of us may say, sir, we have 30 days. So see, everything would depend on the attitude which we carry in these 30 days or in this month. So let's start with the first topic. So I'll discuss psychiatry topic wise so that we are able to understand all those important points. So the first topic which will start is the MSC. What is MSC? Again, a very important topic. MSC is mental status examination, how we assess any patient who is having psychiatric illness. Again, I'll say, nearly 1 or 2 questions in each exam we are getting from this topic of MSC. So it's a very important topic. And in fact, we are getting around 8 to 10 questions of psychiatry in each exam. So again, we are expecting somewhat a similar amount of question this time as well. So see this question, everyone, let's see this question. A 30-year-old male presents with diagnosis of schizophrenia. So the diagnosis is given. I'll also try to highlight some keywords. So this is how we should approach these MCQs. Let's try to understand the keywords. Family members report that he doesn't show changes in emotions in any happy or sad event at home. So whether there is any happy event, or there is a sad event, he does not show any changes of emotion. So what is this phenomenon known as? So what is this phenomenon known as? You have to tell me what is the false statement. See, this is very important. Don't miss out on these words. They are asking false statement. Very good. It is affective flattening. In fact, it is a negative symptom of schizophrenia. This was a PYQ which was asked, in one of the FMGE exam. That affective flattening, it is a negative symptom. It is associated with, yes, decrease in dopamine in the mesocortical tract. So we'll discuss certain dopamine tracts related with schizophrenia. Is it labile affect? No, it is not labile affect. So the right answer here, we have to choose the incorrect statement is, the false statement is option number D. Very good. So we are talking about a very important phenomena, that is affect. So what is affect? Affect is expression of emotions. Our emotions are expressed in our face, in our body language. So let's discuss a very important slide. Let's discuss certain abnormalities of affect. So in psychiatry, I always say, Shakespeare ne to kaha hai what's there in the name, but I always say names are very important in psychiatry. You just remember the name and you'll understand the concept. So what is this first important abnormality we'll discuss? Flat affect, also sometimes referred to as blunt affect, flat or blunt affect. See, when we do an ECG, you see a lot of such waves. How is the ECG of a person who is dead? It's a straight, it's a flat line. So this is the meaning of flat affect. That is, there is no change in emotion, as if the emotions are dead. So this is the meaning of flat affect. It's a negative symptom of schizophrenia. So yes, correct. It is seen in which condition? It is seen in schizophrenia. Now, a very important opposite phenomena you can remember is labile affect. What is the meaning of labile? Labile ka matlab hai something which is rapidly changing. So there is rapid and abrupt changes in emotion. You can remember it like this. So this is labile affect or lability. So there is rapid abrupt changes in emotion. So you may get another question that a patient is laughing and he's suddenly starts crying. He's laughing and suddenly starts crying without any reason. So what is this? This is labile affect. Again, can you tell me where do you see lability? Can anybody tell me 2 important conditions I want you to remember? Tell me where we see labile affect. 2 conditions, very good. One is mania. You call it mania or bipolar disorder. We'll take both the answer. Yes, it is mania, and another is organic mental disorder. Very good. Let's also discuss 2 other abnormalities. One is inappropriate affect. So what do you mean by inappropriate? Here, that means ki affect is not appropriate to the situation. For example, a person goes to a funeral, everybody is very sad, a family member has died, he goes to a funeral, and he sees the dead body and he starts laughing. So this is inappropriate affect. Then what is incongruent? Congruent means to match, match karna. Incongruent means here the affect is not matching with what? It is not matching with the mood or the thought. For example, suppose you ask a patient, how is your mood? The patient says, sir, my mood is very sad. My mood is very sad. So can you appreciate यहाँ पे patient का mood कैसा है? He is reporting mood, he is feeling sad from within. But उसका affect कैसा है? It is very happy. So can you see here the affect and the thought or the mood is not matching. So this is incongruent affect. Again remember, can you tell me where do we see inappropriate incongruent affect? These can again be seen in conditions like schizophrenia. So again a very important topic. I am trying to tell you certain clinical scenarios also, because so many times we are seeing now that they are asking such clinical questions. So let's discuss the second question. It's a very important question. Please remember this topic. So see this. Match the types of delusions with their correct description. So on one side we have mentioned the types of delusion and you have to match with the description. So tell me, delusion of grandeur. What is delusion of grandeur? Very good. It is a belief that one is rich, grandiosity. What is delusion of persecution? Persecution का मतलब है to harm or to kill. Very good. So belief that someone is planning to harm him or kill him. Nihilistic delusion. What is delusion of nihilism? Here the person believes that the world is going to end, or I am dead, family members are dead. So such beliefs. So this is also known as delusion of negation. In fact, the last option, see this, delusion of influence, it was asked in one of the PYQs in FMGE exam. Here, as the name suggests, patient believe that his thoughts or actions are controlled by others. So what is the right answer? The right answer is option number A. So please see this. Now tell me, we will discuss delusion, a very important topic. Nearly in every exam you will see questions from delusion. It is disorder of what? It is disorder of thought. This is again a PYQ. Can you tell me, we divide the disorders of thought into 4 domains. Tell me it's a disorder of flow, content, form or possession. So quickly tell me, we'll discuss all these delusions. Don't worry. Delusion is a disorder of, it's a disorder of thought. ये पुराना PYQ है. Tell me if they ask under thought, it is a disorder of, very good, it's a disorder of content. So let's talk about the abnormality under content. Very important, one important abnormality आती है, that is delusion. See what is delusion? Delusion, it is a false fixed firm belief. It's a false fixed firm idea or belief. So in the mind of the patient there is a false thought and that thought is fixed, it is firm. And he is holding this thought with extraordinary conviction. No matter whatever evidence you try to give, his thought is not changing. For example, suppose there is a 20-year-old male who is brought to our OPD and he says that my neighbor wants to kill me. So ये convince है कि neighbor मुझे मारना चाहता है. The parents say, sir, neighbors are so sweet people, they cannot kill a mosquito, how will they kill him? But the patient is convinced. Family members say that, sir, we have tried to give him evidence, even the neighbors have tried to convince him, but he is not getting convinced. So this is a characteristic example of a delusion. Now also remember the last statement. Delusions are unexplained by the social cultural background. Can anybody tell me why I am mentioning this last statement? This helps us differentiate delusion with which other important phenomena which we'll discuss. They are unexplained by the social cultural background. See, in certain societies, in certain cultures, there are certain beliefs. For example, some people believe that if a black cat crosses their way, something bad will happen. है ना, काली बिल्ली ने रास्ता काट दिया तो कुछ अपशगुन हो जाएगा. They hold this belief so firmly that they may wait for half an hour, 1 hour. जब तक कोई और cross by नहीं करेगा, they will not cross by. So it is also like a false belief held with extraordinary conviction. But इसको क्या कहते हैं? Very good. This is superstition. So the last line helps us differentiate delusion from superstition. Superstition can be explained by the social cultural background, whereas delusion cannot be explained. I hope this is clear. Many times they are asking such questions of definition. So please be very careful when they ask such questions. So let's talk about various types of delusion. Also remember, delusion is a psychotic symptom. So it can be seen in various psychotic disorders like schizophrenia. It can also be seen in other conditions. So let's talk about certain delusions. So let's just again revise. A person says somebody wants to kill me or somebody wants to harm me. Please remember, it is delusion of persecution. Now delusion of persecution not necessarily always mean to kill. This is the PYQ again in FMGE exam. A 16-year-old girl thinks that the school principal along with the teachers want to fail her in the exam. So she thinks somebody wants to harm her. Again, this is an example of delusion of persecution. patient believe that people are talking about him or they're spying on him. So patient is walking, he thinks that two strangers standing very far from him, they are talking about him, or patient says that somebody is spying on me. What is this? So can you appreciate यहाँ पे क्या हो रहा है? Patient thinks कि मेरे जो आसपास हो रहे things happening around me is in reference to me. तो इसे क्या कहते हैं? Delusion of reference. Now please see, sometimes they may give you some newer examples also. For example, एक patient है, he is watching television and he says that on the news anchor is giving him some secret message. So what is this? Again, it's a false belief and he thinks things around him are happening in reference to him. This is also an example of delusion of reference. So please be very careful. Patient makes such big claims, you know, I am the king of the world, Prime Minister knows me, I made Donald Trump the president of USA again. So such false big claims patient makes, this is known as delusion of grandiosity. Again, we discussed it's a psychotic symptom, can be seen in psychotic disorders. Can you tell me an important mood disorder where you may find this delusion of grandiosity? It can be seen in which condition? Can anybody tell me? It can also be seen in conditions such as in mania. So sometimes mania patient may have psychotic symptom, that is known as mania with psychotic symptoms. Of course, any delusion can be seen, but sometimes you may see this delusion. Patient denies existence of his self. Patient says, sir, I am dead from inside, I don't have a brain, I don't have any intestine. Or he may say that, sir, my loved ones, they are all dead, they are just plank of card. Or he may say, sir, this world is a dead place, ये मरे हुए लोगों की दुनिया है, everybody is just a plank of card. ये कौन सी delusion है? Yes, this is nihilistic delusion or delusion of negation. Again, it can be seen where, see, it is not thought insertion. We will discuss what is thought insertion separately, okay? जब हम discuss करेंगे possession. Right now we are talking about delusion. Again, it can be seen in other conditions also, like in depression. Sometimes patient with depression may also develop this delusion. And what is this phenomena known as? This is known as Cotard syndrome. So remember, what is Cotard syndrome? Depression with delusion of nihilism. It's a very old question that Cotard syndrome is delusion of persecution, reference, grandiosity or nihilism. Now let me discuss one question which was asked in one of the INI-CT exam. Again, you will see a lot of questions are being interchanged from various exams. The question was that a patient with depression says that I am dead, I don't have a head, what is the point of eating anything? The question was, which delusion is seen here? Options were, one option was A, delusion of nihilism, and option B was Cotard syndrome. Can you tell me what was the answer here? See this question, tell me A or B. Tell me A or B. The question is, patient with depression says, I am dead, I don't have a head, what is the point of eating? Tell me the delusion. Delusion of nihilism or is it Cotard syndrome? See, that was the catch point. You know, please be very careful. A lot of times we see that the last line is very important. All of us understood this concept, but see what they are asking in the question. Which delusion is seen? So here the answer is delusion of nihilism. So please be very careful. Sometimes question may appear very simple, but see what the examiner is actually asking and then answer the question. Okay. So the answer there was delusion of nihilism. Now let's also see some other delusion. What is this delusion known as? Very good. Someone else is in love with the patient. Patient says someone else is in love with me. For example, let us say a 25-year-old female claims that Salman Khan is in love with her. All the movies which he is making is telling her that he is in love with him. Although poor Salman Khan might never have met this patient, but she is claiming this. Can you tell me what is this delusion? So please remember all these names. Yes, it is known as de Clermont syndrome, erotomania or delusion of love. Sometimes they may just ask you what is erotomania. So in the option they may give you de Clermont syndrome or delusion of love. So please remember these names, very important. Delusion is a very important topic. Another delusion, patient thinks that my partner, my husband, my wife, he is having an affair. Everybody is trying to convince the person otherwise, but he is not getting convinced. Ye kaun si delusion hai? Again, it has multiple names. So tell me the names, very important. Very good. It is known as Othello syndrome, also known as delusion of infidelity. So infidelity ka matlab hi yahi hai that my partner or spouse is having an affair or cheating. Also known as morbid jealousy. So again, it is a psychotic symptom, can be seen in psychotic disorders. It can also be seen with a very important substance. So can you tell me which substance I am talking about? The patient is consuming which substance? This may be asked. Options are cannabis, cocaine, amphetamine, alcohol. What is the substance? What is the substance? Very good. So please remember, sometimes we see that a patient consuming alcohol for a long time may develop this delusion. So in the end, they may just ask you the substance. So please be very careful. Very good. Let's see the next question. A 34-year-old male admitted in the hospital with a diagnosis of schizophrenia. So again, they are giving you the diagnosis. He claims that his wife present is not his wife but a hospital staff who wants to kill him and even tried it 2 days before. He continues to claim it despite being convinced otherwise. What is the most likely diagnosis? So can you appreciate here also he is having a false fixed firm belief held with extraordinary conviction. So here again they are asking about delusion. So what is the right answer? Very good. It is not delusion of infidelity, it is not delusion of love. So out of Capgras or Fregoli, I am very happy, yes, it is Capgras syndrome. So let's discuss delusional misidentification syndrome. See, नाम से ही पता चल रहा है misidentification. The person is not identifying the person correctly. The first very important is Capgras syndrome. See, again I will give you some tricks so that you can just remember it from the name itself. So the name will tell you what is Capgras syndrome. See, just see these alternate letters. So C for close person replaced by stranger. So it is close person replaced by stranger. So this is Capgras syndrome. So patient thinks that somebody closely related to me has been replaced by a stranger. Like in this scenario, can you appreciate, patient ki actual wife has come to meet him. So he may say that, you know, I know you're looking like my wife, but you're not my wife, you're somebody else in disguise. So this is Capgras syndrome. Again, I'll give you one trick. Whenever you get confused, always see with whom the patient is fighting with. Tell me, in Capgras syndrome, he is fighting with a stranger or the close person? Very good. So please remember, C for Capgras, he is fighting C for close person. So this is Capgras syndrome. Now can you tell me one important dementia with which Capgras syndrome may be associated with, which was asked as a question, it's a PYQ from the FMGE exam. Can you tell me which important dementia I am talking about? This question was asked in the exam. Very good. So what is this? Yes, Lewy body disease. Very important. We'll discuss this. Yes, it is one of the supportive features of Lewy body disease. So we'll discuss. Second is Fregoli syndrome. Beta, what is Fregoli syndrome? Remember, it's the opposite. Fregoli syndrome में क्या हो रहा है? यहाँ पे the patient thinks that a familiar person is imposing as a stranger. I'll give you one example. Suppose we have a person, let's say we have a patient, let's call him Mr. Freg. So Mr. Freg is walking and he saw one stranger. Let's call him S1. So he saw one stranger, he said, you're looking like a stranger. I've never met you before. But he says to the stranger, you're not a stranger, you are my wife in disguise. What are you doing here? Go back home, go back home. तो यहाँ पे क्या हो रहा है, पेशेंट को लग रहा है कि a familiar person, in this case his wife, is imposing as a stranger. But actually में this person is actually a stranger only. So ये है Fregoli syndrome. So next time you may be given such scenario. Suppose he goes further and he meets another stranger, let's call S2. So again, sometimes he think that this stranger again is looking like a stranger, but it's not a stranger. Again, he may think that it is my wife in disguise. So he may also think that this familiar person can take multiple appearances. So this is Fregoli syndrome. So again, how would you remember this? See, Capgras syndrome mein he is fighting with the close person. Here in Fregoli, tell me he is fighting with the stranger or he is fighting with the close person? Very good. He is fighting with the stranger. Like in this scenario, he is arguing he is fighting with the stranger, that you are not a stranger, you are a familiar person, okay, who has come in front of me in disguise. So please remember these scenarios. Let's in fact discuss this question which was asked in the last exam. So again, you'll appreciate how important this topic is. A person has false beliefs, or they are telling you that they are discussing about delusion. Even from the option you can see that they are talking about delusion. So what is the false belief of the person? That he has lots of property and he is rich and somebody he knows wants to kill him and take it from him. He appears depressed and physically unwell. Again, when you see depression, again, don't jump to delusion nihilism. In fact, in depression, other delusions can also be seen. So what is the right answer here? Very good. I'm very happy. So please remember, see the question carefully, see the option. Here we know the patient is having delusion of grandeur and delusion of persecution. So the right answer is option A. Very good. Correct. Let's see the next question. Again, I'm also showing you PYQ so that you get an idea how they are asking question. It's in fact a old PYQ in 2019. They had asked this question. A patient says, home is sweet, sweet in diabetes, diabetes urine has smell, smell is hell. What is the symptom? You have to tell me the symptom. So can you tell me what is this symptom? Anybody? Chalo, I'll ease out for you. It is not tangentiality, it is not neologism. Tell me what is the right answer here. Now of course we'll discuss in flight of ideas, we'll discuss that the speed is increased. But here in the question they have not mentioned about speed, but still many of you, in fact most of you, yes, you are saying it is flight of ideas. Yes, very good. Here the answer is flight of ideas. So let's discuss the second abnormality under thought. So we have discussed content, let's now talk about flow or stream of thought. So normally you can appreciate कि जो हमारे thoughts हैं, just like water is flowing in a river, our thoughts also are flowing in our mind. So sometimes problem हो सकती है in this flow. Now sometimes this flow may have very high speed. So patient के mind में thoughts are coming very fast. One thought, second, third, fourth, fifth. तो patient की speech कैसी होगी? It will also be very fast. So let's discuss one important abnormality beta, that is flight of ideas. Again you don't have to mug up. See the name. देखो flight of ideas, नाम से क्या पता चल रहा है that the ideas are on a flight. So here what is happening, if you ask patient a question, the thoughts are coming very fast, so there is increased speed. The patient may say things which may not make much sense and ultimately he may not answer your question. तो हम क्या बोलेंगे, goal is reached or not reached? We will say that the goal is not reached. Now very interestingly, जब आप patient को सुनोगे, when you listen to the patient may say things which are not making much sense, but you will see that his thoughts may be connected. So his thoughts may be connected by chance. For example, patient may speak like this: my name is Virat, I like playing cricket. Cricket is a game of gentlemen. Gentleman is my friend Mukesh. Mukesh smokes cigarette. Cigarette causes cancer. Cancer is my zodiac sign. और ये में से like this, ये मौसम की बारिश, ये बारिश का पानी, ये पानी की बूंदे तुझे ही तो ढूंढे. Something like this. So you'll see one thought is connected by other by chance, and sometimes it may be connected by what is known as clang association or rhyming. So patient may speak like this: Ram can sing, birds have wing, I am the king, phone goes ring ring, the weather is spring, bring 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 bring. So can you appreciate he's saying a lot of things not making much sense, but it is rhyming. So this is clang association. So this is flight of ideas. And can you tell me one important condition in which flight of ideas can be seen? Can you tell me कहाँ मिल सकती है flight of ideas? But it can be seen in conditions such as mania. In fact, we'll discuss in mania one of the letters we'll discuss as a mnemonic F. That F in mania would mean flight of ideas. I hope this is clear to everyone. So I'm showing you the question. Now can you appreciate here, although they have not mentioned the speed, but can you appreciate home is sweet, sweet in diabetes, diabetes urine has smell. So there is some by chance connection, and also smell hell. So there is also some clang association also they mentioned. So this is flight of ideas. I hope this is clear. Very good. Now let's see this question again. This is a recent question. I've been talking about this topic. It is one of the topics we were telling you it may come as a new question, and finally this question was asked. See this question. The question is, a doctor asks a patient about her age. The patient responds, doctor, I am from a village. We were married at a very young age at 12 with my husband who is just 5 years older than me. Then I had 2 kids when I was around 18 or something. Now I am 38 but look like their older sister, doctor. What is the most likely thought disorder displayed here? Can you tell me what is the right answer? Very good. It is not flight of ideas. Also please see this. Sometimes you will see that even in flight of ideas also the patient will speak a lot of things. But can you appreciate, although they have not mentioned the speed, we'll discuss in circumstantiality usually the speed is decreased. The answer here is circumstantiality. But can you appreciate when you see flight of ideas, the words which the patient is saying, the things which he is saying may not make much sense. Here everything is making sense. So this is circumstantiality and it is not tangentiality. We'll know the difference. First let's understand what is circumstantiality. So again, circumstantiality you can remember under flow or stream. Here the speed is reduced. Flight of ideas में increase है, यहाँ पे decrease है. So patient speaks slowly and patient may say unnecessary or trivial information. Can you appreciate in that question? Patient से पूछा age and the patient is giving unnecessary trivial information. Important thing is here the patient answers your question. So the goal is reached. So this is circumstantiality. From A to B, if somebody wants to go, the person may go like this. So this is circumstantiality. Unnecessary trivial information, although it's making sense, and ultimately he will answer the question. While in tangentiality beta we'll discuss, here the goal is not reached. But here in the question, can you appreciate the patient has reached the goal. So it is circumstantiality. Very simple example again, you know, which I always give. If you ask a patient who is your favorite actress, the patient may start like this: Sir, Alia Bhatt acts very well. I have seen all her movies. I was upset for a few days when I heard she is getting married. May God bless her. Even Katrina Kaif is a wonderful actress. I was upset for a few days when I heard she is getting married. May God bless her. Even Kareena Kapoor is a wonderful actress. I have seen so many of her movies. I was upset when I heard she is getting married. May God bless her. But my favorite actress is Kiara Advani. So can you appreciate this is circumstantiality, right? Again, it can be seen in conditions such as schizophrenia, and even in other situations it can be seen. Now let's discuss one more very important abnormality under flow or stream, that is perseveration. But please remember, it can come as a new question. So our FQ topic will discuss perseveration. What is the English meaning of perseveration? Perseveration or to perseverate. But perseveration का मतलब क्या है? To repeat something again and again. So remember, P से perseveration, P से a thought persist beyond the point of relevance. So patient के mind में एक ही thought बार बार repeat हो रहा है, and it is beyond the point of relevance. So they may just ask this question that a patient is answering all the questions with the same words. So this is perseveration. Or they may give you such scenarios. For example, what is your name? Patient says, my name is Mukesh. ये तो correct है. What do you do? My name is Mukesh. Where do you live? My name is Mukesh. What is the name of your wife? My name is Mukesh. Now can you appreciate? देखो, initially this my name is Mukesh ये तो relevant था ना, but this same thought is now persisting beyond the point of relevance. Can you appreciate? As if patient एक ही answer पे stuck हो गया. He is not able to go forward. So it's an abnormality of flow or stream. Is it clear to everyone? Very important. You know, sometimes they may ask such questions also if they want to modify. Suppose a patient says, I want to go home, and he repeats home, home, home. Again, what is this abnormality? I want to go home seems to make sense, but now then he is continuously saying home, 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 home. So again, this seems, you know, in a way it's an abnormality, that is perseveration. So please be very careful if such questions are asked. Very good, है ना? Yes. So now tell me, in which two important conditions it can be seen. This is again very important. Next time they may just ask you the condition. Tell me in the sequence. Beta, yes, we'll differentiate it from equililia. Okay, I hope it is clear. देखो verbigeration में तो क्या हो गया ना, he is speaking just words or you know certain phrases which is not making any sense. But here we are saying that initially, you know, it is making some sense, but it is persisting beyond the point of relevance. But please remember one very important condition if they ask: organic mental disorder. Second, also it can also be seen in schizophrenia. So sometimes, you know, they may give both the options. So please see which is written first. So again, it can be seen in organic mental disorder, and sometimes yes, even in schizophrenia. I hope this is clear. Now let's see this question. Again, it's an interesting question. Try to read the question carefully. So please practice MCQs, because many times we have seen that you know the concept, but the practice is missing. So see this question. A 30-year-old male is admitted in a psychiatric ward for psychotic behavior over the past 8 months. The patient's mother says that his son is speaking things like he knows USA president and patient is the one who actually is running the country. So he is making such claim. When he spoke, his sentences did not always seem to have any connection with each other. He is using terms like pratinate, kit, wit, fitlo, which is not making any sense. He is also claiming that terrorist group is, you know, wants to kill him. He is followed by the terrorist group to kill him. What is the following symptom not seen? You have to tell me which is not seen. Very good. But a neologism we can see, yes, he is using such words. Loosening of association we will discuss. You know, he is saying things which are not making much sense. They are not connected. Delusion of grandiosity है यहाँ पे. Very good. You know, he is claiming such big things. Yes, it is not perseveration. Perseveration is not seen here. Can anybody tell me any other phenomena also? Any other important symptom which is also seen here? Can you tell me? Chalo, let me ask you any other phenomena that you can see here. The terrorist group wants to kill him. Yes, so here again delusion of persecution is also seen. Very good. I hope this is clear now. So please be very careful. So in fact, let's talk about the third abnormality under thought, that is form. See, form का मतलब क्या है? Form means structure or organization. Like this pen which I am holding, it has a form na, it has a structure. Similarly, हमारे जो thoughts हैं, our thoughts, they also have a form. So pick up any of your thought, you will see हमारे हर thought में there will be a start, there will be a middle part, and then there is a end. All our thoughts are logically connected. So this is normal form. When the form is abnormal, beta, what do we call that? Can anybody tell me? When the thought is abnormal, what do we call that? That is known as, remember, formal thought disorder. That is known as formal thought disorder. See the name is telling you it is made up from form, na? So formal thought disorder ka matlab hai the form is abnormal. So normally when the form is normal, we say that the thought is organized. So formal thought disorder ka matlab kya hai? That there is disorganization. There is disorganization. And can you tell me, formal thought disorders can be seen in which conditions? So formal thought disorders in which the thoughts are disorganized, can you tell me it is seen in which condition? It can be seen in condition like schizophrenia. So please remember this. So let's discuss certain abnormalities of form. Again, you don't have to mug up these definitions, just see the name. The first is very good. The first is loosening of association. But what do you mean by loosening of association? The term is telling you जो association था thoughts के बीच में पहले, now that has loosened up. So what does that mean? That there is a break in the logical connection between the thoughts. So a thought which was earlier logically connected, वो logical connection चला गया. So words will make sense. You will say, sir, patient is saying certain things, words will make sense, but sentences don't make any sense. For example, suppose you ask a patient, what will you do if you want to have coffee outside? Normally he will say, sir, I will book a cab, I'll reach cafe, I'll order, I'll drink coffee, I'll pay and come back. So it's a normal thought. So patient may say like this, having loosening of association, sir, I will come back, I will drink coffee, I will reach cafe, I will pay, black umbrella. So can you appreciate यहाँ पे words are making sense but sentences are not making any sense. In fact, now you can appreciate this question which we had discussed. देखो यहाँ पे loosening of association is also a very important differential diagnosis, isn't it? So many times be very careful in the FMGE exam, you will see there are two options which are very similar. But still देखो they have not mentioned speed. Speed अगर लिखा होता तो we would know that speed is increased here while speed is normal here, right? But still, why did we say it is flight of ideas? Because you can see there is some connection, while no such connection is seen in loosening of association. So this is loosening of association. Next time they may just give you an example of loosening of association. Second abnormality is derailment. Now beta, what do you mean by derailment? What is the term derail means? That a train is going on track and suddenly it derails, it gets off track. So this is the meaning of derailment. So derailment का मतलब क्या है? Jumping off the track. It is also known as night move thinking. It is also known as night's move thinking. How does a horse move in the chessboard? It goes straight and suddenly takes a right or left. So this is derailment. Now for example, you ask the same patient, what will you do if you want to have a cup of coffee? The patient may say, sir, I will book a cab, I will reach cafe. So please see, for derailment, the patient is on track for some time and suddenly the patient says, so he's on track for some time and suddenly says, so India versus South Africa test, T20 series is going on. I hope India wins this T20 series, and he goes on this topic. So can you appreciate patient kuch der ke liye is on track and then he changes the track and there is no connection between these two thoughts. So this is derailment or night's move thinking. Next is tangentiality. But what is tangentiality? See this, just see the name. What is the meaning of tangent? So, in school days, teacher would say, draw a tangent to a circle. What is a tangent? It's a line which touches the circle at one point, it goes away and does not return. So this is tangentiality. मतलब patient ने topic touch किया, he touches the topic and he goes away. क्या कभी tangent comes back to the circle? बेटा नहीं. So that means in tangentiality, goal is reached or not reached? Goal is not reached. Now can you appreciate the difference between circumstantiality there and tangentiality? Circumstantiality में he is giving unnecessary trivial information but reaches the goal. यहाँ पे touches the topic and goes away. I hope this is clear to everyone. Next is neologism. Again just see the name. Neologism. Neo means new, logos means word. So just the term is telling you. Patient out of nowhere is saying a new word which is not there in the language known to him. Like in this case, patient is using such terms that is prat, nit, kit, wit, fit, low. Apne you search Google, no such word is there. You open Oxford dictionary, no such word is there. But still the patient is saying, patient may say, sir, this is prat, nit, kit, wit, filto. This pen which I am holding, he has given this pen this name. So again you don't know how this new word has come. It is not present in the language known to the patient. So this is again neologism. So please be very careful. Now what is verbigeration? Verbigeration is senseless repetition. Patient is just repeating certain words. I am, who, ha, going, vanilla. I am hoo-ha going, vanilla. I am going hoo-ha, vanilla. So patient is just having this senseless repetition of words. This is verbigeration. I hope this is clear to everyone. So these are some important formal thought disorders which can be seen. Now let's complete this. So in this, I hope this is clear. The answer is perseveration. Let's complete the abnormalities of thought. So let's discuss the last domain, that is possession. Yes. Talking past the point क्या होता है बेटा? What is talking past the point? Again in form, there are other abnormalities. Talking past the point, talking past the point or verbatim. So what is talking past the point or verbatim? यहाँ पे as the name suggests, the reply of the patient will tell you. So patient ने आपने question पूछा, patient replied something. His answer would tell you that he is talking around that point. So he understood the question, but he is talking around that point. For example, if you ask a person what is the color of grass, you ask color of grass and the patient says red, and the patient says red. Now can you appreciate what is this red telling you? आपने पूछा था question color of grass, so this red is telling me that he understood the question. I am asking a color, but he is talking around that point. So this is talking past the point. I hope this is clear to everyone. But what is the difference? How to differentiate flight of ideas? Like in this case, देखो, that is why I have shown you that question ना. Tell me how would you differentiate? यहाँ पे speed they have not mentioned ना, but still you have differentiated it as flight of ideas, because we know in flight of ideas there is some connection which can be seen, like by chance connection, या clang association, while no, so connection is present here, no connection is present here. So this is how we can differentiate. Yes, I will continue. Yes, what is then Ganser syndrome? Can anybody tell me? So we talked about talking past the point, but it's an old term which sometimes was used, that what is Ganser syndrome? Ganser syndrome का मतलब है a patient having talking past the point seen in prisoners. So initially this talking past the point, it was identified in prisoners. So they gave this term talking past the point. So remember, it is seen, Ganser syndrome is seen in gangsters. But remember, of course, talking past the point can be seen in other population also. But this is a old term which is used, कि Ganser syndrome मतलब talking past the point seen in prisoners. So this is Ganser syndrome. Again, it's a old PYQ. Very good. Let's complete this. Let's talk about now abnormalities of possession. देखो, what do you mean by possession? If I ask you कि in your mind जो thoughts आ रहे हैं, are they your thoughts or your neighbor's thought? You will say, of course sir, these are my thoughts. I possess my thought. So normally we know that we can control our thoughts and we possess our thoughts. But sometimes that may not be the case. So two important abnormalities which I will discuss. One is obsession. Now please be very careful. You know, sometimes in some books it is described under content also. But please remember, for your exams, obsession is an abnormality of possession of thought. Okay. So where we see obsession, we will discuss obsession under OCD. So they may just give you an example of a case of OCD and ask you, it's a problem of flow, content, form या possession. It's an abnormality of possession. So what is an obsession? Here patient has repetitive either thoughts, images or impulses. Patient के mind में बार बार कुछ thoughts या फिर images या कुछ impulses बार बार आ रही हैं. बेटा, what is impulse? What is impulse? Remember, impulse is urge. This was also asked in your exam previously. So we'll discuss, I'll give you a mnemonic to remember the characteristic of obsession when I'll discuss OCD. But remember, obsession is an abnormality of possession. Very good. Second is thought alienation. See, the name is telling you thought alien, thought alienation, also known as passivity of thought. But what do you mean by passivity? Now in psychiatry, whenever you see this term passivity, that means under someone else's control. Under someone else's control. So passivity of thought का मतलब क्या है? My thoughts are under someone else's control. So here three important abnormalities occur. One is thought insertion. See, the name is telling you. Patient says that somebody is putting thoughts in my mind. Patient says, sir, I have a thought that I should go and watch a new movie. But sir, this thought is not mine. Somebody has put this thought in my mind. So ये क्या? Thought insertion. Then what is thought withdrawal? Thought withdrawal का मतलब, sir, somebody is taking away my thoughts. My thoughts are getting withdrawn. And what is thought broadcast? My thoughts are getting broadcasted outside. Very good. Now, sometimes they may ask such question. A patient says that everyone is able to know my thoughts. Suppose they say that patient is saying that everybody is able to know his thoughts. What is this phenomena? Again, it's a phenomenon of thought broadcast. Patient को लगता है that maybe through radio waves or maybe through television my thoughts are getting broadcasted outside. So this is thought broadcast. But please don't confuse that earlier question which I discussed. I discussed one question. In that question, a patient thinks that the news anchor in the television is giving him some secret message. वहाँ पे उसको लगता है that things around him are happening in reference to him. वहाँ पे था, what was the answer? Delusion of reference. यहाँ पे he is saying that my thoughts are getting broadcasted outside. If the patient says my thoughts are getting broadcasted in the television, then you will say it is thought broadcast. I hope this is clear to everyone. Very important. Sometimes such difference can be asked. So they may give both the options. So please be very careful when to say reference, when to say broadcast. Let's see the next question. Again, it's a PYQ. So we have talked about some important abnormalities of thought. Now we will discuss in the MSc some important abnormalities of perception. See this. All are true about pseudo hallucination except, you have to tell me which is not true. Okay, please be very careful when you read such question. They have asked you except. So which is false statement here? Pseudo hallucination. So it's an abnormality of perception. But what is perception? Let's understand. Perception is how we perceive the external environment. You can hear me, you can see things, you can smell things around, you can taste things, and also there is a sense of touch. So this is how we perceive the external environment. So let's talk about, let's talk about two important abnormalities under perception. One is hallucination. But please remember what is hallucination. Hallucination, just like delusion we discussed, it is also a psychotic symptom. So it's an abnormality of perception. So what is hallucination? It's a false perception. So actually there is no perception, actually there is no object, or there is no perception without real object. So there is no real object, but still the person is able to perceive something. For example, person says that in this video, sir, along with you I can see another person also sitting. He is wearing white hat, he is wearing white shirt, or say let us say black shirt, and he has a mustache. Now of course all of you can see only me na, but he is able to see someone else also so clearly that he can even describe it. So this is an example of hallucination. So it's a false perception without real object. Like in this movie, if you've seen this movie, Munna Bhai can see and hear Mahatma Gandhi. We know Mahatma Gandhi is no more with us, but he's able to see it clearly, hear him very clearly. Everybody is trying to convince there is no Mahatma Gandhi, but he's not getting convinced because he says I can experience, I can see and hear him. So this is a classical example of how a patient experiences hallucination. But please remember, hallucination and pseudo hallucination, they are very similar. Both of them have similar characteristic, that both of them are very clear, just like real object. It's very clear, very vivid, independent of patient will. Patient says it is not under my control, and both are without real object. But what is the difference between hallucination and pseudo hallucination? No, I hope you are only seeing me here right now, because only I am present, right? So yes. So tell me the difference. But tell me the difference. Remember, hallucination, it occurs in the outer objective space. The patient says I am seeing it outside, I am experiencing it outside, voices are coming from outside. While pseudo hallucination, they occur in the inner subjective space. Inner space means in the mind space. Patient says, sir, I can see someone in my mind, it is very clear, independent of my will, there is no real object. So this is pseudo hallucination. If he is seeing it outside or hearing it outside, experiencing outside, mein kya hoga? Hallucination. If he is experiencing it in the inner subjective space, then it is pseudo hallucination. I hope this is clear to everyone. So here, now tell me the answer. Yes. So this is a false statement, that it occurs in outer objective space. No, it occurs in the inner subjective space. I hope it is clear to everyone. Acha, also, let's also understand one other abnormality of perception. Beta, what is illusion? Illusion is also a false perception, but of a real object. Yahan pe real object is present. Sometimes we might also have experienced illusion. For example, a person says that he can see a snake under his bed. उसको अपने बेड के नीचे सांप दिखाई दे रहा है. Becomes very fearful, very scared. He shouts. Family members come running in his room. They switch on the lights, and then he see, oh, actually it is a rope. So can you appreciate this snake? It's a false perception, but of a real object. So sometimes they may just give you an example of illusion also. So please be very careful. Just see if it's an abnormality of thought or it's an abnormality of perception, then try to identify. See, delusion, thinking ki problem hai, it's a false thought. Hallucination, is a problem of perception. I hope you will be able to differentiate both these in the exam. Just like we discussed various types of delusion, let's also discuss some types of hallucination. First is auditory hallucination. Beta, auditory means patient is hearing things not heard by others. It could be a bell ringing, a dog barking, or a human voice. It could be anything. Remember, it is the most common hallucination in psychiatric disorders. Which is the most common delusion in psychiatric disorders? Beta, delusion अगर मैं आपसे पूछूं most common कौन सा है? Very good. Most common delusion is delusion of persecution. Please remember, delusion of persecution. Then second is visual hallucination. Please highlight this, very important. I'll show you one interesting question also. Visual hallucination is when patient is seeing something not seen by others. So it could be again any object, it could be an animal or a human. Now we have discussed that hallucination, their psychotic symptoms can be seen in psychotic disorders like schizophrenia, but agar visual hallucination is given, please try to see whether they are talking about any organic mental disorder. So many times we see in organic mental disorder hallucinations can occur, especially visual. So if I ask you in organic mental disorder most common hallucination kaun sa hai, then you can say visual hallucination. Of course, visual hallucination can also occur in other conditions like schizophrenia and other conditions. But remember this very important point. You know, this sometimes is asked in a lot of ways. So please remember this. Next is tactile hallucination. But what do you mean by tactile? Means sense of touch. Also known as formication. What is formication? Patient says that he can feel insects crawling under or over his skin. Usko apne skin ke upar or under the skin he is able to feel insects. It's a sensation na? So this is tactile hallucination. Also known as cocaine bugs or magnum bugs. Why it is known as cocaine bugs? Anybody? It is known as cocaine bugs because it can be seen with cocaine users. A very interesting question. I'll discuss this question again. A patient comes to us with complaint of tachycardia, tachypnea and scratch marks. Which substance he is consuming? Can you tell me which substance it could be? Yes, very good. So these scratch marks are telling you maybe he is having these cocaine bugs or tactile hallucination. So sometimes you may see scratch marks in the physical findings. So please be very careful. Such questions have been asked. Then what is olfactory hallucination? Smell. He is smelling something, you know, which others cannot smell. There is no actual object but he is able to smell something. Gustatory means, you know, taste. So there is no food on his tongue but usko taste aa raha hai. So these are olfactory, gustatory hallucination. Again, of course, they can be seen in condition like schizophrenia. Patient after a road accident had a head injury and he develops olfactory, gustatory hallucination. Can you tell me which area may be affected? Very good. Can you tell me which area may be affected? Very good. In temporal lobe disorders, sometimes patient may develop like epilepsy, temporal lobe epilepsy, temporal lobe trauma. Sometimes patient may experience it. Very good. Now also let's discuss one special hallucination. We'll discuss few special hallucination. One of the special hallucination is reflex hallucination. It is also known as morbid synesthesia. Please remember this name. This name was asked previously in an AIIMS exam. देखो, reflex hallucination. Why I am saying it's a special hallucination? Normally in hallucination we have learned that there is no real object required, but here what is happening, that a normal stimulus in one sensory modality means this normal stimulus ye auditory ho sakta hai, visual or any other modality. So patient experiences a normal stimulus in one sensory modality that produces hallucination in a different modality. Very, very important. So here a real object is producing a stimulus. For example, a patient says, sir, whenever I switch on the radio, so he is turning on the radio, that means you can also hear it. So this real object is in which modality? You will say, sir, ye to auditory stimulus hua na? He is hearing the radio. Whenever I turn on the radio, patient say that I see color in the air. उसको हवा में color दिखाई देते हैं. So ये कौन सी hallucination हुई? You will say it's visual hallucination. So real auditory stimulus ने visual hallucination produce की. Can you appreciate as a reflex? So this is what reflex hallucination. Same question was asked in the FMGE exam. The question was, which of the following substance may be associated with this reflex hallucination? So can you tell me? Yes, hallucinogens like LSD. Very good. Lysergic acid, diethylamide. Very good. So hallucinogen like LSD may be associated with such hallucination. So they may give you such clinical scenarios also. Please be very careful. Let's complete Let's complete the MSc with some of the remaining topics. Next important topic is cognitive functions or higher mental function. Now see this. So we'll discuss how to assess some of the important cognitive functions. One important point, remember, now organic mental disorders have been given new name both in ICD-11 and DSM-5. What is the new name of organic mental disorder? Anybody? It is known as neurocognitive disorders. So they are known as neurocognitive disorders. So now can you appreciate when I'll discuss these cognitive functions, the name is telling you in this neurocognitive disorder. So the name is telling you कि neurocognitive disorders में क्या affect हुए हैं? Cognitive functions. So let's discuss some important cognitive functions. Very good. Beta, we'll discuss some important cognitive functions. One is orientation. First is orientation. Very simple. Orientation का मतलब है awareness of self and surrounding. So all of us right now we are oriented ना. Orientation we check with time, place, person. So all of us know what is the time right now, what is the date, what is the month, what is the year, what is the place right now you are sitting, and who are the people around you. So you are oriented. So this is orientation. Suppose a patient is admitted in the hospital and he says, I am at my home. मैं अपने घर पे हूँ या अपने workplace पे हूँ. So can you tell me he is disoriented? Disorientation is seen. Can you tell me disorientation is seen in which important condition? We'll discuss this condition. D for, remember, disorientation, D for delirium, very important condition. Please remember this, and we know delirium is a organic mental disorder. So please remember, we'll discuss important points about delirium. So you can see disorientation. Second is attention. But what is attention? Don't mug up any definition. In school days, teacher would come in the class and say pay attention. So attention का मतलब है ability to focus on a stimulus. How do we test attention? The important test which you should remember for attention is digit repetition or digit span test. हम patient को कुछ digits देते हैं, we give some numbers to him and we ask the patient to repeat them. If he is able to repeat them, then we say his attention is intact. So you may be asked such questions. In fact, there are two parts. One is digit forward test. In digit forward test, we will give some numbers, let us say 2, 7. तो patient को forward direction में repeat करना. He will say 2, 7. Then I will increase the number. And another is digit backward test. In digit backward test, I will give some numbers. Let us say 3, 8. He has to say 8, 3. He has to repeat in the backward direction, and then I increase the number. So these are tests for attention. But if both digit forward and backward are given in the option, then if you have to choose one test for attention, then you will go with digit forward test will be a better answer for testing attention. Third is concentration. In fact, this was asked in the FMGE exam. It's a PYQ, concentration. Again, don't mug up any definition. But what do you mean by concentration? You know, sometimes you say, sir, after studying for half an hour, I lose my concentration. So concentration का मतलब है sustained attention. So what is concentration? It's sustained attention. How do we test concentration? This was the question which was asked in the exam. 100 minus 7 test. Okay, or serial 7 subtraction test. In 100 minus 7 test, what we do, we tell the patient to subtract 7 out of 100. So जो भी आंसर आएगा, keep on subtracting 7 till you can. Suppose patient says 93, 86, 79, 72 and so on. So if the person is able to do at least 5 times, then we say it is normal. So this was asked that a psychiatrist is doing 100 minus 7 test, what is he assessing? Concentration. Suppose concentration was not given in the option, then you can also say attention, because concentration is nothing but sustained attention. But better answer क्या है? Better answer is concentration. Also, let's discuss how to assess memory. Again, memory we can divide based on the duration into immediate, recent and remote. But what is immediate memory? Immediate memory का मतलब है memory of the past few seconds. So few seconds back जो भी हुआ, if the patient is able to remember, तब हम बोलेंगे कि patient की immediate memory is intact. So please remember that we don't do any separate test. But I'll try to cover some of the important topics. So roughly around 3.5 hours tak we'll take this session so that we are able to cover some of the most important topics, right? So all those tests of attention and concentration, beta, they are also in a way checking the immediate memory. But suppose if they ask you one test, then again you can go with digit forward test. If they ask you one test. Second very important is recent memory. But what is recent memory? Recent memory का मतलब है, very good, memory of the past few minutes, hours or days. Okay, if something happened few minutes, hours or days back and you are able to remember, then we will say ki your recent memory is intact. And what is the test which we do? The test is yes, 24-hour recall method. So we ask something which has happened in the past 24 hours. If he is able to tell us, then we say uski recent memory intact hai. You know, very commonly we ask such question like, what did you had in your last meal? Suppose I ask you, what did you had in your lunch today? So I hope all of you will be able to tell me, you know, sir, I had this, I had this. So that means your recent memory is intact. Now they may ask some new questions also. Suppose they ask this question that a psychiatrist is asking a patient who came to meet you in the morning today. So he is asking some event which has happened recently. So this is, we are assessing what again? Recent memory. I hope this is clear now. So please be very careful. Don't think that they will only ask these, you know, specific questions. They may just give you newer ones also. Now what is remote? Remote का मतलब क्या होता है? Something which is far. So remote means memory of past few months or maybe even years. So how do we assess remote memory? Beta, remote memory we assess by asking personal information. For example, let us say I am asking a 70-year-old male, I am asking what is the name of his school or name of his school friends, name of his wife, children. So I am asking such question, you know, so this is telling me that it's remote memory which I am assessing. So please be very careful. They may just ask questions like this, that psychiatrist is asking something, what is he assessing? So question may be asked like this. Let's now see this question. A psychiatry resident asks a patient similarity between a car and a plane. The patient replies that both have tires and both have windows. Which of the following function is being assessed? Very interesting. Tell me what is the right answer here? Is it abstract thinking, test judgment, insight, or is it remote memory? See, I am sure it is not remote memory. All of us have understood now. Correct. So yes, similarity testing is a test to assess abstract thinking. But abstract का मतलब क्या है? Abstract का मतलब है ability to understand hidden meanings. Hidden meaning समझ पाना या ability to form concept, तो उसे हम बोलते हैं abstract thinking. So there are two important tests which we do for abstract thinking. One is proverb testing, and another is similarity testing. बेटा what is a proverb? Proverb का मतलब क्या होता है? मुहावरा. Suppose I ask you the meaning of this proverb, pen is mightier than sword, है ना? If suppose I ask you the meaning of this proverb, that pen is mightier than sword. कलम की ताकत तलवार की ताकत से ज़्यादा होती है. तो इस proverb का मतलब क्या होता है? Anybody? You will say, sir, this means that knowledge or intelligence is more powerful than muscle, isn't it? So can you appreciate proverbs have a hidden meaning? So if the patient is able to understand this, then we say his abstract thinking is intact. Now what if the patient says, sir, pen is mightier than sword का मतलब है that if I am fighting with someone और मेरे हाथ में there is a pen and other person is holding a sword, तो I will win because I am holding a pen. क्या इसका मतलब ये है? नहीं. तो इसका मतलब है abstract thinking present है या absent है? इसका मतलब है abstract thinking is impaired. Can anybody tell me what is the term we use when abstract thinking is impaired? उसको क्या term हम use करते हैं? Very good. It is known as concrete thinking. But I am trying to give you these examples because nowadays we don't see direct question. They will ask such clinical question कि patient से ये पूछा, ये answer दिया, क्या assess हो रहा है या क्या मिल रहा है. Another test is बेटा, another test is similarity testing. Like in this case, we ask the patient similarity between a car and a plane. So if I ask you, beta, what is the similarity between a car and a plane? Tell me what similarity will you tell me? What is the similarity between car and plane? Tell me. So you will say, sir, both of them are mode of transport, isn't it? So you are able to see the larger picture. You are able to see the functional similarity. But question में patient क्या कह रहा है? Tire हैं दोनों में, windows हैं. So he is not able to see the larger picture, only he is able to see the structural similarity. So again I will say that abstract thinking is impaired. And again remember, abstract thinking may be impaired in conditions like schizophrenia. Okay, I hope this is clear. Now what is judgment? Let's also understand what is judgment. देखो judgment का मतलब क्या है? Like in a courtroom, a judge hear all the evidence and pass a judgment ना, तो judgment का मतलब होता है ability to take right decisions based on the circumstances. Like every day there are certain decisions which we make. Like today you woke up in the morning, thought might have come, arey, it's a very nice day, let's go outside, let's roam around, but one thought came, no, exams are coming, so I should study. So that is telling me that your judgment is intact. So out of all those things you chose to study. So this is judgment. Now what is test judgment? बेटा नाम से ही पता चल रहा है टेस्ट जजमेंट में हम पेशेंट का एक टेस्ट लेते हैं. सो व्हाट वी डू, वी गिव हाइपोथेटिकल, कोई इमेजिनरी सिचुएशन देते हैं पेशेंट को और पेशेंट से पूछते हैं कि इस इमेजिनरी सिचुएशन में व्हाट विल यू डू, व्हाट विल यू डू. तो अब दिस इज द क्वेश्चन विच वी आस्क. सपोज यू नो what we ask, like question like fire problem. Suppose if I ask you all, the neighbor's house catches fire, what will you do? What will you do if the neighbor's house catches fire? Some of us may say, sir, we will call fire brigade, we will try to help the neighbor. So one of the patients says, sir, you know what I will do? I will pour kerosene in the fire. Now tell me, यहाँ पे judgment is intact or impaired? So here you can say, you will say that the judgment is impaired. Again, impaired judgment can be seen in conditions like schizophrenia. I hope this is clear. So next time they may ask such question. A psychiatrist asks a patient, what will you do if a 2-year-old child is crying alone in front of your house? So again उसने एक imaginary situation दिया ना and asking what to do. So he is again assessing test judgment. बेटा lastly let's discuss what is insight. Insight का मतलब क्या होता है? Insight का मतलब है awareness of the illness. Now usually we don't check insight in medical or surgical illness, but in psychiatric illnesses we do check insight also. Sometimes patient says, sir, I don't have any problem, I think my family members have some problem, they are having some issues, but actual problem किसको है? Patient को ही है. So remember, insight may be present, insight may be absent. Can you tell me, out of neurosis, psychosis, usually insight present किस में होता है? Anybody? How do we? So how do we assess? We ask the patient, na, do you think you have any illness, or what? If he says yes, what illness do you think? What could be the reason? So all those things. So tell me, neurosis may usually insight may be present, and conditions like psychosis, schizophrenia is a psychotic illness, na, वहाँ पे insight may be absent. I hope this is clear to everyone. So I've tried to discuss, I've taken some time to discuss MSc because usually you are getting 1 or 2 questions just from the MSc topic. Okay, I hope it is clear. Now before moving on to the disorders, let's discuss some classification. Now we know that the latest classification to make a diagnosis of psychiatric illness, we have 2 classifications like DSM-5 and ICD-11. So they give us the criteria, they give us the duration, and we make a diagnosis. Now there is a old classification which I will discuss. This is very important. If you understood this classification, in a way we will discuss psychiatric disorders in a nutshell and it will be very useful. So see, अर्लियर साइकाइट्रिक डिसऑर्डर्स को हम डिवाइड करते थे ऑर्गेनिक में और फंक्शनल में. जब हम ऑर्गेनिक बोलते हैं, ऑर्गेनिक का मतलब है देयर इज अ विजिबल कॉज, देयर इज अ विजिबल कॉज. फॉर एग्जांपल, सपोज आफ्टर अ हेड इंजरी patient developed some psychiatric symptoms. So you can see the head injury, you do a brain scan, you will see the injury. So you are able to see the cause. Suppose a patient develops hyponatremia, sodium levels go below 130 and he develops some symptoms. So again you can see the cause. So these are known as organic disorders. So we'll discuss disorders like delirium, dementia, they are under organic. Now what is functional? Functional means that there is no visible cause. But please appreciate, I am not saying there is no cause, I am saying the cause is not visible. Usually in the routine investigation we don't find the cause. Like a patient with depression or schizophrenia may come to us, we do routine investigation, we may not find any abnormality. So that is why we call it functional. But remember, nowadays nothing is functional, everything has a cause. Maybe a genetic factors may be there, maybe neurotransmitter level pe there is cause, so there are causes. But earlier that was termed as functional. And functional is further divided, remember, as neurosis and psychosis. So let's discuss this table of neurosis and psychosis. Now you have to tell me, out of neurosis psychosis, beta insight is present where, absent where? Insight कहाँ पे present है, absent कहाँ पे? We have just discussed. In neurosis it is usually present, in psychosis it is absent. Judgment also we have discussed ना, judgment is usually intact in neurosis and it is impaired in psychosis. देखो delusions, hallucination, very interesting. We have been talking about again and again delusions, hallucination, they are psychotic symptoms. So usually they are present in psychosis, absent in neurosis. Also reality testing, देखो reality testing का मतलब है touch with reality, whether the person is able to differentiate क्या real है क्या unreal है. So reality testing usually is intact in neurosis and it is impaired in psychosis. Now give me some examples of neurotic illnesses. Can anybody tell me some examples of neurotic illness? Remember examples like anxiety disorders, very good. we'll discuss even disorders like OCD, even we'll discuss somatoform and related disorders. Even to an extent mood disorder is although discussed separately, but we can discuss mood disorder. Depression has characteristics of neurosis. On the other hand, can you give me some examples of psychotic illnesses? Very good, I'm very happy. Yes, all of you are giving right answers. Schizophrenia. Schizophrenia, again and again we have discussed, it's a psychotic illness. Other psychotic illnesses like acute psychosis. Even to an extent we can say mania. You call mania or bipolar disorder, I'll take both the answers. Now please remember, sometimes depression we know can develop delusions, hallucination, and that is termed as psychotic depression. So please remember, please be very careful, sometimes question may be asked like this, ki patient ko depression hai and is fulfilling the criteria of depression, let us say for 5 months, and for 10 days he is having delusions or hallucination. तो वहाँ पे सिर्फ depression नहीं होगा, वहाँ पे answer होगा psychotic depression. So please be very careful. Now see, this depression which was present as a neurotic condition sometimes can move there. So it's an old way of classifying. It's not a very crystal clear classification. But इस classification के benefits क्या है? First of all, what we'll do, in fact any subject which you are studying, try to compartmentalize the topics. So what we'll do, first we'll talk about organic disorders, then we'll talk about psychotic disorders, we'll discuss mood disorder, and we'll discuss neurotic disorders. In the exam, many times if you are able to just see ki it's a neurotic illness or a psychotic illness, you are able to answer the question. And sometimes question may be asked from this table. Suppose if I ask you in a somatoform or related disorder, if I ask you reality testing is intact or impaired, you will say sir it is intact. So many times you may be asked question like this. Sometimes you will see question में आपको 2-3 options नहीं सुनी आपने, but you may know 1 or 2 options, and option may be framed like this. So please be very careful. This is how we are going to discuss. Let's now talk about the disorder. So we'll start with the first disorder, very important topic we'll discuss. See this question. So in the question form I am discussing the topic so that you are able to understand how to approach these questions. A 65-year-old male was admitted for knee replacement surgery. On the second post-operative day in hospital, he started saying irrelevant things and would continue to say that he is at his home. He would appear irritable and would sometimes try to even remove the catheter. Can you tell me what is the likely diagnosis? Very good. Okay, very good. Nearly 8-10 questions we are seeing from psychiatry beta. Can anybody tell me? Yes, the answer is absolutely correct. Can you tell me why you are marking delirium? You have to also tell me the answer why. Why you are saying it is delirium? Haan, some of you are saying C or D, mein very good. So yes, there can be doubts between C and D. Can you tell me why it is D for delirium? Very good. See, देखो, duration is not the right answer, we'll discuss. Let's talk about the neurocognitive disorders or organic mental disorders. So we'll discuss the disorders in this table. First we'll talk about delirium. See, ये neurocognitive disorder है ना, तो यहाँ पे cognitive impairment तो है, but very important for delirium, remember the consciousness is impaired. This is the key point, very important. And in fact, let me give you a trick. Remember this mnemonic A, C, D, C. So if any of these points are given in the question, this is telling you that consciousness, awareness of self and surrounding is impaired. So somewhere in the question they have mentioned there is altered sensorium or there is clouding of consciousness. In the clear sky of consciousness, अब clouds आ गए. Or they may say D for, remember, disorientation, patient is disoriented, or simply they may just use this term beta, confusion. So that is telling you that consciousness impaired hai, answer is delirium. Of course, cognition is also impaired. So yes, cognitive impairment is there. For example, patient may have memory impairment, language impairment may be there, even perceptual abnormality may be there, and other cognitive impairment may be there. Can you tell me which important perceptual abnormality can be seen in these patients? Can you tell me which perceptual abnormality you can see in delirium? Anybody? We have discussed just now, visual hallucinations may be seen, other hallucinations can occur, but more common is visual hallucination. So please remember, to make a diagnosis of delirium, consciousness is impaired. Also remember, yes, like in this case, usually delirium may be seen in elderly. Many times we see this is given, patient has undergone some surgery, usually in the second or the third post-operative period they may give you, or they may give you a history of road traffic accident. So they may give you some of such histories. But very important, what is the key point you have made the diagnosis? See, he says he continued to say that he is at his home although he is in hospital. So यहाँ पे disorientation has started, that is why we are calling it as delirium. If that would not have been present, then it could have been acute psychosis. So please be very, very careful here. The answer is, it is delirium. So I have tried to give you some key points, but most important for diagnosing delirium is consciousness is impaired. If that is given, then you think of delirium, otherwise not. Clear? Now also in the assessment, see, when we do test, we will do all the tests to find the cause. Suppose the cause is head injury, we'll try to see, we'll try to find the cause, we'll do various investigation, we'll do brain scan. So we'll try to find the cause and treat it. So very important is we try to find the cause and treat it, because you will see delirium is an emergency, but it is reversible. Now in the test, one important test you can remember is confusion assessment method. Confusion assessment method, CM. It's a very simple test. 4 things we see and we see whether it is delirium or not. So it is again suggesting towards delirium. Now sometimes they may just ask you new question. So this question, when it was asked, suppose I ask you confusion assessment method is used for, options में है, we have mania, depression, schizophrenia and delirium. Tell me what you will choose if you don't know that it is used for delirium. Always see the name. So again I am saying, even if you see new questions beta in psychiatry especially, you will see somewhere in the question, somewhere in the option they have given you hints. So it is used for, yes, it is used for delirium. Now also remember, in the management, but in the treatment, usually patient with delirium may also have delusions, may also have hallucination, even may be very agitated. Sometimes you will see patient is severely agitated, removing cannula, removing catheter, like in that case which we discussed. So in the treatment, if I ask you which drugs will you use? So very important is we can give antipsychotics. So drugs like antipsychotics can be given, especially for these symptoms, and most commonly haloperidol is the most common antipsychotic usually used. It is the most common, and even other drugs like olanzapine and other drugs can be used. Haloperidol we'll discuss, it is a first generation antipsychotic, olanzapine is second generation. In fact this question was asked in your exams. Question था कि delirium की drug of choice क्या है, and one option was haloperidol, one was risperidone. So both are antipsychotic, but they had asked one, then you will go with haloperidol. So please be very careful. Now also benzodiazepine, let's discuss क्या benzodiazepines का कोई role है. Now benzodiazepines, we know they are CNS depressant. Here also the patients, they may have abnormality of consciousness is there. So benzodiazepine, they say it can worsen delirium. But sometimes we may give benzodiazepine in low doses. For example, patient agitated, so we may give benzodiazepine in low doses. Can anybody tell me one important cause of delirium जहाँ पे benzodiazepines are the drug of choice? Can you tell me which important delirium में benzodiazepines are the drug of choice? Usually I am saying that they can even worsen also sometimes. Very good. Alcohol withdrawal delirium, very good. Alcohol withdrawal delirium में the drug of choice is benzodiazepines. What is alcohol withdrawal delirium known as? Very good, all of you are answering it correctly, known as delirium tremens. But both these questions were asked in one exam. एक ही FMGE एग्जाम में दोनों questions थे. एक question था कि delirium की drug of choice क्या है, और एक question था delirium tremens की drug of choice क्या है. So please be very careful, such questions have been asked. Now let me ask you a differential diagnosis. देखो suppose acute onset of symptoms हैं, delirium usually we know acute onset का होता है. Let us say for 5 days there is a history of fever and patient has developed delusions, hallucination. तो यहाँ पे एक differential diagnosis तो you will say delirium है. Can you tell me what other differential diagnosis you can see? What other differential diagnosis could be there? एक तो delirium could be the option. Can you tell me which other differential diagnosis you may think of? Please remember acute psychosis. So a differential diagnosis of delirium is acute psychosis. Please remember, many times you will see fever in the history और आपको लगेगा delirium है. नहीं, fever can also occur in acute psychosis. How to differentiate? Can anybody tell me कैसे differentiate करोगे? Like in this case ना, even acute psychosis is also a possibility. कैसे differentiate करोगे इन दोनों में? Remember in delirium there is impairment of consciousness. There is impairment of consciousness. I hope this is clear to everyone. Very, very important point. Many times you will see questions being asked like this. Clear? Now let's discuss the second neurocognitive disorder, that is dementia. Now see, in dementia what we are saying that the consciousness is intact. So there is no abnormality of consciousness. So ये भी neurocognitive disorder है ना. So क्या impaired है बेटा यहाँ पे? Here cognition is impaired. So only cognition. Yes, but even in other conditions like yes, endocrinal problems maybe delirium can occur. There is some infection can cause delirium. Liver, hepatic encephalopathy can cause delirium. So there are so many causes, isn't it? But you have to identify whether it is delirium. Then we find the cause and we treat it. Okay. Now see this. Let's talk about dementia. In dementia, I am saying that there is cognitive impairment. So let's see what all cognitive impairment you can see. One is amnesia. Beta, what is amnesia? When I say amnesia, what is amnesia? There is impairment of memory. So memory function may be affected. What is aphasia? So they may tell you that patient is not able to use words properly. Family members will tell you कि language impairment है. So aphasia क्या होता है? Language impairment. Praxia का मतलब होता है movement. What is apraxia? Fine movements, fine learned movements patient is not able to do. So they may give you in the history that patient is not able to comb his hair, not able to button unbutton his clothes, not able to tie and untie the shoelaces. So he is not able to do fine movements. Agnosia. What is agnosia? Agnosia is he is not able to identify. He is not able to identify object or even faces. So in final year in CNS examination, we do this in the CNS examination that we show some object and we ask the patient to identify. So in agnosia, patient may not be able to identify object and not be able to identify faces. But what is the term we use when patient is not able to identify faces? Can anybody tell me what is the term? That is known as prosapognosia. And this was again asked in your FMGE exam. So they had asked this term. I'll write this again. So please remember, the person is not able to identify the faces, prosapognosia. So even if you don't remember these terms or you don't know these terms, always see the name. This name is agnosia is there in the name. So prosapognosia, when he is not able to identify the faces. Now see this, I am saying in delirium both consciousness and cognition are impaired, while in dementia I am saying only the cognition is affected. So one very important difference between delirium and dementia, there are so many differences. Like usually delirium has acute onset, dementia usually may have a slow onset, but there are so many differences. One important difference is consciousness is impaired here while it is intact here. Let's complete this table. Last is amnestic syndrome. Now see this, here I am saying out of cognition, name is telling you only memory is impaired. So can you appreciate only memory impairment is there. So that is known as amnestic disorder. So there are so many causes of amnestic disorder. Can be CNS causes like there is trauma, tumor. Systemic causes are also there, so many. Can anybody tell me one important systemic cause of amnestic disorder related with alcohol? Can you tell me related with alcohol, which important condition I am talking about, which I will discuss later on also? Yes, which condition starting with K? We will discuss Korsakoff syndrome. Very good, Korsakoff syndrome. So Korsakoff syndrome I will discuss that there is amnestic disorder, there is amnesia. Yes, there is both anterograde, retrograde, we will discuss. Okay. So Korsakoff syndrome actual cause is not alcohol. Beta, what is the actual cause of Korsakoff syndrome? It is deficiency of vitamin B1, thiamine deficiency. So thiamine deficiency can cause amnestic disorder. So I hope this table is clear to everyone. Very important for your exam, beta, delirium and dementia. Now let's discuss this question. Again, it's a topic which was asked in FMGE exam and subsequently it was repeated in INI-CT. This question was asked in INI-CT, but the topic was asked previously in FMGE exam. So you will see a lot of these topics are getting interchanged. Which of the following are reversible causes of dementia? Dekho, usually we know that dementia is a progressive condition, but there are some reversible causes. So tell me, we'll discuss beta Korsakoff syndrome, I'll discuss even confabulation there. Yes, very good. So normal pressure hydrocephalus, it is reversible. Hyperthyroidism, these are also reversible causes. Vitamin B12 deficiency is also reversible. Lewy body dementia disease, it is irreversible, it is progressive. So here the answer is A, B and D. So let's discuss this table. So there are around 10 to 15% causes of dementia जो कि है reversible. So there may be neurosurgical causes like SDH. But what is SDH? Subdural hemorrhage or hematoma. Patient had a subdural hemorrhage. So they may give you even a brain scan in the question. patient has any brain tumor or abscess, what is NPH? Anybody? It is normal, just like we discussed, normal pressure hydrocephalus. And you may see this triad, Hakim triad or Adams triad, sometimes known as cognitive impairment, gait abnormality, so there is a magnetic gait, and urinary incontinence. So it's a triad. So NPH, how do we treat NPH? It may be treated by ventricular shunting. So these are some neurosurgical causes. You treat the cause and you will see that dementia is reversed. Then there are certain infections like encephalitis, meningitis, deficiencies. Again, various vitamin deficiencies can cause. If they ask you one vitamin deficiency, very important, remember vitamin B12, even niacin, folate, even thiamine deficiency can cause reversible dementia. You treat it and dementia will be reversed. In the metabolic causes, remember some endocrinal abnormalities like hypothyroidism. But if they ask you one endocrinal abnormality, remember hypothyroidism. Even other endocrinal abnormalities like hyperthyroidism, hyperthyroidism can also cause reversible dementia. Any substance patient is consuming, chronic use of substance, patient को dementia हो गया, you tell the patient stop the substance, dementia, even the brain changes जो थे वो reverse हो सकते हैं. Which substance I am talking about? Remember which substance? Alcohol. Yes. So sometimes alcohol can also cause reversible dementia. So this is one way of asking question. They may just ask you direct question. Next time they may just give you a clinical case of dementia and may just ask you what all investigation would you like to do. So they may give you in the option like brain scan, check vitamin B12, check the thyroid function test, or one of the option could be all of the above. So tell me what could be the answer in those cases. So they are trying to see whether you know that there are some reversible causes which you are trying to rule out. Yes, so here the answer would be all. So please be very careful. Such question very good. Such questions can be asked. Now see this. This is a very important topic. Again and again questions have been asked from this topic. So let's try to answer this question. A 70-year-old female is brought by the family members as she is having difficulty in doing activities of daily routine, can't remember events. So again, problems in daily routine activity, this is telling you that there is cognitive impairment. She is also having visual hallucinations and symptoms of rigidity, bradykinesia, some motor symptoms are there. Image below shows finding in the brain. So they have also given you, in fact, such image was also asked in the FMGE exam once. So if you tell me what is the likely diagnosis, very good. The answer here is Lewy body disease, Lewy body dementia, very good. So let's talk about dementia in slightly more detail. So one more classification of dementia we know is cortical and subcortical. But a cortical means the cortex is affecting first and later on maybe the subcortex get affected, while in the subcortical dementia, subcortical grey matter like basal ganglia, such areas are getting affected first and other areas may get affected. Now one important question is they may just ask you the examples. Can you give me some examples of cortical dementia? So cortical dementia ke remember example one is Alzheimer's disease, even pig disease. So Alzheimer's disease is there, even pig disease. Please remember another name of pig disease. Pig disease का दूसरा नाम क्या है? Remember it is also known as frontotemporal dementia. देखो नाम से ही पता चल रहा है ना, frontotemporal. The name is telling you कि frontal and temporal lobes are affected. So it is a cortical dementia. Give me some examples of subcortical dementia, everybody. Some example of subcortical beta like Parkinson disease. देखो Parkinson disease में usually neurology what all symptoms you read like there is tremors, rigidity, bradykinesia. Huntington disease, there may be coriform movement. In multiple sclerosis, Wilson disease, PSP, progressive supranuclear palsy, all these conditions which can also cause subcortical dementia. Usually you see motor symptoms as the initial presentation. So can I say motor system usually is normal here in the beginning, it may get affected later on, while it may be abnormal here in the beginning. Can anybody tell me why we are seeing this? Because you will say, sir, in subcortical dementia areas like basal ganglia they are getting affected and which may affect the movement. So they may give you a clinical picture in which symptoms started with motor symptoms and gradually patient developed cognitive impairment. So they may just ask you what is the likely diagnosis, and one example they might have given you of subcortical dementia. So such clinical question also one has to be very careful, very good. I hope this is clear to everyone, right? Now also tell me, so if I ask you most common overall cause of dementia, what is the most common overall cause? You will say, sir, it is Alzheimer's disease. Can anybody tell me second most common cause of dementia now? Now beta answers have changed, please remember. Ab second kaun sa hai? Please remember it is not vascular dementia, now we say it is Lewy body disease. And vascular dementia, remember, is now the third overall most common cause of dementia. Clear? Now suppose now I ask you beta vascular dementia or Lewy body disease ये कहाँ पे है? Cortical में या subcortical में? What would you say? Tell me, where will you place vascular dementia? Where will you place Lewy body disease? Cortical में या subcortical में? Remember, they are mixed. Mixed का मतलब है both cortex and subcortex may be affected. So please remember, when in fact now I'll discuss some of the features of Lewy body disease. Remember, it may have mixed involvement. So cortical features भी मिलेंगे and you may also get subcortical features. I hope it is clear. Let's now discuss the core features of Lewy body dementia, Lewy body disease. Now earlier there were 3, now there is one more which is added, so that becomes a very important question. How to remember? I'll give you one mnemonic. Suppose Mr. Lewy went for an interview to an organization. So Mr. Lewy गए for an interview and interviewer ने Mr. Lewy से कहा show your CV Mr. CVMR. So let's discuss the core features. But first is there is fluctuating cognition. See, cortex is involved, so there is cognition is affected and it is fluctuating also. So there is variation in attention, alertness. Now see, what is V? I've been talking about this again and again na, कि organic disorders में which hallucination is more common? See, that is visual hallucination. Here, in fact, even in the core feature they mentioned visual hallucination. We discussed that Lewy body disease, it has mixed features. So जब subcortex भी involve होगा, can I say patient will also have motor features of Parkinsonism like tremors, rigidity, bradykinesia? Now R is very important. Please highlight this REM sleep behavior disorder. So REM sleep behavior disorders may also be seen. Now we know that REM may normal. What happens to muscle tone? Beta, what happens to muscle tone when we are in REM stage of sleep? So there is NREM and there is REM stage. When we are in the REM stage of the sleep, what happens to the muscle tone? There is atonia. So our muscles are in a state of paralysis. But in REM sleep behavior disorder, what happens that this atonia is not there. So what happens? So there may be kicking, punching like movement in the sleep. So this is REM sleep behavior disorder. It may be asked as a new question. Please remember, it is also a core feature, or they may just ask you REM sleep behavior disorder is present, which dementia may be present. So again remember, Lewy body disease may be seen. So these were the core features. Now let's also talk about some supportive features. But the supportive features का मतलब है, if these features are present, they are supporting the diagnosis of Lewy body disease. Now one is, these patients have severe neuroleptic sensitivity. Neuroleptic का मतलब antipsychotic. So they may be sensitive to the side effects caused by antipsychotic like EPS. So suppose आपने antipsychotic दिया, patient may develop EPS like this. There is sudden contraction of a group of muscle. What is this EPS? Acute dystonia. So these patients are very sensitive. So if you have to give antipsychotic, try to give low doses, give those antipsychotics which have less, EPS has a less side effect. Patient may also have, history of repetitive falls may be there, syncope may be there, transient loss of consciousness may be there, severe autonomic dysfunction can be present, the blood pressure, pulse rate, these are fluctuating. Systematized delusions can be seen, like patient may have delusion of persecution. Can you tell me which other delusion may also be seen in these patients? We discussed Capgras syndrome. What is Capgras syndrome, which was asked in your exam? Close person replaced by stranger. So can you appreciate how they are asking such questions? And in the patient, from your pathology point of view, this question was in fact asked as a clinical question. So can you appreciate this central core surrounded by a halo? What is this known as? What is this? Name is telling you, Lewy bodies. Yes, they are made up of alpha synuclein. So please remember this. Also, can you tell me where else you can see Lewy bodies? So Lewy bodies pathology में और कहाँ मिल सकते हैं? Yes, very good. Can you tell me where else you can see these Lewy bodies? Even in Parkinson's disease. So they can also be seen in Parkinson's disease. Okay. So in fact, Parkinson's disease is a close differential diagnosis. It's a close differential diagnosis. So Lewy body disease and Parkinson's disease dementia, they are close differential diagnosis of each other. In fact, when they had asked this question, they had given you the diagnosis of Parkinson's disease और पूछा था ये image क्या है. So these were Lewy bodies which were present. So please remember, both of these may have similar features. Now tell me, if I want to ask a slightly more difficult question, so next time I will ask you how will you differentiate Parkinson's disease dementia from Lewy body disease? Can anybody tell me how will you differentiate? I'll give you one hint. Okay, can you tell me? हाँ बेटा, in between we'll see if you want a break, we'll take in between, है ना. अभी मुझे बताओ कि हाउ विल यू डिफरेंशिएट बेटा. वेरी गुड. देखो पार्किंसन डिजीज डिमेंशिया आई डिस्कस सबकॉर्टिकल डिमेंशिया है ना. सो यहाँ पे इट विल बी मोटर सिम्टम्स फर्स्ट एंड लेटर ऑन द पेशेंट विल हैव कॉग्निटिव सिम्टम. इनफैक्ट इन द रिसर्च क्राइटेरिया वी यूज 1 ईयर की मोटर सिम्टम्स स्टार्ट होने के 1 ईयर लेटर ऑन पेशेंट डेवलप्स कॉग्निटिव सिम्टम्स. while in Lewy body disease beta cognitive symptoms will be present in the beginning plus minus motor symptoms. Okay, so motor symptoms may be present in the beginning or may develop later on. I hope this is clear. So next time they may just ask you this as well. So please be very careful. Now let's talk about this. Now very important again, the management. So please be very careful in the management also. You will see a lot of questions, you know, from psychiatry being asked from pharma. So I'll discuss some important psychopharmacology questions also. A 70-year-old male presents with symptoms of difficulty remembering using tools like screwdriver. He makes grammatical mistakes while speaking, and these symptoms are present in the last 2 years. First of all, can you tell me what is the diagnosis here? Beta, can you tell me what is the diagnosis here? Very good, all of you are answering it correctly. See, he is not able to remember things, there is amnesia. He is not able to use tools, there is apraxia. Also there is language impairment, there is aphasia. So they are trying to tell you, and symptoms have developed, you know, since 2 years the symptom is present. So they are trying to tell you that it's a case of dementia. Most likely seeing the clinical picture might be Alzheimer's disease, a possible diagnosis. Which of the following is incorrect about the drugs we use? So let's talk about the drugs which we use for dementia. Better see this. Again, always try to correlate the drugs, the mechanism of action of drugs with the etiology, because sometimes they have asked questions on etiology. Now if we talk about, let us say, Alzheimer's disease, when we talk about Alzheimer's disease, in the etiology we know that there is decrease of acetylcholine, there is increase of glutamate, and also in the brain we have A beta deposits. So now I am trying to correlate the etiology with the mechanism of action of drugs, so that now you will never forget. This question in fact was asked that in Alzheimer's disease what is seen? There is decrease in acetylcholine. So let's discuss the first important mechanism of action of drug, choline esterase inhibitors. Very important drugs. So choline esterase inhibitors, what they do? So we know acetylcholine is broken down into acetyl-CoA plus choline in our brain by this enzyme. Suppose now what we did, we inhibited this enzyme. So what will happen beta? What will happen to acetylcholine? You will say sir acetylcholine will increase, है ना? This is what is desired, because we know acetylcholine कम हो रहा है, हमें उसको increase करना है. So let's see some of the drugs with this mechanism. One was tacrine, but not much used now because of what important side effect? Can you tell me? Tacrine का important side effect, it is hepatotoxic. It is hepatotoxic. Then some of the other drugs, remember donepezil, rivastigmine and galantamine. Now this question was asked in INI-CT exam. You should know some of these questions. देखो question था, a patient with dementia started on cholinesterase inhibitors. Patient developed GI side effects. Now which drug will you use? So we know that these drugs may cause, you know, when given orally they may cause these GI side effects. So they are trying to ask you that which of the drugs can be given through other route. So please remember, rivastigmine, it is available as transdermal patch. Okay, so please remember this. This is again an important question which has been asked previously. Now also remember one important new drug. So there is a new drug, benzgalantamine. Now since that asked question on side effect, remember benzgalantamine is a drug which is made, which is an oral drug. One important reason for developing this drug is it is an oral drug and it has less GI side effects. Okay, so very important. So it has less GI side effects. So this again can be asked, benzgalantamine. Okay, so this is cholinesterase inhibitors. Second is NMDA antagonist. See, we said that glutamate is increasing. देखो glutamate क्या है? It is a excitatory neurotransmitter. तो ज़्यादा glutamate होने से excitatory damage हो रहा है brain में. NMDA receptor किसके receptors हैं? Glutamate के receptors हैं. तो हमने क्या drug दिया? हमने NMDA antagonist दिया. Can you tell me which drug? Yes. So NMDA antagonist में one important drug, remember, memantine. Okay, memantine. It is usually used in moderate to severe cases. It is used in moderate to severe cases, and also remember it can be combined with cholinesterase inhibitor. In fact, there are formulations of donepezil plus memantine combination. So there are also formulations available as combination. Now these are the two drugs which are available in India. Now we also now have one new category of drug which is approved by the FDA, that is A beta deposits. Now what which act on these A beta deposits, and what are these important drugs? These are monoclonal antibodies or MAB. See, these monoclonal antibodies, they go in the brain, they attach to these A beta deposits and they help in their clearance. Now see, these earlier two categories of drug we can also use for other causes of dementia, but can you tell me these monoclonal antibodies we will use in which cause of dementia beta? We will use these monoclonal antibodies for Alzheimer's disease. Please remember Alzheimer's disease, especially mild cases of Alzheimer's disease. And in fact, I'll give you these three names and you can just remember with this mnemonic only: Alzheimer's disease. Okay, first name is aducanumab. देखो MAB मतलब monoclonal antibody. Aducanumab. Can you remember the name? Yes, you can. Aducanumab. Lecanemab. Can you remember the name? Yes, lecanemab. Please highlight lecanemab, very important. Okay, and also remember donanemab. So these monoclonal antibodies, they are given through IV infusion and they are approved by the FDA in the management of Alzheimer's disease. So I hope this is clear to everyone. Now let's try to answer this question. Which of the following is not suggestive of medical cause of mental illness? It's a FMGE ka PYQ, a very interesting question. Let's try to see if we can answer this question. Dekho, so many times we have discussed that it's not just an exam of your medical knowledge, but it is also an exam of your English language. So try to see what the examiner have asked. So now beta, can you answer this question? Okay, so tell me what is the right answer of this question. Which of the following is not suggestive of medical cause of mental illness? Very good. Dekho, when I say medical cause of mental illness ka matlab what they are asking you about organic mental disorder, isn't it? When a mental illness has a medical cause, we are thinking of organic mental disorder. So now they asked you which of the following is not suggestive. Very good. Dekho beta, elderly age. See, both in delirium dementia we know elderly people may be at a higher risk. We discussed that delirium can have acute onset, but a consciousness we have discussed that is affected only in delirium. So the right answer here is it is not auditory hallucination beta which is suggestive of organicity, and again I have discussed this point, it is visual hallucination. Now can you appreciate a very simple point, they have just made it into a question. So please be very careful with such questions. If you read the question carefully, I am sure you can derive the answer. Right, now let's talk about the psychotic disorder. So we have discussed the organic disorders, now we will discuss the psychotic disorders. A 30-year-old male reports of having stabbing sensations in his stomach for the past few months. Okay, okay, but at 8 let's take a break now. I'll just finish some of the topic, then we'll take a small break. These sensations occur intermittently in the daytime and would lead to a lot of distress. He told his wife to distance herself from the new neighbors as he claims that they have hidden an electronic chip in their house which is sending signals and causing this pain. Which is the phenomena seen here? But it's very important. Chalo, so many of you are confused between A and C. Very good. So I'm happy in a way that you are confused between two options. C, it is not thought insertion, it is not made feelings. What is the right answer? In fact, when we talk about schizophrenia, so we are now in the topic of, I'll just write down here, psychotic disorders, and let's first discuss schizophrenia. In fact, when we read the history, we talk about certain individuals, and one important individual is Schneider. Schneider gave Schneider's first rank symptoms. So he gave these 11 symptoms which he said may be seen in schizophrenia. See, the first 3 symptoms he said that patient can hear his own thoughts, or patient can hear voices discussing about the patient or voices commenting on one's action. All the 3 are auditory hallucination. So not all auditory hallucinations bit are SFRS, but only these 3. Next 3 we have already discussed, thought insertion, withdrawal, broadcast. ये कहाँ पढ़ा था अभी हमने? Thought alienation. We have discussed this point in thought alienation. So we know all these 3 also. Now see the next 3. Made impulses, made feelings, action. Beta how to remember? Remember it with the mnemonic IFA. है ना, IFA words होते हैं बॉलीवुड में, remember IFA. Here made का मतलब है patient feels or patient experiences that his impulses, feelings or acts जो ये कर रहा है, they are somebody is making him do these things. You are making him have these impulses. So this is made impulses. So patient may say that I am having impulses, yeah, I am having some feelings, yeah, some of my actions, they are not mine. Somebody is making me, have those. So this is made phenomena. Now let's discuss the last two. The last two are very important. Again, you will see sometimes such clinical questions can be asked. In fact, recently in one of the other exams, they had asked question on delusional perception. So let's discuss first what is somatic passivity. Again, don't mug up anything, but I always try to remember psychiatry terms with the name. Let's just break it down. Somatic का मतलब क्या है? Bodily sensation. Passivity, but I just told you in the beginning, ना, passivity का मतलब क्या है? Imposed by an external agency. So patient, let us say, a patient says, sir, I am having pain in my abdomen, and this pain is because of aliens, they are sending radio waves. So can you appreciate यहाँ पे patient is having abdominal pain, and which he says because of some external agency. So this is somatic passivity. Always remember things like this. See this question, he is saying that he is having some bodily sensation. Sir, I am having headache because a new neighbor has come near my house and he is doing some black magic, kala jadoo on me. So this is again example of somatic passivity. I hope you will be able to remember this point, but even if you don't remember the definitions, just read the terms. देखो, also see what is option number A. So what is option number A? Don't read it in hurry. Exam, exam you're in a hurry, you may read it as delusion of persecution. No, it is not. It is delusional perception. So what is delusional perception? Delusion का मतलब है patient के mind में a delusion has developed after experiencing a normal perception. The question which was asked in one of the recent exams, that a person saw birds flying, so flapping his wings. So patient ने देखा birds flapping the wings and he thought that God is sending him signal to run away. So now can you appreciate what has happened? There is a normal perception and he has developed a delusional meaning to it. So this is delusional perception. I hope this is clear. I hope this is clear. हाँ, I'll repeat again बेटा. Somatic, देखो, see this. Somatic passivity का मतलब क्या है? Patient experiences a bodily sensation and he says it is because of some external agency. ये है somatic passivity. Delusional perception का मतलब क्या है? Patient के mind में delusion develop हुई है after a normal perception. Like in this case, उसने देखा birds flapping the wings and he developed a delusion that God is sending him a message to run away. So this is delusional perception. I hope it is clear. Right. Also in the history, when we talk about the history, beta, one more person you should know, Eugene Bleuler. Eugene Bleuler. Can you tell me important contribution of Eugene Bleuler? Tell me what is the important contribution. One is he coined the term schizophrenia, beta. He coined the term schizophrenia. And also what other contribution you should remember of Eugene Bleuler? Anybody? He also gave what is known as 4 A's. Very good. So what are the 4 A's? 4 A's given by Bleuler. Can you tell me what are the 4 A's? First is loosening of association. So this we have already covered, na? Disturbance of association we discussed in formal thought disorders. Also remember affective abnormalities like affective flattening. So remember where we have discussed this, flat affect हमने discuss किया. Can you tell me any other A of Bleuler? Another is autism. Beta, what is the meaning of autism here? यहाँ पे autism का मतलब है the person is having illogical thinking. Illogical thinking. See, this question was asked in one other exam. A patient says, Lord Hanuman is a celibate. I am a celibate. So that means I am Lord Hanuman. So please try to see. He says, देखो, ये celibate is not a neologism word. It's a English word. Celibate means brahmachari. He says that Lord Hanuman is a celibate. I am a celibate. So that means I am Lord Hanuman. So can I say here the patient is having autistic thinking, he is having illogical thinking, isn't it? So sometimes such questions can be framed. And another A is ambivalence. Now what is beta ambivalence क्या है? Ambivalence का मतलब होता है inability to take decision. For example, there is pen on the table. Patient is thinking in his mind for hours and hours that should I pick it up or not. So he's not able to decide. So this is ambivalence. So these are the Bleuler's 4 A's. So please remember he coined the term schizo means split, phrenia means mind. And he also gave what is known as Bleuler's 4 A's. Now let's discuss this next question. A patient of 27 years old, again a very similar question was asked in FMG exam. So I'm trying to show you these questions also so that you are able to understand what type of question they're asking. With complaint that aliens are communicating, he says aliens are communicating with him and they are sending electromagnetic radiation to his brain and asking him to kill his distant relatives. His relative said that he has this illness for last 20 years. Patient does not work on farm and stop going to social functions. He is aware of time, place, person. Matlab he is not disoriented. What is the most likely diagnosis? Very good. But what is the likely diagnosis? See, you will say, sir, it is not depression, it is not mania, na? Because we will discuss these are mood disorders. यहाँ पे abnormality of mood should be present. So tell me, is it, अच्छा, चलो, it is C or D? Very good. So let's try to understand. Let's talk about the criteria for schizophrenia. Now in the criteria of schizophrenia, according to DSM-5, there are 5 symptoms. Now have you seen this movie Dhadkan? Now doesn't matter if you have not watched the movie. Movie में किसी को schizophrenia नहीं है, but from the name of the movie, we will remember the symptoms. So remember this name and you will remember the symptoms of schizophrenia. So D for remember delusion. Now again, can you appreciate? Have I mentioned which delusion? No. That means any delusion can be seen in schizophrenia. Of course, most common you can say delusion of persecution. Similarly, see, have I mentioned any hallucination? Which hallucination have I mentioned? No. Any hallucination can occur in schizophrenia, but most common is auditory. And D for disorganized speech. Can anybody tell me what all symptoms may be seen in disorganized speech? Okay. Can you tell me disorganized speech में क्या abnormalities आएंगे? Remember we discussed disorganization under thought. देखो thought में अगर disorganization होगा तो can I say even in the speech there will be disorganization, isn't it? So tell me what are the abnormalities? So all those formal thought disorders. So all those formal thought disorders like loosening of association, derailment, tangentiality, neologism can be seen here. Now let's discuss some other symptoms, catatonic symptoms. So let's talk about catatonic symptoms and negative symptoms. देखो negative symptom, let's discuss some important negative symptom. First is anhedonia. Beta, what is anhedonia? Can anybody tell me? What is anhedonia? Anhedonia का मतलब है decrease interest. So for example, patient को जिन चीज़ों में पहले interest आता था, उन चीज़ों में interest अब कम हो गया. सर अब TV देखने में मज़ा नहीं आता, shopping करने में मज़ा नहीं आता. So anhedonia. Avolition. बेटा volition means will power. Avolition का मतलब है there is decrease will. Family member से सर अब will power या motivation कम हो गया. We tell him to do something, he does not show any will or any motivation to do that task. Can you appreciate logia? We discussed what was neologism, new word. So logia matlab word. So what is alogia? Alogia matlab decrease in the speech. Mother may say that sir I ask a 10-minute long question, वो सिर्फ एक या दो words में ही answers. Speaks very less. Affective flattening, beta we have already covered na. Flat affect. Blunt affect, remember, decrease in expression. This question was asked in your exam recently. Ki affective flattening is which symptom of schizophrenia? Negative symptom. Lastly, remember asociality. Beta, what is asocial? देखो, it is different from antisocial. Antisocial क्या होता है? When somebody is against society, fighting with others. Asocial का मतलब क्या है? Less social. So there is decrease in socialization. So these are the negative symptoms. Can you appreciate why we are calling them as negative symptom? Because everything is getting minus, everything is getting less. So these are known as negative symptoms. So sometimes question may be asked like this also. So please be very careful. Now let's talk about catatonia. Now catatonia or catatonic symptoms, they are group of motor signs and symptoms. So they are motor signs and symptoms. Now I am discussing this under schizophrenia, but it does not mean that they are only seen in schizophrenia. In fact, remember, these catatonic symptoms are more common in mood disorders than even schizophrenia. So that they can be seen in other situations also. But let's discuss these catatonic symptoms here. Now let's try to study them together so that you are able to remember. First three let's discuss. One is stupor. But what do you mean by stupor? Stupor का मतलब है there is decrease in the psychomotor activity. Psyche का मतलब mind, motor मतलब body. Patient is just lying down on the bed, hardly he is moving, hardly he is talking. In fact, in neurology, sometimes you read in neurological conditions, in medical conditions, patient has developed stupor. That term is known as akinetic mutism. Akinetic mutism. So akinetic का मतलब है movement ना करना, mutism मतलब बोलना ना. Sometimes patient may be under excitement, so they may just have opposite. So what is excitement? As the name tell you, increase in the psychomotor activity. So patient who has developed catatonia, he is running around, removing cannula, removing catheter, so there is increase in the psychomotor activity. And some patients may have mutism. See, just the name, mutism. When sometimes you are watching television, you may just mute the television. So the screen is moving but you cannot hear anything. So as if मैंने patient को mute कर दिया. So there is significantly reduced or no speech. He is not speaking anything. He is doing things but he is not speaking. Okay. So this is mutism. Next very important symptom, please remember, is waxy flexibility. But what do you mean by waxy flexibility? As the name tell you, flexible like a wax candle. So person can be molded like a wax candle. Suppose this is a wax candle. I am trying to mold this. So there may be initial resistance and later on I can bend the way I want. So this is waxy flexibility. So please remember, initial resistance is seen here. Okay, initial resistance. Now also see this image. Better please see this image. Sometimes you may be asked such images. They are fond of asking image based questions. So they may give you such images that patient is maintaining such odd posture for a long time. So this can be catalepsy. देखो ये catalepsy है. There is something known as cataplexy. बेटा cataplexy कहाँ मिलता है? Where do you see cataplexy? Remember it like this. वो मिलता है narcolepsy में. Narcolepsy is a sleep disorder. So remember, narcolepsy में catalepsy नहीं मिलता, उल्टा मिलता है cataplexy. So catalepsy and posturing. So here both these terms means कि patient ने abnormal posture maintain किया है. The difference is that this catalepsy is a passive phenomena. Suppose this patient, the examiner made this patient to come in this posture और अब patient उसको maintain कर रहा है. So वो खुद नहीं आया, passively लाया गया है. So this is catalepsy. Suppose patient himself came into this posture and now is maintaining. तो ये क्या हो गया? Posturing. Very important to identify these two conditions. But I'll give you two examples. Patient number A. This is the hand of patient number A. हमने उसका hand लिया. There is initial resistance and after that I am able to bend the way I want. I remove my hand and gradually patient's hand came slowly down. What is this phenomena? Can anybody tell me? What is this phenomena? Anybody? What is this phenomena? Anybody tell me? Yes, this is बेटा initial resistance थी, उसके बाद धीरे धीरे करके it came back. This is waxy flexibility. Patient number B, let us say this is again the hand of the patient and there is no resistance. I made the patient's hand like this in this position and then I remove my hand. Patient is maintaining this. So what is this now? ये क्या है बेटा? What is this? This is catalepsy. I hope this is clear to everyone बेटा. I hope this is clear to everyone. And I hope this is clear. Right? हाँ. But most common hallucination is auditory. Delusion of persecution, remember it's a delusion. Most common delusion होगा तो it is delusion of persecution. I hope it is clear to everybody. हाँ, please be very careful. Initial resistance is seen in waxy flexibility. Let's now discuss the next two phenomena. But negativism and automatic obedience. देखो नाम से ही हम we will remember. Negativism का मतलब क्या है? As if the patient has developed a negative attitude towards the examiner. So he will oppose the examiner or he will remain in the same position. Suppose patient को आपने कहा come forward, patient goes backward. आपने कहा patient को आगे आओ और पीछे चला गया. So he is doing the opposite. This is negativism. While automatic obedience का मतलब है now he is extremely cooperative. So there is excessive cooperation. So you may elicit like this. Suppose I take a needle or a pin. I tell the patient I will prick your tongue with the pin. I have told this to the patient. Now I tell the patient to pull out the tongue. But a patient will pull out the tongue. Even if we slightly gently just prick his tongue and again tell him to pull out, he will again pull out. तो वो क्या हो गया? Extremely cooperative. Let's discuss the next two terms together. Mannerisms and stereotypy. दोनों का मतलब है repetitive odd movements patient is doing. Again and again he is doing some movements. What is the difference? Difference is in the name. See, mannerism is made up of word manner. So these movements which he is doing, remember they are purposeful. They are purposeful. For example, a patient is doing like this. See this. What is this movement? You will say, sir, it is a salute movement, but now it has become repetitive odd na. तो ये क्या है? Mannerism. While what are stereotypies? These are non-purposeful movements. So patient is doing some movement which have no purpose like this. So he is doing some movement like this. So this is stereotypies. Next two symptoms let's discuss together. One is echolalia and echopraxia. See, echo or echo means to repeat. Lalia means words. So here he is mimicking the examiner's speech. A question which we usually discussed was asked in your exam. So you ask a patient, what is your name? He says, what is your name? What do you do? What do you do? So whatever you are saying, he is repeating that. That is echolalia. What is your name? My name is Mukesh. What do you do? My name is Mukesh. Where do you live? My name is Mukesh. बेटा ये क्या है? ये था perseveration. वहाँ पे एक ही आंसर पे वो stuck हो गया. यहाँ पे he is mimicking the examiner speech. Then what is echopraxia? देखो, now you will tell me. बेटा praxia का मतलब movement होता है. Echopraxia मतलब mimicking examiner's movement. So very simple way to elicit. You start scratching your head in front of the patient. Patient will also start scratching his head. So he will mimic your movement. So ये क्या है? Echopraxia. See the name and you will understand. Let's discuss the last two. Grimacing. Beta, what is grimacing? Nowadays, when you take a selfie, what do? You pout. So if you maintain this pout for a long time, that is grimacing. So grimacing क्या है? It is maintaining odd facial features. Maintaining odd facial features. And lastly, we have ambitendency. देखो अभी हमने डिस्कस किया ambivalence. Ambivalence था indecisiveness at the level of thought. This is tendency na. So what is ambitendency? This is inability to decide a movement. Inability to decide a movement. For example, suppose there is a pen on the table. Patient takes his hand forward, then backward. Forward, then backward. He is not able to decide should I pick it up or not. तो ये क्या हो गया? This is ambitendency. I hope all these symptoms are clear, beta. So many times you will see questions are just asked from these symptoms also. So let me come back to this slide now. So we have also discussed catatonic symptoms and negative symptoms. So what is the diagnosis? So according to DSM-5, out of these 5, beta 2 or more symptoms should be present. So minimum should be 2. But there is a catch that out of the 2, at least 1 should be from the first 3. So first 3 कौन से? Delusion, hallucination and disorganized speech. इन तीनों में से कम एक होना चाहिए. Total at least 2. 3 भी हो सकते हैं, 4 or even all the 5 are present. According to DSM-5, beta, what is the duration? Can anybody tell me? The duration is 6 months. देखो, how is it different from ICD? ICD 11 में कितना है बेटा? ICD 11 में the duration is 1 month. देखो, if nothing is mentioned, then you can go with DSM. If they are not asked specifically for DSM or ICD, you can go with DSM. And also see the question. Sometimes the question is telling you to choose ICD or DSM. So according to the options you can answer. I hope it is clear. Very good. Now please see this question. A patient presents with voluntary purposeless movements, negativism, waxy flexibility. So here can I say patient has catatonia? Here patient has catatonia. See, should all these symptoms should be present to call it catatonia? No. If out of those catatonic symptoms, if 3 or more symptoms are present, beta, we say that patient has catatonia. So patient has come to you with catatonia. What is the treatment? Now we know that for treatment of schizophrenia, we have antipsychotics. But remember, for catatonic symptoms, very important, beta, what is the first line treatment? If they ask you, then we can give lorazepam. So you can give lorazepam IV, even IM oral, and you will see there is drastic improvement. So this patient who has come to you with such symptoms, there will be significant improvement maybe within few minutes after giving benzodiazepines like lorazepam. Suppose it is not showing much effect, then what is the best treatment? If they ask you, beta, what is the best treatment? If they ask you, then you can say it is ECT. So please remember, first line treatment is lorazepam. Best treatment if they ask you, it is electroconvulsive therapy. Okay. हाँ बेटा, यही diagnosis. I'll just show you the diagnosis. The diagnostics in 5 में से out of the 5, minimum 2 symptoms are there, and at least 1 symptom should be from first 3, and the other symptom may be any of the 5. So it should be at least 2 symptom, but एक symptom होना चाहिए from first 3. Okay. It may be delusion, hallucination, only these 2 symptoms are present. Schizophrenia, isn't it? Because both are from first 3. है ना? Delusion है patient को, patient has catatonic symptom, then you can say it is schizophrenia. If patient has only catatonic symptom and negative symptom, then you cannot call it schizophrenia, because at least 1 symptom should be from first 3. What is ECT? Very good. It is electroconvulsive therapy. Very good. It is electroconvulsive therapy. Okay. So please remember this. Okay. So we pass electric current and we produce convulsions. Seizures aa jate hain, and that is used in the management. Now let's also talk about some important pathways. Dopamine pathways. See, two dopamine pathways you should remember. They are for symptoms, and two dopamine pathways in the brain we'll discuss for the side effects of antipsychotic. So let's talk about the first two pathways related with the symptoms. So the first pathway is mesolimbic pathway. Meso ka matlab midbrain, and it goes from the midbrain to the limbic system. Here we see that there is increase of dopamine. An increase of dopamine in this pathway, beta, what it causes, which symptom? It causes positive symptoms of schizophrenia. Please remember. So positive symptoms of schizophrenia kab aate hain? One of the reason is increase of dopamine in this pathway. In fact, we talk about antipsychotics. Can you appreciate antipsychotics ka mechanism kya hai? Now you can correlate. Antipsychotics are dopamine antagonist. So they will help in decreasing these symptoms. Next is mesocortical pathway. Beta mesocortical, meso midbrain se they are going to the cortex. Yahan pe in schizophrenia there is decrease of dopamine in this pathway, and that causes negative symptoms of schizophrenia. That causes so all those negative symptoms of schizophrenia. Okay. Right. So let's take, okay, so some of you are requesting break. Let's take a small break. Okay. 5 minutes would be fine. Let's take a small short 5-minute break. And let's take a small 5-minute break, and we'll again start. Chalo, at 8:07 we'll start, hai na? Because I want to discuss some important topics. Let's take a small break. Chalo, 8:10 पे आ जाते हैं. Let's meet at 8:10. ठीक है ना? Let's take a small break. Okay. Right. Right, so let me know in the chat box I am audible and visible to all of you. Don't worry, we'll start at 8:10. So I'll just till the time everybody joins in. So I hope now you've joined in, right? So we've talked about two dopamine pathways which are related with the symptoms. Now let's also talk about two dopamine pathways which are associated with side effects. Now can you appreciate, we give antipsychotics, we discussed, so हम antipsychotics देते हैं, and the antipsychotics are what they have dopamine antagonism. Now let's come to this next pathway, nigrostriatal pathway. So it is from which area to which area? Substantia nigra se it is to the striatum. Now in medicine we read about these areas. In which condition? One important condition we read in Parkinson disease. So let's now try to use this knowledge about Parkinson disease. Now in Parkinson disease, what is the treatment we give? We give drugs like levodopa. So can I say in Parkinson disease there is decrease of dopamine in these areas, which leads to what symptoms? Motor symptoms, isn't it? Like there is tremors, rigidity, bradykinesia. So can I say if dopamine is reduced in these areas, it can lead to motor symptoms? Now let's see, a patient has schizophrenia. So a patient जिसको schizophrenia है, what drugs I have given? I have given that patient antipsychotics. Now what are antipsychotics but are doing? They are dopamine antagonist. So if they decrease dopamine in this area, what will happen? It will cause EPS. So very important, so EPS can occur if dopamine is reduced. So extrapyramidal, what is EPS? Extrapyramidal symptoms, it can occur. Now also let's talk about one more pathway, tuberoinfundibular pathway. Now this pathway, it is from the hypothalamus, it is from the hypothalamus to the pituitary, anterior pituitary. Now let's try to correlate some physiology knowledge which we have. We know in this pathway what is happening to, what is the relation between dopamine and prolactin? What is the relation? We know that in this pathway dopamine is inversely related to prolactin. It is also a PYQ, remember. Now what is happening? Now suppose if I give antipsychotics to my patient and it reduces dopamine in this pathway, but what will happen to prolactin? It will be hyperprolactinemia. This is a very important point, but please remember this. And let's discuss what happens when prolactin is increased. Let's correlate with our obs and gynae knowledge. So in a female who is pregnant, who has delivered, there is increase in prolactin which causes galactorrhea, milk secretion. It causes lactational amenorrhea. So please see this, a patient who is not pregnant, who has not delivered, this young female who is taking antipsychotics may present to us with galactorrhea, with amenorrhea. And why it is occurring? Because of hyperprolactinemia. So this is a very important point. Next time they may just ask this as a new question, that hyperprolactinemia can occur with antipsychotic, and both males and females it can cause decrease in libido or sexual desire. I hope we are able to understand these pathways, and very important, remember some of the side effects which can occur. Now let's discuss a very important topic. You know, this question has been asked nearly in every exam. They are asking this question about EPS. So let's see this question. Now let's try to answer this question, everybody. A patient receiving haloperidol injection. So he is receiving antipsychotics and in injection form develops fever, autonomic instability and elevated creatine phosphokinase level. Can you tell me what is the diagnosis here? Which important side effect you are able to see? Yes, it is what? It is neuroleptic malignant syndrome. And what is the right answer in the management? So let's discuss EPS, very important. Now these two slides which I will discuss, they are very important. How to remember these EPS? Remember it with this mnemonic DP at night. You know, in our medical college we have DP, dance party at night. So remember DP at night. First is D for dystonia. Dystonia is contraction of muscle, acute, sudden contraction of a group of muscle. It is the earliest EPS. You have given patient antipsychotics, sometimes maybe within few minutes patient may develop, you know, oculogyric crisis. Patient may come like this, my eyes are rolled upwards, or like this, torticollis, my neck is twisted to one side, or there may be laryngospasm. What is the treatment? It is very distressing. Can you tell me what is the treatment for acute dystonia? We give anticholinergic drugs and many times we give parenteral drugs because it is very distressing. So drugs like promethazine, benztropine. This has been asked in your exam. So first is, remember, dystonia. DP. P say what is P? Drug induced Parkinsonism. So patient on antipsychotic may come to us like this. Tremors is there, rigidity is there, bradykinesia is there. So patient on antipsychotic may come with such Parkinsonism like feature or pseudo Parkinsonism. Again, what is the treatment? Remember, again the treatment is we can give anticholinergic drugs. Here we can give even oral drugs like trihexyphenidyl. A, what is A? Please highlight. A से है akathisia. It is the most common EPS. What is akathisia? Akathisia का मतलब है restless. So patient is, subjectively from inside he is very restless. Patient will say, sir, I am feeling very restless. मुझे अंदर से घबराहट है. And when you see from outside, objectively also he will appear restless. He is moving around, not able to stay still, running around, pacing in the ward. So this is akathisia. Can anybody tell me what is the drug of choice for akathisia? Here we give beta blockers like propranolol. Very good, very good. अंदर से भी और बाहर से भी उसको घबराहट है, akathisia. Next is at T for, remember, tardive dyskinesia. Tardive का मतलब long term use. After long term use. So in the question they may tell you that patient is on antipsychotic for months or years. Dyskinesia means abnormal movement. So patient is having lip smacking or chewing movements like this, or tongue protrusion movement, or you may find coriform hand movements, pill rolling or piano form like movements. Tardive dyskinesia. But what is the treatment for tardive dyskinesia? Remember, we give dopamine depleters, VMAT2 inhibitors, vesicular monoamine transporter 2 inhibitors, valbenazine, deutetrabenazine. So these drugs can be used. And lastly, N for, remember, very important, neuroleptic malignant syndrome, NMS. See, if I tell you that some condition is malignant, malignant का मतलब ये benign है या serious है? It is a serious life threatening condition. Patient on antipsychotic may present with high temperature, increase in the CPK, muscle rigidity. He may have even other symptoms like there is sweating, there is tachycardia, confusion, there may be increase in the TLC count, increase in the liver function test. So all these are again telling me that patient has NMS. It is life threatening, it is an emergency. So first point, if they ask you the first step, but the first step will be, what will be the first step? It will be to stop the antipsychotics. And if they ask you the drug of choice, then you can say drugs like dantrolene. Even dopamine agonists like amantadine, bromocriptine, these can also be used. So please remember, if they ask you first step, it will be stop antipsychotic. Now let's see this question. So you have identified this is NMS, add anticholinergic medication, stop haloperidol and start dantrolene. That will be a better answer. I hope this is clear. दोनों अलग अलग होता, stop haloperidol, start dantrolene. You would stop haloperidol first. Okay. So I hope this is clear to everyone. Yes. Now let's talk about the antipsychotics. So briefly I'll discuss some important drugs. Now we know in antipsychotics we have first generation and second generation. First generation yani typical, second generation means atypical. So what is the typical thing about first generation? They are D2 antagonists. So we have 5 dopamine receptors, D1 to D5. We are blocking D2 receptors. Now in atypical or second generation, they are not just D2 antagonists, but remember, they are also serotonin 5-HT2. Which 2? It is 2A. A for, remember, atypical. Just like this you can remember so that you don't forget. This has been asked. So remember, they are blocking D2 and 5-HT2A. Now we know that EPS occurs because of dopamine antagonism. So can you tell me which will have more EPS? First generation or second generation? Which will have more EPS? Anybody? So remember that first generation will have more EPS, second generation will have less EPS. Now let's talk about the metabolic side effect. Now it's a very important point which I will discuss. Metabolic side effect may. So tell me some metabolic side effects such as weight gain, such as hypertension, diabetes, hyperlipidemia. So these are metabolic side effects, beta. Now metabolic side effects, remember, they occur because of 5-HT2C. So how to remember, beta? See, they are occurring because of 5-HT2C. So metabolic hai na, remember it like this. So they are occurring because of 5-HT2C antagonism. So now tell me who will have more metabolic side effects. So usually who will have more metabolic side effect? Remember, they are more with second generation, less with first generation. But there is an exception which was asked in your exams. In fact, twice recently they have asked question on the metabolic side effect. So very important to understand. I'll give you the exceptions also. Now let's talk about some first generation antipsychotics first. So first generation. In the first generation, remember one drug, chlorpromazine. Now what is the mechanism of action of beta chlorpromazine? You will say, sir, it is first generation, so it is blocking D2 receptors, but it also blocks alpha, M and H receptors. But if alpha receptors are blocked, so it causes side effects because of blockage of these receptors. So alpha receptors agar block हुए हैं, so it will cause hypotension. Hypotension can occur. Muscarinic receptors are blocked, so then patient can have anticholinergic side effects. Anticholinergic side effects हो सकते हैं. बेटा H से क्या है? Histaminic receptors अगर block होंगे तो which side effect can occur? So patient may have sedation. Also remember, even weight gain can occur. In fact, chlorpromazine is one drug which is a first generation which has a moderate risk of weight gain. It is very important. So please remember, usually we know that weight gain, metabolic side effect is more with second generation. But chlorpromazine is one drug which also has a moderate risk of weight gain. Also remember, suppose a patient comes with chlorpromazine, he comes to the ophthalmologist with some problems in the vision, and the ophthalmologist see that there is deposits on the cornea and on the lens. So which drug it is? Remember C for chlorpromazine, remember C for corneal and lenticular deposit. So this can come as an integrated new question, so please be very careful. So one is chlorpromazine, second is thioridazine. So remember, R is coming, which important effect in the eye can be seen with thioridazine? Remember, it can cause retinal pigmentation. So please remember this. Now thioridazine is one of the first generation which has less EPS. Out of the first generation which has maximum EPS, remember it is haloperidol which has maximum EPS. So I hope this is clear to everyone, right? Is it clear to everyone now? Now let's talk about a question, a very important drug, and this is a very important question. A patient diagnosed with schizophrenia not responding to haloperidol and thioridazine. So we gave two antipsychotic, he is not showing any response. Started on another medication, drug A, which has side effect of cyalloria, dyslipidemia and hyperglycemia. This drug also requires close blood monitoring for a serious side effect. What is the drug? I am very happy. Yes, all of you are answering it correctly. It is A, clozapine. So let's talk about some second generation antipsychotics. But second generation antipsychotics में let's discuss. देखो, risperidone is, although it's a second generation, but it is one of the second generation which has maximum EPS. Now also, when we talk about weight gain, maximum weight gain, when asked about the antipsychotic, beta, one is clozapine and another second generation, remember, is olanzapine. Remember clozapine first. Okay. So olanzapine is one of the antipsychotic which also causes weight gain. This question was asked in the exam. A patient taking olanzapine showing improvement, but now he has stopped taking the drug. Why? Because weight gain is a side effect which sometimes is very problematic for the patient. Now what is aripiprazole? This question was also asked, beta, what is the mechanism of action of aripiprazole? First, remember, although it is a second generation, but it is a partial agonist at D2 receptor. It is a partial agonist at D2 receptor. Remember one more important point about aripiprazole and ziprasidone. देखो ये दोनों, they are second generation antipsychotic. Remember it like this, A to Z. You know some of the important, two important second generation antipsychotic. Remember, A say aripiprazole, Z say ziprasidone. They have low risk of weight gain. Now can you appreciate, in your exam they had asked a question that chlorpromazine, which is a first generation, whether chlorpromazine will have low weight gain or ziprasidone, which is a second generation, will have weight gain. Now here you should know, chlorpromazine although is a first generation, but it is having moderate risk. So वहाँ पे answer था ziprasidone. It is second generation, but it has low risk of weight gain. So please be very careful. They have asked so many questions like this related to the antipsychotics. So let's now talk about clozapine. It is a second generation antipsychotic. देखो, although it is second generation, it is acting on more on D4 than D2. Now EPS occurs because of D2 blockage. So it is having out of the second generation one of the drugs with least EPS. Also remember, it has anti-suicidal property. So I will discuss three important drugs which have anti-suicidal property. One of them is clozapine. So please remember this, very important. So clozapine has anti-suicidal property. The clozapine is a very effective, in fact you can say it is the most effective antipsychotic, but it is not used as a first drug. So what is the use of clozapine? Beta, clozapine is used for treatment resistant schizophrenia. Treatment resistance का मतलब क्या है? Like we read in penicillin resistance है, vancomycin resistance. So treatment resistant schizophrenia means no response to two antipsychotics. At least two antipsychotics पे कोई response नहीं आया, then we can give clozapine. So you will say, sir, it is so effective drug, why don't we start it as a first drug? Because it has some serious side effects. So first let's talk about some common side effects. The most common side effect, beta, what is the most common side effect of clozapine? Remember, sedation. Again, cialorrhea, hypersalivation is also a side effect. Now they may just ask you what is the practical treatment management for cialorrhea. Now this cialorrhea occurs because of decrease in swallowing. And patient is embarrassed that when he wake up he says that my pillow is all wet. So one practical step you can do is you can tell the patient to put a towel over the pillow before he sleeps. Rather than starting any drug, because again it can have some interaction, we can first use this practical method. So put a towel over the pillow. It can also cause hypotension, weight gain. Remember we have discussed maximum weight gain. Also remember, clozapine, constipation can occur because it has anticholinergic property. Now let's discuss the serious side effect, very important, which you can remember it with the mnemonic SAM. S से है seizure. Patient on clozapine beta can develop seizure. So what will you do? So when a patient has developed seizure with clozapine, we can treat it by giving anti-epileptic drugs and then we can again restart clozapine. Next is very important, beta, agranulocytosis. This is a very important serious side effect. What is agranulocytosis? Can anybody tell me? Decrease in the WBC count, especially the absolute neutrophil count. So suppose a patient has come to you, he is taking clozapine and he has developed fever, there is sore throat, there is tachycardia. They are trying to tell you that patient ko infection ho gaya. So what you are trying to think, maybe this infection has occurred because of agranulocytosis. What will you do? You will check the counts. If the counts are low, you have to stop the drug. So very important that you have to stop the drug if the counts have reduced. In fact, this is such a serious side effect that any patient we start clozapine, we monitor the count. For the first 6 months, every week we have to check the counts. Next 6 months, every 2 weeks, and after that every month till the time he is on clozapine, we have to check the counts. So this was meant by this statement that it requires regular blood monitoring, because of which side effect? Agranulocytosis. Patient on clozapine come to you with chest pain, there is tachycardia, there is the blood pressure is increased. So what you may think, this may be because of myocarditis, ECG is abnormal. So now again you have to stop the drug. I hope this is clear. I am trying to give you a clinical picture so that whenever such question come, you are able to answer these questions. Also remember one new drug. So this is one of the latest antipsychotic, got approved last year, xanomeline. Very interesting drug. Now xanomeline, it is an interesting drug because till now we have discussed that all these antipsychotics are acting on dopamine receptors. This is one drug which is, remember, in the name M is coming now. So remember it is a M1 M4 muscarinic agonist. Now this drug is combined with trospium because of this muscarinic agonist action can occur in the peripheral tissue to reduce the side effect. Trospium chloride is also added, which is muscarinic antagonist for the peripheral tissue side effect. Also remember L is coming in between. So you can remember L is coming, so it is not recommended for liver disease. So even for mild liver disease, it is not recommended. So please remember the name xanomeline. I hope it is clear to everyone. Very good. Now let's see this question. A patient with a diagnosis of schizophrenia was started on oral risperidone. So he started on an antipsychotic. Always try to identify which category of drug they mentioned. Has showed improvement of symptoms on 3 mg per day, but patient refuses to take medication and there was a relapse of symptoms. So patient has to take, sometimes for years he has to take the medication. Now he has stopped taking the medication. So again the symptom have started. But what will you do? Stop antipsychotic? No, you have to give antipsychotic because symptoms are present. Start CBT? CBT may be used but not for these psychotic symptoms, may not be much useful. Again he is not taking orally now, so again even syrup risperidone may not be useful. Now what you can consider the long acting injectable antipsychotics or depot antipsychotics. So please remember, such clinical scenarios can be asked. So what are these long acting injectable LAI or depot antipsychotics? They are basically intramuscular injections, and usually they may be given every 2 weeks, or even after a month they can be repeated, or even longer. So once they are given in the muscle, gradually the drug is released over time. So we don't have to give the oral drug every day. So they can be used for patients who are having poor compliance to these oral medication. And also remember the technique by which we give, it is known as Z-track technique. So remember, Z-track technique is the technique by which we give these LAIs to prevent the leakage of these drugs when we are giving it as intramuscular injection. I hope it is clear to everyone. Now let's talk about this question. So we have discussed schizophrenia. Okay, we have talked about even acute psychosis. You can say symptoms are similar to schizophrenia, but duration is less. तो उसको कहते हैं acute psychosis. Now see this question again. It's a PYQ FMG exam का question है. A patient for 3 months believed that his daughter wanted to kill him. Tell me the diagnosis. First, tell me the symptom, beta. What is the symptom here? Can I say it is delusion of persecution? So you'll say it is not xenophobia. It is not bipolar disorder. Achha, why we are saying it is delusional disorder? Can anybody tell me why you are saying it is delusional disorder? Why it is delusional disorder, beta? देखो duration, let me say, let's make it 6 months. हाँ देखो, I am asking this because I want you to be exactly sure why you are saying it is delusional disorder. कभी कभी by chance भी आंसर ठीक हो जाता है ना. So that should not be the case here. You should know why the answer is correct. See here, duration is not very important in a sense, because remember, when I say patient is having only delusion, can you make a diagnosis of schizophrenia just if patient is having only delusion as the symptom? No. We know to make the diagnosis of schizophrenia, at least 2 symptoms should be present. So here patient is having only delusion, then we call it as delusional disorder. So delusional disorder ka matlab hai if patient has only delusion. It may be one or it may be multiple. And again treatment will be antipsychotics. Very good, yes. No other symptom is present. Very good. So we have talked about a very important topic of psychotic disorders. Let's now start with the mood disorders. Let's now talk about mood disorders. So in mood disorders, let's see. So in mood disorders, beta, what we have 2 set of disorders. One is when the patient has only depressive episodes. So let us say नीचे वाले symptoms हैं sadness के, ऊपर वाले symptoms हैं happy or irritable sometimes. So if the patient has symptoms only at lower pole, इसे क्या कहते हैं? इसे कहते हैं depression. Suppose the patient has sometimes depressive episodes, sometimes the patient has symptoms of mania or hypomania. Can anybody tell me what is this known as? This is known as bipolar disorder. Very good. This is known as bipolar disorder. So remember bipolar क्यों बोल रहे हैं? क्योंकि symptoms are present on both the poles है ना, कभी खुशी कभी गम. This is bipolar disorder. Okay. So first we'll talk about depression and then we'll talk about bipolar disorder. But both these topics are again very important. Now the question is, which of the following is a key feature of depression? Now it's a very interesting question. It's a new question which was asked in your exam. See, nowadays we are not seeing any old question. They are asking newer question. But if you know the concepts well, you will be able to solve. So let's see how to make a diagnosis of depression. Depression in DSM-5 is known as major depressive disorder or MDD. So let's discuss the symptoms of depression with this mnemonic, beta, SIGE CAPS. So what are these symptoms? So we discuss these symptoms with this mnemonic. देखो, it's a mood disorder ना, तो पहला symptom हमेशा होगा mood का. S for sad mood. So what is the mood in depression? The mood is sad. Patient says most of the time, most of the places I am feeling sad. I say interest. Beta, what happens to interest in depression? It decreases. So it is in fact known as anhedonia. See, anhedonia is seen in depression and also it's a negative symptom of schizophrenia. Then next is C. G for guilt or worthlessness. Patient has negative feelings towards self. Patient may have worthlessness, that I am good for nothing, I am a bad person. E is energy. Beta, what happens to energy levels in depression? Energy reduces. Patient says, sir, I get tired very easily. Easy fatigability. Now CAPS. C for, remember, concentration. The concentration of the patient reduces. Patient says, sir, आजकल मेरा ध्यान कम हो गया. Patient may present to us with symptom of forgetfulness. Sir, I forget where I have kept my documents, my keys. But it is not because of true dementia. It is because of decrease in concentration. So it is also known as pseudo dementia. Please remember this. If they ask you pseudo dementia, it is seen in depression. But what happens to appetite in depression? Remember, the appetite reduces and even the weight reduces. But sometimes opposite can also occur. Some patient may say, sir, we eat a lot and the weight may also increase. Usually decrease hota hai, but it can also increase. What is PMA? Psychomotor activity. But what happens to psychomotor activity? It usually decreases. Patient talks very slowly, walks very slowly. But sometimes it can even increase. You will see sometimes patient in depression, they are agitated, not able to stay still. They are running around. Now sleep. 2S we'll discuss. One is sleep, beta, insomnia. So patient may say that I am not able to sleep, but sometimes opposite can also occur, hypersomnia. And last S is very important, suicidal ideation or suicidal attempt may be there. So these are the 9 symptoms which can occur in schizophrenia. The diagnostic criteria says, suppose this is 1, this is 2. At least one of them should be present from the first 2 plus 4 or more of the remaining symptoms. For how much duration? Beta, what is the duration to make the diagnosis? Remember, duration is 2 weeks. Then we say it is depression. Now, can you appreciate from the criteria, if I ask you what are the key features of depression, you will say, sir, both first and second seem to be the key feature. Now, let's come to this question. Now, see this. Now, let's answer this. Dekho, when they are asking such new question, you should always go back to your basics. Now, you can say, so low mood and both loss of interest is given. Now, tell me which is the key feature. Dekho, mood disorder may always remember the key feature, the most important feature is abnormality of mood. So, please remember here the answer will be low mood. If that is not mentioned, then you can go with option B. I hope it is clear to everyone now. Please don't mug up things. Again, I am saying they are not repeating the questions, they are repeating the topics. So, it is very important. Now, let's discuss this next question. Again, it's very important. Now, we are talk about specifier. Let's talk about specifier. So, specifier ka matlab hai, we have made a diagnosis of depression or MDD. But sometimes patient may have some unique features, characteristics. So, we add this specifier. So, we will say MDD with whatever that unique feature is, we will add it as a specifier. Now, this is a very important topic. I will show you the table. A female brought to the psychiatrist 3 weeks after her delivery. She is appearing sad, irritable, decrease interest, decrease sleep, having suicidal thoughts. It's a very old question, 2019 ka question is repeated. You know, this topic is repeated. What is the likely diagnosis, beta? Is it, now this is not panic disorder, this is not psychosis, is it depression or is it blues? Very good. So, I am very happy you even know the name of the drugs, very good. So, this is a very important table, beta. Let's now discuss some important points about psychiatry and pregnancy. The first is postpartum blues. देखो blues का मतलब क्या है ना, movies में when there is a breakup ना background में song चलता है ना, feeling blues, feeling blues. So, blue means sadness. See this. It can be seen in up to 80% of the females after their delivery. Onset usually is within few days after delivery, 3 to 5 days. You will see, and the symptom may last for weeks, days to weeks. And the symptoms usually are transient and mild. Transient ka matlab for less time. So, there is usually spontaneous recovery. So, patient may present within few days after delivery with sadness, decrease sleep, tearfulness. So, what is the diagnosis? You are thinking it is postpartum blues. Would you give any specific treatment? But remember, only supportive care, no specific treatment is required. Very good. This question was asked recently. Please remember postpartum blues. Second, what we are discussing, postpartum depression. So, can you appreciate this female? So, it occurs in 10 to 15% of the females, you know, during pregnancy or after, within 6 weeks after delivery, patient has developed depression. So, depression to develop हुआ, वो diagnostic criteria to fulfill हो रहा है, but this is the catch ना, that patient has developed during pregnancy or within 6 weeks of delivery. So, now I will not call it just depression, I will add a specifier, I will call it as postpartum depression. Now, how to differentiate postpartum depression beta from blues? Remember, if in the question they tell you ki patient has suicidal thoughts, has guilt, anhedonia, this is more pointing towards that patient has postpartum depression. Now, would you like to treat this beta? Yes, you will treat it. You will give drugs like SSRI, you can give CBT, we can do, and also we have some new drugs. But we have some new drugs. Remember these GABA A modulators. So, we have some new drugs. Remember these names. Brexanolone, zuranolone. So, nolone is coming. Brexanolone is a IV drug. Very important. Remember, zuranolone, it's a oral drug. So, both these postpartum blues and depression has been asked. Now this third point, postpartum psychosis, has not been asked, but what did they ask in the next exam? So postpartum psychosis का मतलब क्या है? Psychosis मतलब delusions, hallucination. It is even less common in 1 to 2 per 1000 childbirths. So see, the symptom usually start with vague symptoms like irritability, sleep problems, anger, and ultimately patient develops delusions, hallucination, which may be related with the baby. So patient may say, this baby is not mine. I have not delivered any baby. So she may develop delusion or may have hallucination like I am hearing voices telling me to kill the baby, I want to kill the baby. So delusions and hallucination, then you will say it is postpartum psychosis. In the treatment, remember, you will say, sir, antipsychotics we can give, and even mood stabilizer lithium has also shown results in postpartum psychosis. So this is a very important table. Please be very careful when they are asking question like this. So here the patient is having depressive symptoms, suicidal thoughts are there. All this is pointing towards postpartum depression. I hope it is clear. Now let's see the next question. Now this is a very important question. This can come as a new question. So let's talk about this question, very important. See this. A 35-year-old female presented to OPD with symptoms present since adolescence. देखो psychiatry में ना keyword duration is a keyword. 25-year-old female है and symptoms are present since adolescence. So can I say the symptoms are present for a long duration? She complains of low mood, lethargy, sleep disturbance. So there are some symptoms, mild symptoms there, and reports of pushing herself every day to go to work. She has completed her graduation and is now working as an assistant manager in a multinational company. What is the likely diagnosis? But can you appreciate that they're trying to tell you कि जो functioning है patient की, that during these symptoms also the patient is able to complete the graduation, working in a company. So they're trying to tell you that functional impairment is not very significant or not very severe. Okay, this is one very important point that you should see from here. Okay, then what is the likely diagnosis? But see, recurrent depression is 2 or more episodes. This is also have been asked previously, 2 or more episodes of depression. Suppose a patient comes like this. So if the patient comes with a second episode and there is a past history of depression, then you will call it as recurrent depressive disorder. Here they are saying it is continuously present. Seasonal affective disorder, here the patient they will give you a history that in every particular season, for example, in every winters the patient develops depression, and when the winter goes the symptoms improve. So then you will think of seasonal affective disorder. Atypical depression, can you appreciate यहाँ पे depressive symptoms हैं but they are atypical. So here they will give you a history of mood reactivity. Normally in depression the mood is not reactive, but here they will say that if a positive stimulus comes, patient is happy, cheerful. They may tell you there is increase in the sleep, increase in appetite. So such symptoms they may give. They may give you symptoms like interpersonal rejection sensitivity. That patient is sensitive of rejection. Okay, if something neutral also occurs, patient को लगता है कि somebody has rejected me. Or they may give you symptom like laden paralysis. Laden paralysis का मतलब है patient को लगता है कि मेरे hands, मेरे legs, they are laden with something heavy. मैं move नहीं कर पा रहा. So such symptoms will give you in a history. They will tell you that they are talking about atypical depression. यहाँ पे the answer is dysthymia. Very very important topic. So this slide, again I'll say, you're getting such questions. So that is why I included this topic. This may come as a new question because previously also this has been asked. So dysthymia is presence of mild depressive symptoms. So the symptoms are mild. That means they are not enough to make a diagnosis of depressive episode. And the symptoms should be present for how much duration? Beta, please remember the duration is at least 2 years. In children we say that it is 1 year. And since the symptoms are mild, the functional impairment is not severe. But please see this. Suppose if the patient touches this line, he is qualifying for an episode of depression. Suppose this is 2 years duration. The patient is having mild symptoms, like in the case, patient is having symptoms for a long duration, but they are not fulfilling the criteria of a depressive episode. This is dysthymia. Now remember, this question was asked previously. What is the new name of dysthymia? In DSM-5, the new name is persistent depressive disorder. So depressive disorder which is persistent. Usually depression, bipolar disorder, they are episodic. It is continuously present, at least for 2 years. And also this was asked previously, beta, what is double depression? So I am trying to include all these questions. Double depression का मतलब है, suppose this patient who has dysthymia, now let us say he develops a depressive episode. So this is known as double depression. So I hope this is clear to everyone, but please see this question again. Please don't miss out on such questions if they are asked in the exams. Clear? Now let's talk about the management. Very important. Again, drugs are very important. Antipsychotics, antidepressant, mood stabilizer. You will see a lot of questions being asked from these drug categories from psychiatry. A 25-year-old female diagnosed with PCOS, polycystic ovarian syndrome, was brought to the psychiatrist with the complaints of low mood, decrease in trust, lethargy, disturbed sleep and anxiety. She is planned to be started on antidepressant. You have to tell me which of the following is an incorrect statement. Now many of the statements you may not know. Still try to approach these questions, because sometimes in the question the examiner will give you some options which you know. Very good. But even if you have not heard of option B or D, we'll discuss all these, but please see, can you still answer this question? Dekho, still you can answer, because you know we have discussed so many times, paroxetine is a SSRI which is contraindicated in pregnancy. So SSRIs can be given in pregnancy. You have to see the risk benefit, but paroxetine one should avoid because P for, remember, paroxetine, P for pregnancy, it is contraindicated as it can cause cardiovascular defect. So we have discussed this point so many times. So I'll discuss all these options, but let's now talk about the antidepressants. Now in the antidepressants, first important category we have is SSRI. Now we know that in depression, so please remember, in depression there is decrease of serotonin, decrease of norepinephrine if they ask two neurotransmitters, and even there is decrease of dopamine. So we know depression mein serotonin kam hai, so we are using a drug known as SSRI. What is SSRI? They are selective serotonin reuptake inhibitors, but they will increase serotonin. So please remember these names also, because in the exam they will give you the names. So drugs such as sertraline, fluoxetine, paroxetine, citalopram, escitalopram, even vilazodone. Vilazodone, you can say it's a serotonin partial agonist and reuptake inhibitor. So it also has partial agonist activity and reuptake inhibitor. So these are some SSRIs. Now SSRIs, if they ask you, this has been asked in your exams. But a simple question tha, patient ko depression hai, that asked which drug the psychiatrist would have started. So they were asking you drug of choice. Remember, SSRIs are the drug of choice. Can anybody tell me why? Why SSRIs are the drug of choice? Because they have less side effects. Also remember, these drugs, they take time. The onset of action takes time. They don't have immediate effect. Okay. Now, although they have less side effect, but they have some side effect. What is the most common side effect? So remember, most common is nausea, and other GI side effects can also occur, like diarrhea, constipation. Some drugs can cause diarrhea, some can cause constipation. Also remember, they can cause dry mouth. Hypersalivation हमने कौन सी ड्रग के लिए डिस्कस किया था बेटा अभी? Tell me. In antipsychotic, we discussed hypersalivation for clozapine. Remember here, these drugs can cause dry mouth because they have anticholinergic property. Which is the most common long-term side effect? बेटा अगर ये question आए, that I am giving SSRI for a long duration, which is the most common long-term side effect? Can SSRIs cause sexual dysfunction? Remember, yes. So sexual dysfunction like decreased libido, delayed ejaculation. Where can I use this side effect of delayed ejaculation? We'll discuss. So delayed ejaculation side effect can be used in the management of PME, premature ejaculation. Patient says, sir, since the time we have started these drugs, I am having very vivid, बड़े अजीब से dreams आ रहे हैं मुझे. They can cause sweating, even hyponatremia, especially in elderly. So one has to be very careful, especially drugs like escitalopram. One has to be very careful. You're getting symptoms of hyponatremia in an elderly who is on SSRI, so it could be a culprit. So please be very careful. Okay. Let's discuss some other drugs. Second is SNRI. देखो SNRI क्या है? It is serotonin norepinephrine reuptake inhibitor. Especially remember the first three names: venlafaxine, desvenlafaxine, duloxetine, even milnacipran and levomilnacipran. Again, question was asked in your exam. Keep a psychiatrist is starting a drug which is affecting both serotonin and norepinephrine. Which drug the psychiatrist has started? So there the answer was one SNRI, which was mentioned was venlafaxine. So please be very careful. Now another drug is NDRI. NDRI. Now what is NDRI? It is norepinephrine dopamine reuptake inhibitor. One very important drug you should know, many times question have been asked, beta bupropion. One very commonly asked question, dekho. We know that some of these antidepressants, they can cause sexual dysfunction, but remember bupropion has low risk of sexual dysfunction. Even sedation, weight gain is low risk in bupropion. Can you tell me any other drug also which has low risk of sexual dysfunction? Another antidepressant starts with M. Both these drugs have been asked. Remember M for, what is M? Mirtazapine. So mirtazapine also is one of the drugs which has low risk of sexual dysfunction. Patient started on antidepressant, develop sexual side effects. So which drug now you can use? So you can use bupropion, or they may give you mirtazapine in the option. So we discussed that it has low risk of sexual dysfunction, but one important side effect, can anybody tell me what important side effect can occur? Remember, seizures can occur, especially at higher doses. So one important FQ beta, can anybody tell me any psychiatric condition in which you will avoid giving bupropion? This can come as a new question. कि bupropion किस condition में नहीं देना? Of course you will not give any seizure disorder. Any psychiatric condition जहाँ पे you will not give bupropion beta, please tell me. Very good. Remember, B से bupropion, B से bulimia nervosa. So bulimia nervosa we'll discuss. Patient is having binge eating and vomiting, purging. So that can cause electrolyte imbalance. It can increase the risk of seizure. Even in anorexia, patient is not eating much. It can cause electrolyte imbalance. It can increase the risk of seizure. So very important, don't give bupropion in these cases. Okay. Now come to this question. See this. SSRI, SNRI can cause sexual dysfunction. Bupropion, mirtazapine cause less sexual side effect. This is correct. Dekho, HAM-D, it is Hamilton Rating Scale of Depression. So there are rating scales. I'll give you some list of rating scales. For depression, it is one of the rating scales, HAM-D. Now this is a new update. It's a new update in Harrison. So in fact, you know, sometimes they may ask this question from Harrison also, from medicine, even from gynae. That patient with PCOS, they should be now screened for depression during the time of your diagnosis and in the follow-up. Because many times we have seen that these patients may also develop depression, anxiety. It's a new update. So I have also discussed some of these updates. One important update, remember, but यहाँ पे answer incorrect statement is this, that paroxetine, it is contraindicated in P से paroxetine, P से contraindicated. I hope it is correct now. देखो, sometimes if you don't know some of the other option, always try to rule out the options. Many times you will see that the answer is there in one of the option which you know. Okay, so please approach the questions like this. Now also let's discuss some other antidepressant. Answer this question. Again, a repeatedly asked question. A 26-year-old female diagnosed with depression on antidepressant presents with altered sensorium, hypotension. ECG shows wide QRS complex. So you have to tell the appropriate treatment. Tell me which drug he might be on. This is which toxicity? Very good. The answer here is sodium bicarbonate. So which toxicity we are talking about? Very good. It is TCA toxicity. Antidepressant may will discuss TCA toxicity. Very important, commonly asked question. Now remember, in TCA toxicity, patient can have CNS, CVS and ANS signs and symptoms. So patient in CNS sign symptom, you will see patient has developed seizures, coma, confusion. In CVS, you may see that arrhythmias may occur because of sodium channel inhibition, increase in the QRS complex. In the ANS, you may see patient may develop dry mouth. Very important, this has been asked, but a hyperthermia can occur. Also remember mydriasis, you know, I'll discuss meiosis, mydriasis. Remember here in TCA toxicity it is mydriasis. So acidosis can occur. What is the management? We will do alkalization by sodium bicarbonate. So this is a very important point. Please remember this. This has been asked so many times. Okay. So here it is telling us these are signs symptoms of TCA toxicity and we'll give sodium bicarbonate. Now patient on MAO inhibitors, he consumes tyramine rich food like cheese, like red wine. This is also very old question, has been asked so many times. Can you tell me what is this known as? So patient on MAO inhibitors consuming cheese, red wine, tyramine rich food, they may land up into cheese reaction. What is cheese reaction? Remember, it is hypertensive crisis. Very good. Now one more important, you know, side effect of a drug trazodone. Just tell me what is the side effect. This has been asked so many times. Trazodone का एक important side effect क्या होता है? What it cause? It can cause priapism, painful prolonged erection. A patient comes in the emergency with painful prolonged erection. Which antidepressant he was taking? So it could be trazodone. So such clinical questions also they have framed. So please be very careful. Now let's discuss a newer question. This may come as a new question. So I'm trying to give you an idea about how they may ask the question from the previous topic but as a new question. You have to tell me which is least useful in TCA toxicity. But I always try to see the picture and then answer. देखो TCA toxicity में क्या diazepam का role है? हाँ, if he develops seizure. Sodium bicarbonate we discussed, but a lidocaine can be used if patient develops arrhythmia. देखो you must have read in pharma, we know that drugs which have high volume of distribution, then hemodialysis may not have much role. So in TCA toxicity, drugs like amitriptyline, they have high volume of distribution. So then hemodialysis has not much role in the management. So please remember this point. Very good. Yes. Now let's talk about this. Again, a new question, very, very important, because sometimes they are asking new questions from the drugs also. So let's complete this topic of antidepressant with this question. You have to tell me which of the following is an incorrect statement. Dekho, now I am sure you would know the answer. Dekho, ketamine, what is ketamine? Ketamine, we know it's an anesthetic agent. It is a NMDA. It is a NMDA antagonist. It is a NMDA antagonist. It has a rapid onset of action, and it is also found to be having antidepressant activity. Also, the second drug which I am discussing, it has anti-suicidal property. It also has anti-suicidal property. So it is now being studied for depression. Usually we know depression may drugs take time, but it has a rapid onset of action for depression. In fact, it's enantiomer S-ketamine. This is approved for treatment-resistant depression. For treatment-resistant depression may approved hai. Also for suicidal behavior. Also in suicidal behavior it is approved. It is also available as nasal spray. So please remember these points. So I have told you two drugs which have anti-suicidal property. Now zuranolone is given through IV route. No, it is wrong. We have discussed now, it is given through oral route. Also remember, it is a latest antidepressant Japirone. Dekho, Japirone mein 1 is coming in the end na, so it is a agonist, partial agonist at 1A receptor. So it is a agonist, partial agonist at 5HT1. So just remember it like this. So the answer here is option D. It is given orally. I hope it is clear to everyone. So again, remember these points. Ketamine, it has antisuicidal property, rapid onset of action. S-ketamine is available as nasal spray. So please remember these points. Okay. Now let's talk about this question. So now let's talk about bipolar disorder. In fact, this question is very important. This is a question which was asked previously in your exams. A 30-year-old female brought with symptoms of excessive talking, decreased sleep, over grooming, excessive spending for 2 weeks. On asking any question, she becomes irritable and angry. So यहाँ पे mood they have mentioned, है ना? Mood also they have mentioned. So please remember. So there is no history of any previous psychiatric symptoms. You have to tell me the diagnosis. See, it is not rapid cycling. देखो, cyclothymia is a milder form of bipolar disorder. जैसे dysthymia हमने discuss किया था. So it is also not cyclothymia here. You have to tell me what is the right answer. Is it B or C? Now let's try to understand first beta what is mania and what is hypomania. Now see, when we talk about mania, remember the mnemonic me, dig, fast. So patient with mania, so let's say the first symptom, mood is elevated, very happy. Patient is very happy, but sometimes it may be even irritable. E for energy, beta energy is increased, the energy levels is high. Now D for distractible, patient is very easily distracted. I for impulsivity, patient may do things without considering the consequences, like there may be increased spending a lot, increased religiosity, है ना? There is a lot of impulsive activity. G से है grandiosity, but I am not saying here delusion of grandiosity. Here I am saying grandiosity का मतलब है inflated self-esteem. So patient has a very high self-esteem. F से we know flight of ideas, we already discussed. Activity level is increased here. Sleep, there is decreased need for sleep. Patient is not sleeping for 10 days and still he is full of energy. Patient says, sir, who needs sleep? Sleep is a waste of time. And patient is talking and is not stopping. So these are the symptoms of mania. To make the diagnosis, we say both first and second should be present plus 3 or more of these symptoms. For how long these symptoms should be present? It is 1 week. Depression के लिए क्या duration था? 2 weeks. Mania में the symptom should be present. Minimum duration I am telling is at least 1 week. Then we will call it as mania. Let's also discuss बेटा what is hypomania. देखो hypo का मतलब क्या होता है? Hypo का मतलब कम होना. तो mania से थोड़ा कम. So symptoms are similar to mania, but they are not severe. So there is not significant impairment. And the duration is at least 4 days. So they may tell you in the question that patient is having these symptoms, but he is going to his office, he is doing the work. So they are trying to tell you that functional impairment severe nahi hai. So then you will think of hypomania. Also remember, in hypomania, you know one important point how to differentiate. There will be no psychotic symptoms. देखो mania में sometimes patient with mania may develop psychotic symptoms like delusions, hallucinations. तो अगर psychotic symptoms develop हो गए, it is not hypomania anymore, it is mania with psychotic symptoms. Also remember, there is no need for hospitalization. So if patient is hospitalized, then you have to think of mania and not hypomania, even if duration is less. And we have already discussed that flight of idea is also usually not seen in hypomania, it is seen in mania. Okay, so please remember this sequence also. Now please try to understand. So everybody of us have understood how to make a diagnosis of mania and hypomania. Let's come back to this question. But see this question now. See, when do we say patient has bipolar 1 disorder? If patient has at least one episode of depression but plus at least one episode of hypomania. और bipolar 1 disorder कब बोलते हैं? If patient has at least one episode of mania and at least one episode of depression, even if patient has only manic episode, that is also now considered as bipolar 1 disorder. But now can you tell me what is the right answer here? Now can anybody tell me beta what is the right answer here? देखो, if you are thinking कि ये mania या hypomania तो answer नहीं आएगा. See, they are giving you that patient has these symptoms, it could be mania, it could be hypomania. But they have told you that there is no history of any psychiatric illness in the past. You cannot call it as bipolar 2 disorder because for bipolar 2 disorder, patient has to have a history of depression in the past. So then you have to take, by default it becomes bipolar 1 disorder. That means right now patient is having mania, so it is bipolar 1 disorder with current episode mania. Very interesting, very good question which was asked. बेटा देखो 2 weeks का मतलब है ये दोनों ड्यूरेशन फुलफिल कर रहा है ना. हाइपोमेनिया के लिए 4 दिन चाहिए मिनिमम एंड मेनिया के लिए एटलीस्ट 1 week चाहिए, दोनों फुलफिल हो रहे हैं, है ना. वो मिनिमम ड्यूरेशन होता है. द सिम्टम्स कैन अकर समटाइम इवन फॉर मंथ्स. So here the answer is option number C, that is it is bipolar 1 disorder. Very interesting question which was asked. Now let's talk about the management. So when I say bipolar disorder, but I will manage the episode, है ना. So let's see how to manage a manic episode. Now suppose the patient has come to us with this episode. So patient has come to us with mania or hypomania. Let us say in the past उसको depression था, हो सकता है ना past में depression, and हमने क्या शुरू किया होगा, antidepressant. अब patient हमारे पास आया है with mania. How will you manage? So there are 3 first line drugs beta which we can give here. This is a very important slide again. One is antipsychotic, lithium and valproate. What is lithium and valproate? Remember, these are mood stabilizers. So what is lithium and valproate beta? These are mood stabilizers. Now can anybody tell me, अगर मैं आपसे पूछूं बेटा what is the first step? Very good. Before starting any of these drugs बेटा first step, पहला step ये होगा that I will stop the antidepressants. Very important. Because antidepressants क्या कर रही हैं? They are elevating the mood. Mood is already too much elevated. First step will be to stop the antidepressant. Very good. If antidepressant is not there, then there is no role of this step. Now if they ask you beta what is the drug of choice, again any of these 3 drugs can be used. But again for your exam purposes, if they ask you drug of choice, then you can go with antipsychotic. And of course you can prefer antipsychotics if patient is also having mania with psychotic symptoms, right? Now out of lithium and valproate, remember both are mood stabilizers. Earlier lithium was the answer out of the 2, but please remember lithium, it has slow onset of action, while valproate has a rapid onset of action. So we can now prefer valproate. So please remember. Also remember, especially in rapid cycling also you can prefer, we'll discuss this point. But avoid valproate in females of childbearing age. Now can anybody tell me why? Why we will avoid valproate in female of childbearing age? Because valproate can cause PCOS or PCOD. But a teratogenic effect I'll discuss. Suppose patient says, sir, I am not having any plan to become pregnant. There also I am saying avoid because it can cause PCOD, PCOS. If they ask you in pregnancy, patient is pregnant and patient develops mania. Now which drug will you prefer? Again in pregnancy you will prefer antipsychotic. So please remember, this question can be asked again. They are asking a lot of questions of psychiatry in pregnancy. So patient in pregnancy develop mania, then again drug of choice is antipsychotic. If that is not there given in the option, then which drug can you use? So yes, we can use lithium, but remember lithium can cause Epstein anomaly, which is a cardiovascular defect. and try if possible avoid valproate because it can cause neural tube defect, which is a CNS defect. So all these teratogenic effects also, please remember, so many times they will ask you in match the following. Okay, so this has been again asked so many times. Now let's answer this question. A 30-year-old patient presents with 5 episodes of mania, hypomania, depression in last 1 year with complete recovery in between these episodes. मतलब बीच में she is absolutely fine. You have to tell me the incorrect statement. What is the incorrect statement? Can anybody tell me? What is the incorrect statement? So what is the diagnosis here? Very good. The diagnosis here is it is rapid cycling bipolar disorder. See, rapid का मतलब है fast, cycling का मतलब है up and down. So rapid cycling bipolar disorder का मतलब है 4 or more episodes of depression, mania, hypomania in 1 year. See this, suppose this is 1 year duration. Can you appreciate patient has 4 episodes in 1 year? So this is rapid cycling bipolar disorder. In between the patient may become normal. In rapid cycling bipolar disorder, beta, this question we have discussed so many times. कौन सी drug use करते हैं? Valproate has shown good result, and this was asked in the exams recently. Also remember, rapid cycling bipolar disorder is more common in females than males. So here, yes, valproate is used in the management. Even lamotrigine is also nowadays shown to having good results. Hypothyroidism is a risk factor. Even female gender we have discussed is a risk factor. Diagnosis is rapid cycling. D is not true. So the answer is option D. It is a false statement. So we have talked about the important topic of mood disorders. You will see a lot of questions being asked from mood disorders. Now let's talk about the neurotic disorders. So let's now talk about neurotic disorders. So I'll discuss some important points about these neurotic disorders. First neurotic disorder we'll discuss is anxiety disorder. So first important topic in neurotic disorder is we'll discuss anxiety disorders. Okay. Let's answer this question. A patient is brought with symptoms of anxiety, palpitation, sweating, breathlessness, chest pain, feeling she might have a heart attack or feeling of impending doom. And these are episodes occurring 5 to 6 episodes in a month lasting for 30 minutes. What is the likely diagnosis? Very good. The answer here is panic disorder. It's a very small but very important topic. You will see many questions. Let's talk about these anxiety disorders. So beta, there are 5 important anxiety disorders I'll discuss which we can club into these 3 categories. First is panic disorder. Now in panic disorder, patient is having panic attacks, sudden onset of anxiety. So patient will say suddenly I have severe anxiety. There is palpitation, tremors, all these symptoms with a very important symptom, remember, with the feeling of impending doom. Patient कहेगा that as if I am about to die. Sir, मुझे लग रहा है मुझे कुछ होने वाला है. Fear of dying. So this is classically how panic attack occurs. And these panic attacks may last for 10 to 20 minutes. And after that patient will say, sir, now I am fine, absolutely fine. So this is what is panic attack. If patient has recurrent panic attacks, then we call it as panic disorder. But tell me, these panic attacks, they are occurring in a particular situation or they are unexpected? Tell me this point. They are unexpected or they are situational? Remember, they are unexpected. Patient will say, I don't know when this attack will come. It can occur anytime, any place. Like suppose patient said, sir, I had a severe attack when I was at my office. After few days, another attack came when I was at my home. Another attack came when I was driving my car. So can you appreciate patient is having these attacks at different time, different places, and what is happening in between? In between the patient is absolutely normal. So this is classically what is panic disorder. Now what are phobias? Phobias, you can remember, they are situational anxiety. See this diagram. Whenever there is situation, there is anxiety. The situation goes, anxiety goes. So again, in between the patient is absolutely normal. So all these phobias we'll discuss in the next slide. Agoraphobia, specific phobia, social phobia. Then what is GAD? Just see the name, generalized anxiety disorder. So as the name suggests, now the anxiety is generalized. There is persistent anxiety, sometimes known as free floating anxiety. One very important symptom that you should remember is patient will report of excessive worries. Very, very important. Patient is worried about small things. So in one of the questions in the exam which was asked in your FMGE exam, a female is having sleep problems and she is worried that her parents may die in a car accident. One of the options they had given was PTSD, but the answer was not PTSD. For PTSD, the accident should occur, na? Here she is worried about something which may happen in the future. So the answer was generalized anxiety disorder. See this diagram. The anxiety may be less but it is continuous. But duration के लिए for panic disorder it is 1 month, for all these disorder it is at least 6 months. Okay. So this is how we make the diagnosis. We will discuss phobias with the help of this question. So see this question. A 45-year-old male feels uncomfortable using lift, being in crowded places, traveling in public transport and going to home alone. Because of these, he has restricted himself going to a lot of places. So can you appreciate he is having anxiety in certain particular situations. So ये कौन सा phobia है? Can anybody tell me? Very good. First of all, you will say, sir, it is not a depressive disorder. And now let's try to understand. Very good. But the answer here is, it is agoraphobia. So let's see these three phobias. But what is agoraphobia? See, in agoraphobia, anxiety is in 2 or more situations. I will give you 5 situations. Out of these 5, at least anxiety is occurring in 2 situations. Then you will call it as agoraphobia. But what are these 5 situations? Patient को public transport में anxiety हो रही है, या फिर open spaces like big park, parking lots में, closed places like lift में, in crowd या standing in a line anxiety हो रही है, or alone outside of home, patient is anxious. So actually the concept is कि patient is having anxiety in places where escape might be difficult. Now very important, why I am highlighting this again and again, 2 or more situation. But in one of your FMGE exam, उन्होंने question पूछा था, a patient is having anxiety in lift, he is not able to use the lift. What is the diagnosis? Will you call it agoraphobia, yes or no? Tell me yes or no. Will you make the diagnosis of agoraphobia? But agoraphobia में remember that patient has anxiety in 2 situations. वहाँ पे answer agoraphobia नहीं था. वहाँ पे answer क्या था? It was specific phobia. As the name suggests, specific phobia मतलब fear of something specific, irrational fear of any object or situation. Again, it's a so many names can be mentioned. So let's discuss some of the important ones. One is allurophobia. Allurophobia क्या है? Fear of cats. Acrophobia. This was again asked recently in the exams, in your exam. Acrophobia मतलब acrobats do stunts in height ना, high places पे the person has fear. Claustrophobia क्या है? This is claustrophobia in closed places. So वहाँ पे lift वाले question का answer क्या था? It was claustrophobia. Specific phobia was there in the option. What is nyctophobia? Nyctophobia is fear of darkness. What is cynophobia beta? Cynophobia is fear of dogs. Misophobia is fear of dirt or germs. Xenophobia, remember, xenophobia is fear of strangers. Zoophobia, animals. Thanatophobia, in the movie Avengers there was the villain Thanos, it was taken from the Greek god of death. So thanatophobia क्या है? Fear of death. So please remember, sometimes they will ask such clinical questions. Lastly, remember what is social anxiety disorder or social phobia. Here the fear is of social situation, but remember beta actual fear is not of that situation. Actual fear क्या है? Patient को actual fear है fear of embarrassment. Sir, what if I go in a marriage and I spill food over my face? It will embarrass me in front of other. What if I blurt out something in front of others? So actual fear क्या है beta? Fear of embarrassment. So this is very important. I hope this is clear to everyone. Now, so the answer here is, so they have mentioned so many places, so many situations in which he is having anxiety. So answer is agoraphobia, right? Now let's talk about this question. A 40-year-old male recently went for an international trip where he accidentally got lost alone in a safari tour, and he was rescued 2 days later and he returned home. So can you appreciate they have given such a severe trauma, right? Since past 2 months now he is having dreams of that event. Okay, बेटा agoraphobia and claustrophobia में कैसे differentiate करोगे anyone? देखो claustrophobia में he is having only anxiety of closed places. Okay, if he is having along with closed spaces, he is having anxiety of any of these, then you will call it as agoraphobia, right? I hope it is clear now. So 2 months he is having now dreams of that event and he wakes up in the night frightened. He also avoids going out for any office trips outside his city, even if it was important for his career growth. What is the likely diagnosis? So can you tell me what is the likely diagnosis beta here? So again, here he is having some symptoms after the trauma. It is not major depression, he is not having symptoms of depression here. So let's try to understand this in the question they may give you a stressor. So let's discuss some trauma or stressor related disorder. So what I've done is I've divided these disorders on the basis of the severity. Suppose the trauma is severe, like in this case it's a very severe trauma. They may give you in the question there is a car accident, or somebody is having a serious illness, somebody experienced some natural disaster. So such severe trauma they may tell you. So then the patient may have two diagnoses we'll discuss. One is PTSD, post-traumatic stress disorder, and another is acute stress disorder. But what is the difference? The difference is in the duration. In PTSD the symptom will be there for at least 1 month or more, while in acute stress disorder the symptom will be less than 1 month. Symptom will be same. So you can remember the symptoms beta with the mnemonic MAHI, है ना? When MAHI comes to bat, he is the trauma for the opponent. Remember it with the mnemonic MAHI. M से क्या है? Mood and cognition. So patient will have negative mood state, patient may be very angry, very sad, and cognition का मतलब patient may have negative thoughts. A is very important, please highlight, avoidance. Now he will avoid things which will remind him of the trauma, like people, object or places related with the trauma. H is hyperarousal, he will be in a hyperarousal state like poor concentration, there is decreased sleep. Again very important is I, but intrusion symptom or re-experiencing symptoms like distressing dreams, flashbacks, patient is having of that trauma. So these symptoms are telling you that the symptoms are related with the trauma, especially remember AI, avoidance and intrusion symptoms. So patient after a severe trauma having these symptoms, if it is 1 month or more, then you will call it as PTSD. So beta, what is the treatment? Remember, treatment of choice is CBT. Even SSRIs can be used, but treatment of choice is CBT, therapy CBT. Now can you appreciate in this question, he is having the duration also they have given, dreams, he is having distressing dreams, so there are intrusion symptoms, and also he is avoiding going outside the city. So he is again having this avoidance behavior. So can you tell me what is the diagnosis here? It is not acute stress disorder, it is PTSD. Also it is not adjustment disorder, we will discuss it in a while. I hope it is clear, but in your exams recently even they had asked about acute stress disorder, वहाँ पे duration 10 days का था. So please remember, symptoms are similar but difference is in the duration. EMDR is also a therapy beta which is used, but remember the therapy of choice, treatment of choice remains CBT. EMDR क्या है? Eye movement desensitization and reprocessing therapy. Okay, clear. Now let's discuss if the trauma is mild or moderate. Suppose somewhere in the question they give you a mild trauma, like for example somebody had some mild illness or there is some loss of job, such mild day-to-day stressor they might give you, which many of us may experience, but we may not develop any illness, but some people may develop what is known as adjustment disorder. So can you appreciate what is adjustment disorder? Difficulty in adjusting to the new situation. So here the symptoms are usually mild, so mild behavioral emotional symptoms are there. And also remember it's a diagnosis of exclusion, matlab you will rule out other disorders. Suppose if a patient after having a mild stressor, suppose loss of job, he is developing depressive symptoms, I will make a diagnosis of depression and not adjustment disorder. So if any other diagnosis is not getting fulfilled, then I will think of adjustment disorder. I hope it is clear because now we are going to discuss, but just 1 more hour I think and we will be done. I will finish all these important topics, give me 1 more hour and we will stop. So answer this question, because why I am discussing all these topics, because nowadays they are asking these newer topics in your exam. So please see this. A 25-year-old software engineer visits a psychiatry clinic as he is suffering from low mood, decreased concentration, sleep disturbance due to stress in his current job from the past 3 years. So they are trying to mention the stressor also. Okay, he cannot work properly and having difficulty to balance family and work. He has no prior history of any psychiatric illness. Is it GAD? No, it is not GAD. In GAD we know the anxiety symptom is excessive worries is the most important symptom. It is not PTSD. It is not acute stress disorder, isn't it? So what is the likely answer here? It is adjustment disorder. In fact, in the PrepLadder app, in our videos we have discussed this very similar example also, and this is the question which is asked very recently in the exam. So again, that is why I am discussing adjustment disorder this time. And these are the topics which they don't ask very often, but they are asking nowadays. So one has to be very careful when they ask such question. Even if when you read the question you may not come to the answer, but don't worry, you are given 4 options. Try to rule out the option, I am sure you can come to the right answer. I hope it is clear. Now let's answer this question, a very interesting topic. So we have discussed second neurotic disorder, that is trauma and stressor related. Now let's discuss the third neurotic disorder. Now see this question, again it's a PYQ. a 20-year-old female, see, they started the question like this, and she is eating food. And the first option they have mentioned is anorexia nervosa. Now this is a trap. A female eats food by arranging, see the entire question in pieces and take very small equal bites each time, spending a lot of time eating her meal. What is the likely diagnosis? Very good. So it is not anorexia nervosa, but in fact it is obsessive compulsive disorder. So let's in fact discuss what is OCD. See, OCD mein patient has obsession and compulsion. Tell me, OCD is a disorder of flow, form, content, possession. This also may be asked in the exam. OCD is a disorder of beta flow, form, content, possession. Beta revise multiple times. That is why I am trying to give you some important points about each drug, so that at least you remember these important points. Yes, it's a disorder of possession. Don't worry, there is only one thing, I am giving you some tricks also to remember. Always revise multiple times and you will remember the drugs and solve MCQs. So remember, we'll discuss what are obsessions. Beta yes, OCD is an abnormality of possession of thought. So we have discussed this point. So remember, obsession, we will remember it with the mnemonic rosy. So there are various types of obsession. I'll give you examples. All these obsessions will have these characteristics of rosy. So what is R? R है repetitive. So patient says, sir, in my mind some repeated thoughts, images या फिर impulses आ रहे हैं. O say patient knows, sir, these are my own thoughts. Patient knows this. S is senseless. This is very important, beta. So this is very important. Sometimes help us differentiate OCD from other conditions. Patient knows that these are senseless thoughts. These are wrong thoughts. He tries to stop them, but these are irresistible. For example, a patient says, sir, I am having repeated thoughts that my hands are dirty. I know these are my own thoughts. I know these are wrong thoughts because look at my hands, they are clean. I am not able to stop them. What is compulsion? Compulsion के नाम से ही पता चल रहा है, compelled to do something. So these are repetitive acts. So sometimes the patient having obsession of contamination may do repeated hand washing. So they may indulge in compulsion. So this is obsession and compulsions. Now let's talk about some important types of obsessions and compulsions. This table is very important. So many times they have asked questions from this table. If I ask you, beta, what is the most common obsession? Can you tell me most common? The one we just discussed. कौन सा है? Contamination is the most common. NEET PG में एक बार पूछा था, second पूछा था most common obsession, and contamination was not given in the option. So also remember, second most common कौन सा है? It is pathological doubts. But a pathological doubt, for example, patient goes out of the room and he is having doubt whether I have switched off the light or not. He says, sir, I know I have switched off the light. I remember. But it's a senseless doubt, but repeating again and again. Symmetry precision का मतलब doing everything now symmetrically. Like in that case, you know, patient is having thoughts of doing things symmetrically. Aggressive का मतलब patient says, sir, I am having thoughts to, let us say, slap someone. No, sir, I don't want to do this. I am not that kind of a person. But patient को बार-बार ऐसे thoughts आ रहे हैं. Sexual का मतलब patient is having some sexual thoughts like touching the opposite gender inappropriately. No, sir, I don't want to do this. I am not that kind of a person. So patient knows these are senseless, but they are occurring again and again. Multiple means patient may have a combination of these. Remember, C say compulsion, C say most common compulsion is checking. So a patient having pathological doubt, what they may do? They may go and check it multiple times. Second is, remember, washing. Counting may be there, patient is doing everything in counts. Symmetry mein patient is now arranging everything symmetrically. Like in that case we discussed, na, patient is doing something symmetrically, taking a lot of time. So this is compulsion. Okay. And multiple means again a combination. But in your exam a very simple question was asked. Repetitive hand washing is seen and they had given an image of hand washing. So very simple, the answer was what? It was OCD. If they ask you, beta, most common pattern of OCD, if this is asked most common pattern of OCD, then the answer will be, remember, it is contamination and washing. Okay, contamination and washing. I hope it is clear. So many questions have been asked from this table, very important. Now see this. Let's talk about the management. In the management, beta, we have drugs. Now in the drugs we have two first line drugs. First line drugs, one is SSRI and another is clomipramine. What is clomipramine? It is a TCA. So which TCA is approved for OCD? Clomipramine. So these are the first line drugs. Can anybody tell me what is the drug of choice? Can you tell me, beta, what is the drug of choice here? Remember, SSRIs are the drug of choice because of less side effects. Now also remember, there is one more important point, beta. augmenting agent. So what do you mean by augmenting agent? Suppose I gave a patient SSRI, had some improvement, I want more. I added clomipramine, some more improvement, I want more. So we can also add augmenting agents like antipsychotics, especially drugs like risperidone, like aripiprazole. Okay, so they are in itself, they don't have their main effect, but they are acting as augmenting agent. So yes, antipsychotics can be used, but as augmenting agent for OCD. In therapy, we have CBT and especially ERP. Beta, what is ERP? Can you tell me what is ERP? Very good. What is ERP? Exposure and response prevention. Exposure and response prevention. So please remember this. So if they ask you both in the question, patient is having obsession of contamination and he is washing, both CBT and ERP are given in the option, but then you have to choose more specific answer, that is ERP. So we know drug of choice, we know therapy of choice. If I ask you what is the treatment of choice, can anybody tell me? Very good. Can anybody tell me treatment of choice क्या होगा बेटा? Combination of drugs and therapy. Very good. So very important topic. Now see this. What DSM-5 and ICD-11 beta they have done, they have made a category of obsessive compulsive and related disorder, and certain disorder which are similar, they have included the disorders here. One important disorder we have already discussed in this is OCD. Another is body dysmorphic disorder. But what is happening? Body dysmorphic का मतलब क्या है? Patient को बार बार thoughts आ रहे हैं कि मेरी body में appearance में कुछ abnormality है. My nose is large, my nose is small, my ears are large, ears are small. Remember in BDD, SSRIs have shown to be very good result and even CBT can be used. Hoarding disorder का मतलब patient is collecting things, newspapers, books, magazines for 10 years and not ready to throw them. He is hoarding them. इकट्ठा करना. What is trichotillomania? Beta, hair pulling disorder. Recurrent urges to pull the hair and he is pulling the hair. And lastly, remember excoriation disorder, skin picking disorder. That is now the patient is picking the skin. So these are the disorders which are included in DSM-5 under this category of obsessive compulsive and related disorder. Very good. Now see this question. This is again a PYQ. This is asked in your FMGE exam. A patient underwent surgery and a mass of hair was found in the stomach as shown in the image. So can you appreciate this? Mass of hair is taken the shape of stomach. To whom should you now refer the patient to? Very good. But what is the diagnosis? Dekho, what is this called? This is also asked previously in the exam. Simply they have asked what is this image? This is what? This is trichobezoar. Very good. This is trichobezoar. How it has reached the stomach? Because of trichophagy. Trichophagy. And why trichophagy? Because of trichotillomania. So many times, you know, patient would pull that, they will throw. Some patient may swallow them and ultimately it may land up into emergency because of obstruction. So here we will refer the patient to the psychiatrist. Very good. Now see this question. So we have covered obsessive compulsive and related disorders. Now I will discuss another important category. You will see sometimes questions being asked from this also. So we will discuss dissociative and somatoform and related disorders. See this. So now when I will talk about these disorders, so I will talk about the somatoform and related disorders के बारे में, but I will discuss somatoform and related disorders. I will also include dissociative disorders here. Now what is the important point about these somatoform and related disorders? You will see that here the patients may have some physical symptoms, some bodily symptoms. So patient will have some bodily symptoms, but there is no cause in the body. So there is no cause or no bodily cause. So patient will have some physical symptoms, but there will be no bodily cause. So somewhere in the question they will tell you that investigations are normal, examination they will tell you is normal, and they may even give you a stressor in the question, plus minus. It may be given, may not be given. So the important point to remember is that the symptoms are not produced by the body but by the mind. Sometimes the stress is too much that the mind, to reduce the stress, convert it into symptoms. Okay, so this is the important concept. Now let's see this question. A man came with bizarre presentation to the hospital. Some collateral person gave a history of recent earthquake few months back. So they have given you a stressor. The person neither remembers personal information nor why he came to the hospital which is 100 kilometers away from his home. So can you appreciate he has traveled so far? There is no history of any physical injury or substance abuse. They are trying to tell you there is no physical cause. What is the likely diagnosis? Beta यहाँ पे क्या likely diagnosis है? Yes, the answer here is it is dissociative fugue. This question was asked in FMGE and later few days later this was repeated in NEET PG. So let's discuss some dissociative disorder. देखो, amnesia we have already discussed. But what is dissociative amnesia? So amnesia हमने discuss किया था ना, could be because of organic condition. But यहाँ पे it is because of symptom produced by the mind. So here, inability to remember important personal information. Suppose person was kidnapped for 2 days, he was rescued 2 days later. He does not remember anything during these 2 days. उसको उसके पहले का पता है, उसके बाद का पता है, does not remember the traumatic memory. So ये क्या है? Dissociative amnesia. Too much stress, mind has made amnesia of that event. Fugue का मतलब होता है to wander. But what is dissociative fugue? Sudden unexpected travel away from home. Like in this case, after the earthquake, he is not able to remember the past and he has assumed a new identity. So this is dissociative fugue. What is dissociative identity disorder या multiple personality disorder? Have you seen this movie? Aparichit. If you've seen this movie, classical case of they've shown multiple personality disorder. So normally all of us have one personality, but here there are 2 or more personalities in one person. So there is one personality which is very timid and one personality is beating everyone. So this is multiple personality disorder. I hope it is clear to everyone. I hope it is clear now. That is multiple personality disorder. So here the answer is it is dissociative fugue. Now let's see this question. Now this is a topic which has been asked so many times, very small topic, but please be very careful. Don't miss out on these questions. So we are continuing with the somatoform and related disorders. A woman presents in emergency department as she develops sudden loss of vision. So can you appreciate usko sudden loss of vision? There is a physical symptom after witnessing a traumatic event, but she appears unconcerned about her blindness. Ophthalmology examination is normal and there is no organic cause beta. So somewhere they are trying to tell you कि यहाँ पे psychiatric कोई condition है. What is the likely diagnosis here? Very good. It is conversion disorder. So conversion disorder in DSM-5 has been given a new name in DSM-5, functional neurological symptom disorder. So can you appreciate patient को neurological symptoms है जो functional है. It is more common in females than males. So patient can have sensory symptoms like hemianesthesia, like blindness in this case, but the cause was not in the eyes, in the brain. No? It was, you cannot find the cause was not there. It was because of some stress. Sometimes patient may have motor symptoms like pseudo seizures. So they may give you in the history that patient is having some abnormal jerky movements, but there is no loss of consciousness, there is no tongue bite, there is no urinary incontinence. These episodes are occurring in front of others. MRI, EEG is normal. So again, they are trying to tell you it is not true seizure, it is pseudo seizures. So then think of conversion disorder. But what is labile indifference? Labile indifference का मतलब है careless attitude towards serious illness. Now can you appreciate in the question patient is not able to see, but still the person appears to be hardly concerned about her blindness. So this is labile indifference. This was also asked recently in the exams. So here the diagnosis is conversion disorder. What is somatization? What is hypochondriasis? Let's discuss that also. देखो, somatic symptom disorder or somatization का मतलब है as the name suggests that patient is preoccupied of symptoms. So patient may say I am having pain in abdomen, I am having breathlessness. So some or the other physical symptom he is having, but everything comes out to be normal. What is hypochondriasis beta? Hypochondriasis का मतलब है preoccupation with a serious illness. Patient को लगता है मुझे कोई serious बीमारी हो गई है. In fact, in DSM-5 they have given a new name, illness anxiety disorder. Anxiety of having a serious illness. Will you be able to differentiate between somatization and hypochondriasis? Everyone, better just tell me how will you differentiate? अगर question में सिर्फ symptoms हैं, it is somatization. If it is, she is worried about serious illness, then you'll think of hypochondriasis. I hope it is clear to everyone. So beta, we have covered that classification of organic and functional. Now we'll discuss some other topics. Now see this. So now let's start with the child psychiatry. Okay. See this. A 4-year-old male child is brought to the child psychiatry with complaints from the parents that the child doesn't interact much with his classmates. He prefers to sit alone and is often seen in doing some repetitive behaviors like waving his hand in front of his eyes. His speech often appears monotonous with pronoun reversal is there. Which of the following treatment modality is used? Now first tell me the diagnosis. But can you tell me the diagnosis? See the child, the age, the symptom, they are giving you hints. So what is the diagnosis here? Very good. The diagnosis is it is autism spectrum disorder. See again in DSM and ICD-11, DSM-5, ICD-11 they have now introduced this new term autism spectrum disorder. But spectrum का मतलब क्या है? Range. So there are certain disorders which are similar, so we have kept in one entity autism spectrum disorder. Please remember very important term, these are neurodevelopmental disorders. There are two core features. One is deficit in social communication. So बच्चे का child का social communication is poor, like he is not interacting in this case with others. And also there is some repetitive patterns of behavior like in this case. So these are the core features of autism spectrum disorder. So disorders in this include autism, Rett syndrome, Heller syndrome, Asperger syndrome. So these are some important disorders included here. Now these are more common in males than females, but except Rett syndrome. Rett syndrome is more common in females than males. So this is one exception. Remember, I will discuss Rett syndrome separately. So this is autism spectrum disorder. Now in the management of autism spectrum disorder, psychosocial interventions play important role. So we tried to manage the behavior using behavioral interventions such as using ABA, applied behavior analysis. So here basically we are trying to increase certain behaviors to decrease certain behaviors using techniques like reinforcement. So we target social communication behavioral skills. We try to improve them using the applied behavior analysis. Certain other interventions like parent training, social skills training, behavior therapy, CBT and educational interventions can be used. Okay, so please see this question. Here the answer is which of the following modalities used? So we are using applied behavioral analysis. We are trying to improve certain behaviors and try to decrease the behavior. I hope it is clear. You should know the answer, the diagnosis and then also the management. Now let's also talk about Rett syndrome. Again a very important topic, Rett syndrome. Remember it is more common in females than males. Now in Rett syndrome, very interestingly, now there is one known genetic risk which has been identified, that is MECP2 gene on chromosome XQ28. Now interesting thing about Rett syndrome, again first of all the two core features are present, that is deficit in social communication and repetitive patterns of behavior. In the first 5 months the child will appear absolutely normal. Abnormality will start from 6 months to 2 years. The child may have stereotypic movement known as hand wringing. So the child may have such midline repetitive movements like this. Microcephaly may be seen, even loss of speech, muscle coordination can be seen. Now tell me this is true or false. In Rett syndrome, microcephaly seen at birth. Tell me it is true or false. Very good, yes. Tell me true or false. In Rett syndrome microcephaly seen at birth. बेटा true है या false है? देखो microcephaly is not seen at birth ना, birth पे तो बच्चा is normal. So don't get into this trap. Problems will start after 5 months. So please be very careful. Also there is a drug recently approved by the FDA. At least remember the name, trofinetide. What is tide? So it's a drug which is approved for Rett syndrome. It's a tripeptide. So please remember this trofinetide. It's a drug which is approved for Rett syndrome. Let's answer this question. A 6.5-year-old boy presents with difficulty to pay attention to details, makes careless mistakes, doesn't sit at one place for long, disturbs others and is not able to wait for his turn. Which of the following drug is incorrect? Which of the following is incorrect about the drugs used for the management? But first tell me the diagnosis. First tell me the diagnosis. Very good. The diagnosis is ADHD. देखो, why it is ADHD? So what is ADHD? There is problem in attention. So does not pay attention, makes careless mistake, and he is having hyperactivity and impulsivity. Okay. So the child having inattention, hyperactivity and impulsivity. So the diagnosis here is ADHD. Please remember ADHD is more common in males than females. it is also a neurodevelopmental disorder. Okay, please remember it's also a neurodevelopmental disorder. Now coming to the management of ADHD, see this. So we know in ADHD there is inattention and hyperactivity, impulsivity seen. So we have two group of drugs. See, in the management of ADHD, beta, remember it is the drugs which is the first line treatment. So in the management, drugs are very important. So we have two categories, beta. One is CNS stimulants, which is the first line drugs, and another is non-stimulants. Please remember, CNS stimulants are contraindicated in cardiac disease. Suppose somewhere in the question they tell you that there is a family history of sudden death. So this is giving you clues that there is some cardiac risk, better don't give or don't start CNS stimulants. If you can give, then what is the drug of choice beta out of the stimulant? Remember, methylphenidate is the drug of choice. Some important side effects, remember, of methylphenidate, it can cause growth suppression. It can cause growth suppression. So the parents may complain that the weight is not increasing, the height is not increasing. So you don't have to stop the drug, you can use a technique known as drug holiday. Holiday from drug. Stop the drug in vacation, summer vacation, winter vacation, in the weekends. The growth will come back. Also remember tics. Parents saying that the child is having abnormal movements like this, vocalization like this. In fact, tics can occur even with other stimulants. So one is methylphenidate, another is amphetamine. It is not available in India in the management of ADHD, and another is modafinil. You can remember it with the mnemonic MAM, M-A-M. Very good. Remember. So we have CNS stimulants, then we have non-stimulants. But in non-stimulants, one drug is atomoxetine. It is a selective NRI drug. NRI means norepinephrine reuptake inhibitor. Okay. So one is atomoxetine. What is clonidine guanfacine? Can you tell me from your pharma knowledge? Can you tell me where do we read these drugs? These are alpha 2 agonist. Okay. Now clonidine guanfacine, can anybody tell me? These are also first line drugs for management of what? For management of tics. So tell me, if a child having ADHD developing tics will not be able to use stimulants, so we can use non-stimulants. But which non-stimulant you can prefer? You can prefer clonidine guanfacine because it will also take care of the tics. In fact, this was the question. Finally, they have started asking question from this table. This was asked in your FMGE exam. Bupropion, what is bupropion? Beta, this drug has again come back. It is a NDRI. Antidepressant used for ADHD, bupropion. So here you can remember it was MAM. Here remember MAM teaches from A to B. So A may remember one is atomoxetine, alpha 2 may remember clonidine guanfacine, and B for bupropion. I hope it is clear to everyone. Okay, so please remember this. So let's come to this. Clonidine is useful with comorbid tics, yes. Transdermal methylphenidate, it is used in children who cannot swallow the pill, yes, it is correct. Atomoxetine is a SNRI, may it is selective NRI, please remember. Amphetamine is preferred in children with cardiac risk, no, it is in fact contraindicated. Clear to everyone? Great. Now let's discuss the next question. A student having difficulty in studies, his IQ level was 55, diagnosis. But tell me, IQ means intelligent quotient. So what is the diagnosis? So we know mental retardation, the new term for mental retardation is intellectual disability, but in DSM-5. Very good. These have been asked, beta. When do we say mental retardation? When the IQ is less than 70. So mild is when the IQ is 50 to 69. Moderate is when it is 35 to 49. Severe it is when it is 20 to 34, and profound is when it is less than 20. Please remember these values, it has been asked so many times. So here the answer is it is mild mental retardation. Also, can anybody tell me most common genetic cause of mental retardation kya hai beta? What is the most common genetic cause of mental retardation? It is Down syndrome. What is Down syndrome? It is trisomy. It is trisomy 21. Second most common genetic cause is, remember, Fragile X syndrome. Suppose if they ask you, they may just twist the language of the question. Most common inherited cause of mental retardation or most common single gene cause. But if this is a single gene cause of mental retardation, then what will you say? Single gene cause of mental retardation, then you will again call it as Fragile X syndrome. Please read the question carefully and then answer. This is a very important question. Please be very careful with such questions. This is the question which was asked recently in INI-CET. High chances that such question may be again repeated in the exam, or they may repeat the topic. A 7-year-old child frequently shows anger outbursts that are disproportionate to the situation or developmental age and persist over time. His mood is irritable most of the time between the episode. Can you tell me the diagnosis? देखो, try to rule out the options बेटा. देखो ADHD तो नहीं है ना, ADHD में तो there is inattention and hyperactivity, यहाँ पे तो is having anger outburst and mood is irritable. ठीक है. Conduct disorder में the child is having violation of rights of others. He violates the rights of others, like he is beating others, he is harming the animals, destroying property. ODD, oppositional defiant disorder, but it is, you can remember, it is mild and conduct is severe. You can remember it like this. So ODD में क्या हो रहा है? The child is disobeying. He is having negativistic attitude, negativistic behavior towards the authority figure. Okay, he is disobeying. He is, arguing with his seniors, with other people around. This is ODD. Conduct disorder में तो he is, fighting, he is harming property. Such symptom may be given. Now, can you appreciate the name disruptive? So here they are telling you that there are disruptive episodes. So there are anger, temper, anger outbursts are there, and mood dysregulation, and in between the mood is irritable between these episodes. So here the answer is, it is DMDD, that is disruptive mood dysregulation disorder. So please be very careful. Try to, when you are having such question, try to rule out the option, you will get to the right answer. Now let's discuss a very important topic. Let's now start with the substance use disorder. A 45-year-old male presents with complaints of tremors, sweating, confusion, auditory hallucinations, altered sensorium, anxiety for 2 days. On taking history, the patient reports of taking alcohol for 13 years but could not take for the past 2 days due to some religious reasons. On examination, hepatomegaly seen and his LFTs are deranged, right? Can you tell me the condition and the drug of choice? Now this is the question we always discuss. देखो, alcohol is a very important topic. Usually every time they are asking some question. So yes, patient is having alcohol withdrawal symptoms. Why it is delirium tremens, can you tell me? Because patient is having altered sensorium. This is telling you that now he has developed delirium. And what is the drug you can use here? So answer is, it is option C. Beta, suppose they had mentioned diazepam, delirium tremens diazepam. Would you prefer that drug or delirium tremens lorazepam? Let's try to understand this. Dekho, alcohol, remember, it's a CNS depressant. Alcohol is a CNS depressant. A patient is taking a CNS depressant, suddenly he stopped taking. So now the brain will go in a hyperexcited state. Let's see the withdrawal symptoms. In 6 to 8 hours, patient may develop tremors, but the most common or earliest withdrawal symptom is tremors. If this withdrawal state continues, in the next 8 to 12 hours, patient may develop alcoholic hallucinosis. So patient may develop hallucinations such as auditory, even visual, tactile hallucinations can also occur. If the withdrawal state continues, he may even develop seizures. These are generalized tonic-clonic seizures. And up to 72 hours, but it may peak in 48 to 72 hours, patient may develop delirium tremens. Again, in delirium tremens also hallucinations can occur. Visual hallucination may be more than auditory hallucination. But can you tell me how will you differentiate alcoholic hallucinosis from delirium tremens? Just tell me this point, very, very important. How will you differentiate delirium tremens from alcoholic hallucinosis? Remember, we have discussed delirium tremens means impairment of consciousness. So just remember, we have talked about now ACDC. If any of these points are mentioned, then you are thinking that delirium has started. So in this case, can you appreciate altered sensorium has been mentioned, confusion has been mentioned. This is giving you hints, now it is delirium tremens. In the management, what is the drug of choice for managing alcohol withdrawal? Remember, the drug of choice is benzodiazepines. So we can use benzodiazepines like lorazepam, diazepam, oxazepam, chlordiazepoxide. Also remember, suppose if the liver is compromised, so liver okay benzodiazepine, remember, that means in liver disease also you can give these benzodiazepines, lorazepam, oxazepam. You can remember liver okay treatment, T for even temazepam. So can you appreciate in this question, they mentioned that the LFTs are deranged. So we can choose these benzodiazepine. Along with benzodiazepines, but anything extra you would like to add? Can anybody tell me you would like to add what? Along with benzodiazepine और क्या add करोगे? Remember, you can add thiamine. So we can also give thiamine. But remember, if they ask you out of benzodiazepine and thiamine, better answer will be benzodiazepine. हाँ, benzodiazepine या फिर benzodiazepine plus thiamine में, then answer will be benzodiazepine plus thiamine. I hope it is clear. So we have managed the withdrawal state. Let's now come to the maintenance. Maintenance का मतलब ऐसा नहीं होना चाहिए patient goes home and he again starts consuming alcohol. So in the maintenance, we don't want the patient to again take alcohol. So we can do, give drugs, and we can also do therapy. So in the drugs, remember, one important drug is disulfiram. This has been asked previously, but what is disulfiram? It is a aversive agent. What is the mechanism of action, beta? Can you tell me? It is aldehyde dehydrogenase inhibitor, ALDH inhibitor. Also we have two FDA approved anti-craving agents. They will decrease the craving. Can you tell me? One is naltrexone. What is the mechanism of naltrexone? It is opioid mu antagonist, and we have acamprosate. It is NMDA antagonist. Okay. So please remember this point. Very, very important. So here the answer is disulfiram, and the answer here is delirium tremens and treatment lorazepam. Let's also discuss this table. Very important. Sometimes chronic use of alcohol can also cause alcohol-induced neurocognitive disorder. So many times they have asked question from this table. So we'll discuss two important neurocognitive disorders, Wernicke's encephalopathy and Korsakoff syndrome. What is the onset of Wernicke's, beta? Acute या chronic? Remember, Wernicke's का onset होता है acute, usually sudden onset. And what are the symptoms? Remember it with the mnemonic GOA, है ना? GOA is very famous for Fanny. G से क्या है? Global confusion. Ophthalmoplegia. Patient may come to us like this. My eyes is deviated to one side. So ophthalmologic signs and symptoms we will see. Remember, 6th cranial nerve is affected more than 3rd cranial nerve. And A for ataxia. He is trying to walk and he falls. देखो, please remember, delirium tremens में भी confusion है, यहाँ पे भी confusion है. It's not big confusion. Remember, delirium tremens, they will give you a history of withdrawal state and they will give you other symptoms. Here they will not give you history of withdrawal state. They will say alcohol is taking and he has developed confusion and other symptoms like these. So then you will think of Wernicke's. Beta, what is the actual cause? Actual cause alcohol नहीं है. Actual cause क्या है? Actual cause is deficiency of vitamin B1, thiamine. So in the treatment, what will you give? You will say, sir, I will give thiamine. Are the symptoms reversed or they are irreversible? Remember, the symptoms are reversible. Now two important points I will discuss, but one point remember, whenever in such patients, so patient who has a history of alcohol, whenever you have to give glucose, always remember that you will give thiamine first, thiamine followed by glucose. So it's a very important point. Suppose patient comes in the emergency, he has hypoglycemia, you are planning to give IV glucose. Always first give thiamine, then you will give glucose. So it's a very important point. This has been asked recently in the NEET PG exam. And the second point I want you to remember, beta, suppose एक patient को symptoms थे गोवा वाले, symptoms of गोवा, you are thinking of Wernicke's, तो आपने क्या treatment दिया? You gave thiamine. But suppose in the question they tell you कि that patient shows no response with thiamine. देखो usually तो Wernicke's would respond to thiamine. So then tell me what is the next plan of treatment. See, alcohol can also decrease certain other vitamins. So it could be because of pellagra encephalopathy. Yes, so now you will give niacin. Very good. So please remember, this can come as a new question. So please be very careful. Okay. Now let's talk about Korsakoff. Remember, Korsakoff, it is having chronic onset. And if you remember, we discussed organic disorders में Korsakoff syndrome का main feature. If I ask you what feature, you will tell me. We discuss it under amnestic disorder, so you will say amnesia. Okay, which amnesia? Both can occur, but remember, anterograde more than retrograde. Also, patient may develop confabulation. Sometimes they have just asked what is confabulation. Confabulation का मतलब क्या है? Filling of memory gaps. Filling of memory gaps with false stories. And a patient is not able to remember. He comes home, Wife asks, where were you? He does not remember. He starts making, stories. I was with my friend, I went to a party, then I went to his home, now I'm here. Now please remember, he's not deliberately making these stories. He also thinks that he has done all those things. So this is confabulation. But what is the actual cause? Again, the cause remains the same, deficiency of vitamin B1 thiamine. So treatment also you will give thiamine. But some symptoms may remain. So it is partially reversible, or you can say it is irreversible. Okay. So please remember this. So very important, sometimes they just ask you alcohol induced neurocognitive disorders, they occur because of, you can say, because of deficiency of vitamin B1. So please be very careful, many questions have been asked from this topic. Let's see this question now. Match the following substance in column 1 and the drug used in the management in column 2. So tell me, alcohol withdrawal we have just discussed, na, lorazepam. Opioid intoxication, can you tell me opioid intoxication? Very, very important. Opioid intoxication mein what is the drug of choice? This is again recently asked also, so many times they have repeated this. It is naloxone. Naloxone, IV naloxone usually we give, it is opioid antagonist, short acting. Please remember this point. Nicotine dependence, tell me for nicotine dependence we can use drugs like varenicline, and for heroin is an opioid withdrawal mein what drug you can use? You can give methadone. So what is the answer? 1D, 2A, 3C, 3B and 4C. So answer is option C. Very good. So please remember this. Now let's briefly discuss this. But opioid intoxication, it's a very important topic. So patient comes to us with opioid intoxication. What is the clinical triad? One is respiratory depression. Please remember, in the eyes, what will you see in opioid intoxication? Meiosis or mydriasis? Remember, it is pinpoint pupil, but a meiosis and coma. And the drug of choice we have just discussed, it is IV naloxone. Okay, it is a opioid short acting drug. In tobacco, so in tobacco, one is we have nicotine replacement therapy like gums, lozenges, patches are there. And also remember, we have anti-craving agents. One is varenicline. But देखो नाम में nic आ रहा है ना, it is a partial agonist of alpha 4 beta 2. 4 is coming first, alpha 4 beta 2 of N, nicotine acetylcholine receptor. And one is bupropion. This question was asked. So bupropion, we know it is an NDRI. Antidepressant used for smoking cessation, bupropion. In one question previously they had asked कि patient wants to quit smoking, which drug will you give, varenicline या bupropion? बेटा तब आंसर क्या होगा? दोनों ऑप्शन है तो remember which is written first. Varenicline, remember it is the most effective. So please be very careful. They have repeated these questions again and again. Let's discuss one more question from substance. A very short but important topic. A patient presents with tachycardia, tachypnea and delusions. He reports of insects crawling under his skin and has scratch marks over the body. Which substance he is consuming? Better tell me. Very good. The right answer is, it is cocaine. So see this, cocaine is a stimulant. Cocaine is a stimulant. Even amphetamine is a stimulant. Remember we discussed amphetamine when we were talking about CNS stimulants in ADHD. So cocaine is derived from the leaves of Erythroxylum coca. देखो stimulant है ना, it will cause hypertension, tachypnea, tachycardia, like in this case, even can cause mydriasis, even seizures. Tell me, it will cause meiosis or mydriasis? देखो meiosis we discussed for opioid intoxication. Remember, cocaine, stimulants, amphetamine, they will cause mydriasis. Very, very important. So many times they have asked this, that patient comes in meiosis. So which substance it is? It is opioid. Cocaine bugs is magnum bugs or formication, and a patient has come to us with scratch marks. What is speedballs? Can anybody tell me? It's a combination of cocaine plus opioids like heroin. Cocaine is, many times people snort it through the nose. So it causes vasoconstriction, chronic use in the nose it can cause, but it can come as an image based question, nasal septal perforation. Tongue mein what finding you can get? Jet black pigmentation. Very good. It can cause nasal septal perforation, jet black pigmentation. So such image based question also they may just ask. So please remember, cocaine, a small but very important topic. So here the answer is, it is cocaine. Let's now start with some smaller topics. Let's discuss eating disorder. Again, it's a short but a topic which has been asked so many times. देखो eating disorders में first is anorexia nervosa. It is more common in females than males. Very, very important point is patient in anorexia nervosa, beta, is not eating food. Patient perceives there is a distorted image of self. Patient thinks that the body image is distorted, that they are fat or their body structure is normal, and they fear that they will gain weight. So patient is restricting food intake, and ultimately it is causing low body weight. Yeah, BMI is less than 18.5 kg per meter square. This is very, very important. To make a diagnosis of anorexia nervosa, please see in the question, have they mentioned low body weight, yeah, decrease in BMI. If that is not mentioned, it is very difficult to make the diagnosis. Now, anorexia nervosa is of two subtypes, but one more common is the restricting type, where patient is not eating much. See this, even binge eating purging type can also be seen. Binge eating का मतलब है eating large amount of food in less time. Purging मतलब doing purging like self-induced vomiting. So ये bulimia nervosa में भी मिलता है, ये यहाँ पे भी मिल सकता है. But how will you differentiate this subtype of anorexia from bulimia nervosa? See this, remember weight or BMI of anorexia nervosa is less. Now in the management, in the treatment, very good. And I hope you are able to differentiate na, by BMI, very good. But many times we see that admission may be required because maybe because of complication, like patient has complication, patient is not eating food much na, so patient may have electrolyte imbalance may be there. Okay, patient may come with dehydration. So because of so many complication, you may have to admit. Weight by height, if it is reduced by 20%, again it's an indication for admission. Now in the treatment, you know, suppose we have admitted a patient and we are giving adequate calories, but there is no increase in weight after 1 week. देखो, usually you will expect ना कि weight बढ़ना चाहिए, तो what will be your next step? Please remember this. Will you increase the calories, give antidepressant, or observe the patient 2 hours after each meal? What will be your next step? Beta, you will observe the patient 2 hours after each meal. Why? Because what if the patient is doing self-induced vomiting or purging, isn't it? Now suppose you have started treating the patient, and after feeding, patient has now developed these complications: low phosphate, low potassium, magnesium, cardiac arrhythmia, rhabdomyolysis, thiamine deficiency, seizures. What is this? So this may come as a new question. But what is this? These complications suggesting you, very good. This is suggesting you it is refeeding syndrome. Very good. If we feed the patient very fast, she may land up into refeeding syndrome. Very good. And in the treatment is CBT is the treatment of choice. We can also give drugs like SSRI. So this is anorexia nervosa. Now let's discuss this question. A 21-year-old female brought in the clinic by her mother whose symptoms are consistent with depression. She has also irresistible urge to eat followed by episodes of self-induced vomiting. Patient is also an appetite suppressant. On examination, they have also given a clinical sign in the image. What is the likely diagnosis? You have to tell me the diagnosis. But why it is not very good? It is bulimia nervosa. See, in the question they have given appetite suppressant. Still, why you are saying it is bulimia nervosa? Very good. The sign is Russell sign. Very good. Why you are saying bulimia nervosa? Because here weight or BMI is not mentioned. Please remember, it is bulimia nervosa. So please remember, in bulimia nervosa, there are episodes of binge eating large amount of food in less time, followed by compensation. But a compensation can be in the form of purging, like vomiting. Sometimes patient may use certain drugs like diuretics, you know, emetic drugs, and also sometimes other behaviors like exercise or dieting. Don't always think कि bulimia nervosa means always purging. It can also be other compensatory behavior. But remember, the weight or BMI, it is usually normal or increased. Very, very important. Now patient, if he is doing self-induced vomiting, can you appreciate HCl is repeatedly coming in the oral cavity, going out? So complications can occur like dental caries, parotitis, also Russell sign, hai na? This is Russell sign, callus on the knuckles. And you know, patient may also have decreased potassium, decreased sodium, HCl is going out, hypochloremic, metabolic alkalosis, acidosis. See, this question was asked this year. So many times you will see new questions have been asked, but the questions are framed from the topics which we have discussed. So this came as a new question this year, but remember, yes, because HCl is going out, remember metabolic alkalosis can occur. So here the answer is, it is bulimia nervosa. But can anybody tell me, here patient has depression na? which antidepressant you will avoid in this patient? देखो, I am asking one new question also. Tell me. कौन सी antidepressant? हाँ बेटा, all these complications can also occur ना, even with anorexia nervosa का कौन सा सब टाइप? binge eating purging type में भी हो सकता है. हाँ, you will avoid bupropion. Remember, very good. Now we have discussed this point. Now you will avoid bupropion. Very good. Please remember these complications very good can also occur with anorexia nervosa का binge eating purging subtype. But आप again वहाँ पे देखोगे weight या BMI क्या है. Very good. Which of the following is not true about the EEG findings? See this. So in sleep disorders, but especially revised sleep physiology, a lot of questions are being asked from the sleep physiology. Stage N2 EEG shows sleep spindles and K complexes. True or false? But it is true, isn't it? This is true. Loss of alpha waves when awake person opens eye. See, when we are awake and eyes are open, our brain shows beta waves. And when we are awake but eyes closed, what waves we see? We see alpha waves. So see this, if you are awake and you have closed your eyes, so alpha waves are right now, and suppose you open your eyes, you are still awake, so what waves are lost? Alpha waves are lost. So this is also correct. REM shows sawtooth appearance, this is also correct. Delta wave, but D for delta, remember D for deep sleep. Delta waves are seen in N3. So we have NREM and REM na? NREM is made up of N1, N2, N3, and we have REM phase. So please remember the incorrect statement is option C. Let me show you the image also. Please be very careful if they ask you images. So remember N2 में 2 findings. These are sleep spindles. Can you appreciate sudden burst of electrical activity? And K complexes. These sharp positive negative wave. These are K complex. Now interestingly, when we are in REM, we get beta and alpha waves. देखो, beta alpha waves were present where? When we were awake. And that is the paradox, that we are sleeping but brain is showing beta alpha wave. That is why REM sleep को क्या बोलते हैं? Paradoxical sleep. So beta alpha waves high frequency waves हैं like this, but इनका जो height amplitude is less. So this is what is known as sawtooth appearance. I hope it is clear. Again I am showing you these images. They may just ask these images also. So please be very careful. Now let's talk about some points about sexual disorder. One is erectile disorder and another is PME. देखो, erectile disorder में there is problem in erection. So the person is not able to obtain erection or not able to maintain erection. And PME क्या है? Premature ejaculation. Here the ejaculation is occurring early. Discharge of semen is occurring prematurely. Now in the treatment, can you tell me? So first of all, in the treatment of sexual disorder, we use dual sex therapy. The therapy which we use is dual sex therapy. Dual का मतलब है we don't treat just the patient, we include the couple in the management. So in the therapy, can anybody tell me erectile dysfunction में what is the therapy we use? Remember these names. Sensate focus technique. So sensate focus technique is used for ED, and drugs में remember we use these PDE5 inhibitors, phosphodiesterase 5 inhibitors, all these fills, sildenafil, tadalafil, vardenafil, avanafil. So these drugs we use in management of ED. In PME, very important, so many times they have asked the name of therapy. So ejaculation is occurring early. Name 2 important therapies, but remember squeeze technique and stop start technique. Both these have been asked. Please be very careful. Can you tell me which drug we can use? Which drug we can use? Remember side effect of one drug we can use. We've talked about na SSRI has a side effect of delayed ejaculation. So we are using the side effect of the drug in the management of PME. Very good. Now see this again, you will see recently questions have been asked in personality disorders. So it's a very important topic. So personality disorders may beta, you will see that symptom usually will begin during this time of late adolescence, early adulthood, and symptoms will remain usually stable through time in personality disorder. So in personality disorder you will be given a long history of symptoms. A 24-year-old female admitted in the hospital after suicidal attempt. Her behavior is unpredictable, unstable self-image is there, and reports of chronic feeling of emptiness. relationships are unstable. So everything they have mentioned in the question. So can you tell me the diagnosis here? Yes, it is borderline personality disorder. I'll discuss this separately. Let's talk about this table. See, this is a very important topic. Please revise this topic. Personality disorders are divided into 3 clusters, cluster A, B and C. In cluster A, we have 3 personality disorders, paranoid, schizoid and schizotypal. I'll tell you few points about each. Paranoid personality disorder, they are very suspicious. They don't trust people easily. See, I'm saying they have suspicious, but they don't have delusions, hallucination. They're suspicious. Schizoid may, they are socially withdrawn. They are socially withdrawn. They don't want to, mingle with others. They are usually isolated, aloof. And schizotypal, you will see they have odd thinking, odd behaviors are there. They may, be believing in telepathy, sixth sense too much. So remember the group characteristic of cluster A, they have odd eccentric behavior. One W you can remember, weird, very good. The second is cluster B. देखो cluster B की group characteristic है, they are very dramatic or emotional or erratic. One W you can remember, wild. देखो anti social का मतलब क्या है? They are violating the rights of others. Person may have criminal cases or they may be involved in a lot of illegal activities, very impulsive. Histrionic, what is histrionic? They want to be the center of attention. So they may wear clothes like this to get attention. They may talk in such a manner that they want to be the center of attention. Narcissistic personality disorder may, they have heightened sense of self-importance. They think that they are more important. So they have a heightened, increased sense of self-importance. Okay, they want people around them who just butter them. So this is cluster B. Cluster C may avoidant, as the name suggests, they will avoid new people. They are very anxious to give their opinion. Dependent may, what is dependent? They are dependent on small things. Day-to-day decision they are not able to make themselves. What should I eat today? Let me ask my friend. What should I wear today? Let me ask my mother. So small decisions, they are dependent on others. Lastly, it is obsessive compulsive personality disorder. But please see, it is not OCD. It is OCPD. Here the person wants to do everything with perfectionism. Everything he wants to do perfectly. You have to follow all the rules, regulations. So the group characteristic of cluster C, remember, is they are anxious, fearful, or remember they are worried. So I have tried to tell you all these important characteristics so that you are able to answer these questions. So it's very important, but please remember. Now let's discuss borderline. Borderline mein they have unstable interpersonal relationships. One day they'll say you are God for me, you're an angel. Second day they may say, Arey, you're the worst person I know. So they may be very impulsive. They may have recurrent suicidal behavior. Mood may be highly unstable. They may report of chronic feeling of emptiness. Remember, borderline personality disorder is more common in females than males. Now, management of all these personality disorder beta is therapy. What therapy is used for borderline? Remember, very good. DBT, dialectical behavior therapy. So please remember DBT. Is it clear? Right. Now let's see this question. Now lithium is a very important topic, but please revise lithium whenever you are revising psychiatry or pharma. It's a topic which is very important. A 25-year-old female having bipolar disorder was on lithium. You have to tell me the incorrect statement. Lithium decreases thyroid function, true or false? Tell me it is true or false. It is true. Thiazides increase lithium toxicity. It is also true, but a very important interaction. Thiazides हम कब देते हैं? In lithium induced diabetes insipidus. But thiazides, what they do? They can decrease the lithium clearance. So remember, they can cause lithium toxicity. Lithium is avoided in pregnancy due to its teratogenic effect, but it is also true. We discussed. Hemodialysis is not useful in lithium toxicity. It is a false statement. So what I will do, I will share some of these slides. I am sure all of us know these ranges. Therapeutic range of lithium is 0.5 to 1.5 milliequivalent per liter. Acute mania में it is 1 to 1.5. Maintenance में it is 0.6 to 1.2. Toxicity कब होती है lithium की बेटा? More than 1.5. See this. Anti-suicidal property. So we have discussed 3 drugs with anti-suicidal property. Can you name all these 3 drugs beta? Can anybody tell me? One is lithium, another we have discussed ketamine, esketamine, and another is clozapine. Also, can you tell me one modality which has anti-suicidal property? Remember, in patient with depression having suicidal behavior, we give ECT. So I am trying to just give you a list so that, very good, very good, I am very happy. Now, in the adverse effect of lithium, better remember it with the mnemonic lithium. Lithium can cause loss of hair, appetite, so it can cause these dermatological side effects like acne, psoriasis, rash. It also causes weight gain. Dekho, although it decreases appetite, but it causes weight gain because of other factors. It can cause weight gain. It can increase leukocytes, tremors, lithium induced tremors ho gaye beta. What is the drug of choice for lithium induced tremors? Can anybody tell me? Drug of choice is propranolol. Lithium can also cause hypothyroidism, hyperthyroidism, and even hyperparathyroidism. Increase in urine, it can cause subsequently diabetes insipidus, and the treatment is thiazide potassium sparing diuretic, and we have discussed that interaction of thiazide and lithium. And maternal may it can cause Epstein anomaly. So again, I am trying to discuss these important points. Please be very careful, revise lithium. Okay, now in the toxicity, please remember this point, our body treats lithium like sodium. हमारी बॉडी लिथियम को सोडियम की तरह ट्रीट करती है. सपोज अ पेशेंट ऑन लिथियम, ही इज हैविंग डिहाइड्रेशन, सो बॉडी विल रीअब्जॉर्ब सोडियम, इट विल ऑल्सो रीअब्जॉर्ब लिथियम, बेटा टॉक्सिसिटी हो सकती है. पेशेंट डेवलप्स वॉमिटिंग और डायरिया, body will reabsorb sodium, it will reabsorb lithium, toxicity can occur. So please be very careful if such question is given. In mild toxicity 1.5 to 2 milliequivalent, there may be GI symptom like vomiting, abdominal pain, also CNS, remember, like ataxia, nystagmus, muscle weakness. In moderate, more GI symptoms, remember CNS symptoms, sign symptom like hyperactive DTRs, patient may have convulsions, stupor, coma. In severe, in severe more than 2.5 milliequivalent per liter, generalized convulsions, oliguria, renal failure and death can occur. So one has to be very careful. So they may give you signs and symptoms of lithium toxicity. So you should identify if they are mentioned in the question. Now in the management, we will stop lithium, we will correct hydration, remove. So see this. So the first step will be to stop lithium. Very, very important. Stopping lithium is very important. Removal of unabsorbed lithium from GI tract by polyethylene glycol, sodium polystyrene sulfonate, and in severe cases we can use hemodialysis. Remember, hemodialysis यहाँ use कर सकते हैं, कहाँ नहीं use किया था हमने, TCA toxicity में. So please remember this. So answer of that question is option D, that is an incorrect statement. Now few points about Mental Health Care Act, beta, this is a very important topic. In forensic also you will read this. So Mental Health Care Act, that is MHCA 2017, it's a new act for mental illness in India. One is advance directive. देखो advance directive का मतलब क्या है बेटा? In advance we can write a directive. So all of us who are 18 and above, we can write a advance directive. That is, if in future somebody develops psychiatric illness and they're not able to take their decisions then, so they can write down in advance directive the way they wish to be treated, and also they can write down the way not to be treated for the illness. Also in this advance directive they can nominate a representative. So nominated representative, they can nominate someone who then can take treatment related decisions for them. Also remember, there is decriminalization of suicide. See, earlier if somebody had attempted suicide and he survived, then there was a case on him under IPC 309. Now this has been removed. So now the suicide is decriminalized. So it is understood that a patient who has attempted suicide must be under severe stress. So now he will not be criminalized. So please remember, you must have read in forensic, now you will read BNS, Bharatiya Nyaya Sanhita. So there is no corresponding section for this 309 because it has been now removed. Now maximum duration of admission. See, when we admit any patient with psychiatric illness, you know, especially supported admission. Supported admission का मतलब है that he is not able to take decision for himself. So nominated representative has taken the decision. In supported admission, so maximum duration of admission is 30 days. It's not that we have to discharge the patient if he still requires admission. We may continue again, but remember maximum duration is at once is 30 days. Now tell me, what is transference and counter transference? Again you will see, you know, these terms very important, many times have been asked. What is transference, beta? So in psychiatry, when we are talking to the patient, sometimes certain phenomena can develop. Sometimes patient may develop feelings towards the therapist. These may be conscious or unconscious. Conscious का मतलब he is aware, Unconscious matlab is unaware. These can be positive feelings, they can be negative feelings. So feelings of the patient towards the therapist. Counter transference kya hai? Again, these are conscious or unconscious feelings of the therapist towards the patient. They can be positive, they can be negative. So please remember these point. बेटा ECT में हम क्या करते हैं? Nowadays, I'll repeat, somebody's asked ECT, modified ECT we use. देखो, पहले हम, direct ECT was when there was no muscle relaxant or anesthesia. Now we give modified ECT. Modified ECT means that we give under general anesthesia, we give anesthesia and muscle relaxant. So we will give general anesthesia, muscle relaxant, then we put electrodes and we pass electric current. So through electric activity convulsions are produced. So this is modified ECT. Again we have discussed, like in catatonia it can be used. Modified, again ECT can be used in depression plus suicidal thoughts or acts patient is having. So again in those scenarios we can prefer ECT, because suicidal thoughts or act, it's an emergency, we can lose the patient. So in those conditions also ECT can be used. Sometimes in resistant cases of depression, other drugs are not showing any result, therapy is not showing much result, then also we can use ECT. So it has many indication. So remember, now in India we use modified ECT because direct ECT is banned under MHCA 2017. Right? Now also let's see this question. This is one important point I will discuss, and also one update also I will discuss. But this was asked recently in the exam. A girl came with a history of schizophrenia to a PHC, and which of the following is a tele-mental health program by the government of India to deliver mental health care services via phone or online application. But sometimes when you see such question, see the name Telemanas. Yes, that is, nowadays everything is getting digitalized. So we also have national tele-mental health program, Telemanas. So Telemanas is mental health assistance and networking across states. But also remember this number 14416. Okay, please remember in the end 14416. So people can also get treatment through the phone or through the online app. In fact, there are some updates. Very good. Yes, it was launched on the World Mental Health Day, 10th of October 2022 by Government of India under Ministry of Health and Family Welfare. In fact, this year in the World Mental Health Day, there are certain updates and new initiatives. Now, first of all, a mental health ambassador is designated for raising awareness about access to mental health services in India. Can you tell me, can you make a guess, any famous film celebrity has been designated? Who is that? A film actress has been designated. It is Deepika Padukone. She has been designated as the mental health ambassador. Also in the Telemanas app, there are certain new initiatives. See, multilingual, other than English and Hindi, other languages have also been included now. Accessibility feature has also been added, more user friendly for visually impaired users. So accessibility feature is added. Also a chatbot feature with the name of Asmi has been included, and also remember even emergency module has been added. So these are some new initiative of the Telemanas app in 2025. So these are very recent. So please be very careful if they ask such questions. So please be very careful. Yes, very good. Also let's answer this. Now please revise paraphilias. So many times questions on paraphilia, sexual perversions are being asked. Okay, in forensic also you will read this topic, so please revise. I have just included one question so that you are careful, you know this. A man derives sexual gratification by touching or using inanimate objects such as female shoes, undergarments. Which paraphilia it is? Very good, it is fetishism. But frotteurism na double T aa raha hai, matlab touching other person and person is getting sexual gratification. Exhibitionism, as the name suggests, exposing genitals to people or to strangers. Voyeurism mein O aa raha hai na, observing other people engaging in some sexual or intimate behavior. So please remember here the answer is yes, it is fetishism. Very good. Please remember this. Now also let's talk about some assessment tools. Can anybody tell me SCOFF criteria is used for which condition, for which disorder? Very good. It is used for eating disorder. See, confusion assessment method we have already discussed na, naam mein confusion hai. So what is the answer? It is used for which condition? It is used for delirium. So please remember. MMSE, beta what is MMSE? Mini mental state examination. See, it is not MSC. MSC तो होता है psychiatric patient के assessment को. MMSC क्या? Mini mental state examination. We do MMSE to assess cognitive function. So it is used for which condition? Condition like dementia. Very good. A score of less than 24 on MMSE is suggestive of dementia. What is PAN-SS? Positive and negative. So suppose they ask you this, positive and negative syndrome scale. If I ask you this new question, positive and negative syndrome scale is used for which condition? नाम से ही पता चला ना, positive and negative symptom बेटा कौन सी condition में? Very good, it is for schizophrenia. Cage questionnaire, audit, alcohol use disorder identification test. So these are for alcohol use disorder. HAM-D we have already discussed na, HAM-D was for depression. So please remember some of these important assessment tools. One last question. So in defense mechanism, see defense mechanism, at least just go through the defense mechanisms and try to solve questions so that you have an idea. I'll just try to help you how to remember from the name. See, Mr. M, a 30-year-old male, had an argument with his wife and he got into a fight during a cricket match and had to be restrained. But कौन सा defense mechanism है? Basically, defense mechanisms are the tools used by the mind to handle stress, and most of them are unconscious. Majority of them are unconscious. Very good. But the displacement में क्या हो रहा है? Can you appreciate he was angry on the wife and he has displaced his anger onto someone else. Intellectualization का मतलब है using intelligence to handle the stress. You told a patient that you are having grade 4 pancreatic tumor. See how the patient reacts. He asks you, sir, ma'am, what are the stages of pancreatic tumor? What is the histopathology of the tumor? What is the location of pancreas? So he is using his intelligence to handle stress. Anticipation means already your person is assessing that something bad will happen and he is anticipating it and preparing for it. A girl, she fails in the exam and while she is going home, in her mind she is thinking, what excuse will I give to mummy and papa? Altruism, gratifying service to others. So person to handle his own stress, he is doing gratifying service to others. Okay. For example, husband died in a car accident and now that lady is managing the traffic of that area without any fees. So this is altruism. So just try to see these questions and you will be able to solve many of these defense mechanisms. Okay. So these were the topics which we have covered. Again, the last, second last slide, in fact, I always share this. It is not the strongest or the most intelligent of species that survive, but the one that is most adaptable to change. Again, please remember you have, good amount of days. I told you in the beginning, the attitude will now determine your rank or your score. So, take one day at a time. Don't worry too much about that exam day. Take one day at a time. Get up in the morning, be hopeful, I'll have a good day. In the night before sleeping, no matter how the day went, be grateful. And then repeat again the next day. So please take one day at a time, and these days are very important. Anything can happen, everything is possible. If you're still thinking that I'm not in the game, you're in the game. If you play these 30 days very well. So very, very important. And again, we all love to hear from all of you. So we are waiting to listen to your success story, and we love, listening to your interviews, and all the very best to all of you. Do really well. So again, take one day at a time, take one session at a time, and always keep a smile, Don't worry about the exam, keep a smile. Smiling will not change the situation, but will change the way you're handling them, and keep moving forward. All the very best. Thank you very much. God bless you all. Thank you.